Good morning, friends. A warm welcome to all of you who have been early risers and who reached us on time. The most important discipline in surgical career, or for the matter in many medical profession or subspecialty, is rising up early in the morning. Many doctors, we definitely lose out on sleep, unlike other professions which are time bound. But that is a privilege a doctor is blessed with, and the respect a doctor endures upon. So I warmly welcome the senior faculty from across the city and out of city also. We have the honor of having a list of case discussions up till tea break, and then we move on to a little bit of lectures. So we have the most important exam cases lined up for the morning: gastric outlet obstruction, secondary SNEC, peripheral arterial disease, CA breast, like that. Can I have the Savita Medical College students who are going to present the GOO to upload the slides, please? As well, Muthukumaran Medical College, secondary SNEC PG students, Vilupuram Medical College, arterial disease students, and Venkateshwara Medical College, CA breast. Can you all upload your PowerPoints, please? So we have the Savita team here. Can you raise up your hand? Savita, please come, please. Come. Mind your step. So I have the honor of calling upon Professor Muthukumaran sir from Savita Medical College to come up to the stage, please. And good friend and guide, Professor Dakshayani ma'am, Professor Anand sir. Dakshayani ma'am is recently retired as the director in charge of the Institute of General Surgery. We have Professor Anand sir, again Professor of Surgical Gastroenterology from Kilpak Medical College. And we expect Professor UP Srinivasan sir shortly. Kana, you have loaded, ma? What are your names? So from Savita, we have Ritvik and Chaitanya coming up. So we would like to request all of you to keep time. So time, important of punctuality, is another important domain of medical practitioners, more so surgeons. So we request all of you to keep timing. Conveners, kindly note 50% of the time let us allot for history and 50% remaining things, so that little bit of surgical questions are also can be left with. We give indication that when we have 5 minutes time, like that. So things apart, can we have Ritvik and Chaitanya come up to the stage, please? Kana, Evi, PowerPoint.
Good morning to one and all present here. I'm Chaitanya, and this is my friend and colleague Ritvik. We are going to be presenting a case of gastric outlet obstruction. Both of us are from Savita Medical College under Muthukumaran sir's unit. He's on stage with us right now. And our HOD is Dr. Shruti Kamal ma'am. Sorry. So this is what we are going to be going through today. We'll start with history that I will be taking care of. Examination and diagnosis, my friend and colleague Ritvik will be taking care of. So now we're starting with our patient's history. So our patient, Mr. X, a 60-year-old male who's a farmer by occupation, and he studied from until grade 8. He hails from Kanjipuram, Tamil Nadu, and he's of the lower middle class socioeconomic status on the BG Prasad scale. He's self-informed. He comes to the OPD. Next slide, please. He comes to the OPD with chief complaints of abdominal pain for the past 4 months, loss of weight and appetite for the past 3 months, vomiting for 2 months, and ball rolling movements for the past 1 month. Now we go on to the history of present illness. The patient was apparently normal 4 months ago, after which he developed abdominal pain that was confined to the epigastric region, insidious in onset, dull aching in nature, and of the intermittent type. It was on and off for the past 4 months. It was aggravated after consuming food, and vomiting relieves the abdominal pain. It was non-radiating. Next slide, please. The history, he has a history of unintentional and significant weight loss and loss of appetite for 3 months that is associated with generalized weakness and easy fatigability. There's history of ball rolling movements for the past 1 month. It was aggravated 3 to 4 hours after consumption of food, and it reduced after an episode of vomiting. Next slide, please. He complained of vomiting that was episodic in nature for the past 2 months. The vomiting was sudden in onset, spontaneous in nature, and he did not complain of inducing the vomiting. It contained partially digested food particles, and it occurred 30 minutes to an hour following intake of food. Vomiting relieves the abdominal pain. It was non-projectile, non-bilious, and non-blood-stained in nature. There is no history of hematemesis and melena, no history of hematochezia. There's no history of dyspnea or hemoptysis. There's no history of yellowish discoloration of the urine, eyes, and skin. No history of back pain or altered bowel or bladder habits. In the past history, he has no history of previous hospitalization or blood transfusion. He's not a known case of diabetes mellitus, hypertension, epilepsy, asthma, allergies, or ischemic heart disease. No recent history of COVID-19 infection. No history of tuberculosis, previous surgery, or previous medications for peptic ulcer disease. He consumes a mixed diet. He has regular bowel and bladder habits, altered sleep habits with difficulty staying asleep. He has a history of consumption of 200 to 300 ml of ethanol every day for the past 20 years. He was also a smoker and smoked a BD pack every day for the past 20 years. So that is 20 pack years, both of which he has abstained from for 2 years. In family history, there's nothing significant. So the summary is, a 65-year-old male who's a chronic alcoholic and smoker presented with complaints of abdominal pain for 4 months, loss of weight for 3 months, vomiting for 2 months, and ball rolling movement for 1 month. This leads us to believe that the patient is suffering from a malignant pathology of the stomach. I will now be handing over the mic and dais to Ritvik, my friend and colleague. He will be taking care of the physical examination. Thank you.
Good morning, everyone. So I'll be doing the physical examination part of the case. So general examination, the patient is conscious, cooperative, and well-oriented to time, place, and person. So he's ill-built and ill-nourished, exhibits sunken eyes and slow skin pinch return. His BMI is 17.5, which is undernourished, and ECOG performance status is 1. He was pale. No signs of icterus, cyanosis, clubbing, pitting pedal edema, or generalized lymph adenopathy. Left supraclavicular, left axial lymph node, and umbilical nodules were not palpable. And his vitals, pulse rate were 90 pulse per minute, and blood pressure 100/70 mm of Hg. Respiratory rate 18 cycles per minute, and temperature is afebrile. abdomen examination. So after getting informed consent from the patient was instructed to lie down in the supine position with his hips and knees in flexion. The patient was exposed from the xiphisternum to the mid-thigh. So this is the picture. And then the inspection part. So abdomen contour, scaphoid with epigastric fullness. Umbilicus was in midline and inverted. All quadrants moved equally corresponding to respiration. Visible gastric peristalsis was seen moving from his left hypochondrium to the right hypochondrium. And no scars, sinuses, dilated veins, masses, or visible pulsation. And bilateral flanks were free. Cough impulse was negative. No fullness seen in supraclavicular fossa. External genitalia appeared normal. This is the video of the case. And you can see the VGP from the left hypochondrium to the right hypochondrium over there.
I apologize. The video takes a little while for the peristalsis to start. Please bear with us. You can see it now.
So on palpation, abdomen was soft, no warmth and tenderness were present, no mass were palpable, epigastric fullness was palpated, consistent with distended stomach. On head raising, it became less prominent, no organomegaly, no umbilical nodule was palpable, no masses palpable in left supraclavicular fossa and axillary region. On percussion, dull percussive note of liver felt in the right fifth intercostal space in the mid-clavicular line. Liver span was 12 centimeter. Percussion over fullness was resonant. Renal angle was resonant on percussion. No free fluid or shifting dullness. On auscultation, bowel sounds were heard and was normal. Ausculto percussion, stomach border distended beyond the umbilicus, and succusion splash test. Splashing sounds were heard few hours postprandial. So other system examination. So cardiovascular system, S1 and S2 were heard without murmurs. Respiratory system, normal vesicular breath sounds with no added sounds. And central nervous system, no focal neurological deficits. Perirectal examination, sphincter tone was normal. Fecal staining was present. No masses felt in the pouch of Douglas. So diagnosis is a case of gastric outlet obstruction due to distal carcinoma of the stomach. Thank you.
Thank you.
First presenter.
Yes, sir. Yes, ma'am.
First presenter. From history, how did you conclude it's malignancy of the stomach?
The patient was ill-nourished and ill-built. And the patient, oh, sorry, you said from history, right, ma'am? Sorry.
From
From-
history.
Okay. From history, it was acute in onset, ma'am, from weeks to months. Because of that, it could be malignant. And he is also an elderly male. He's a 60-year-old male, which is more indicative of a malignancy. And he also is a smoker and alcoholic, which also increases the likelihood of it being a malignancy. Lower socioeconomic status as well. So that increases the risk of an H. pylori infection, which could ultimately, in rare cases, lead to it could lead to a malignancy. It's not very rare.
What are the other causes, the precursors for CS stomach?
Atrophy.
In history.
Sorry, ma'am.
What are the other precursors or predisposing causes for malignancy of stomach? You will elicit in history. Other than smoking, alcohol.
History of polyps, history of familial history of malignancies, then polyps, then
How will you ask for polyp history?
If they've been admitted before for hospitalization, or if they've had similar complaints in the past, and if they've had a previous gastric surgery also, that is increased likelihood of stomach carcinoma. And
Any other causes?
Ma'am, pernicious anemia, ma'am, vitamin B12 deficiency, Plummer-Wilson syndrome, and then taking any preserved foods, salted foods, and
smoked meats.
blood group A, they are exposed to, and then gastric ulcer, which is common,
Epigastric pain also can
and
tell in history.
HNPCC, ma'am.
But the patient will not know HNPCC. So if there's history of colorectal carcinoma, we can ask in family.
What will be the type of vomiters in a case of CS stomach?
Depending on where the lesion is or the pathology is in the stomach, we can tell, ma'am. For our case, because it's a distal pathology, the vomiters will be it could be blood stained, then it will have food particles that are partially digested, and he can complain of hematemesis as well. The bleed is very big, and proximal CA stomach, we can the vomiting will be immediately after taking food, and it will not be digested, and there will be bleeds as well. And the most specific thing with our cases, it will be non-bilious, because there's an obstruction that prevents food entry into the duodenum.
You elicited a history of vomiting. The other point is you have to ask for a self-induced vomiting. Generally, you know, that did you elicit? Did you elicit?
We asked,
sir.
sir.
Self-induced, because you know that will relieve their symptom. So they will not reveal it. It should be a leading question from us. So that is one. But I'm asking, VGP is common in a benign disease or in a malignant scenario?
Malignant disease.
Sir, it is also seen in benign. If there is any
Whenever there is an obstruction,
yes,
it will get a
if there's
VGP.
any pyloric strictures or something, we can see the VGP, sir.
It's, going by the history and physical examination, there is no lump, only distended stomach is seen. Probably we can take it as a distal malignancy in the antropyloric region, which is causing this VGP. Can it still be a benign disease? As a differential diagnosis, can you offer?
Cicatrized duodenal ulcer.
Yeah. Can it still? I'm just asking. Can it still be a benign disease?
Yes, sir. They can be, sir.
Because clinically there is no lump felt. It is only a distended stomach because of obstruction you have seen, and there is a vomiting, non-bilious, and peripherally also there is no nodes or liver mets, no ascites. Bloomer's shelf is negative, so everything is negative. Only by the short duration, elderly man, we suspect. Can it still occur in the same age group, a benign disease with ulcer cicatrization? Or it is totally not?
Why is he
Consider.
repeatedly asking whether it could be benign? What is the difference in a gastric outlet obstruction due to benign and gastric outlet obstruction due to cancerous lesion? The distal stomach. The distensibility of the stomach will be lost mostly in CA stomach. So to elicit the gastric VGP in a CA stomach is little uncommon comparing to benign lesions. Okay.
Mostly malignancy will be infiltrative. So it is not confined to one region. Because of the infiltration, distensibility is lost. So VGP is not prominent most usually in malignancy. Whereas in benign lesion, which is confined to that part, the stomach is hugely distended, VGP is obvious. That is why Sir is repeatedly asking, VGP is in favor of benign condition or malignant condition. VGP is mostly in favor of benign condition in the absence of mass. In the presence of mass, it is 100% malignant. In this patient, age is in favor of malignancy, but mass is there. So we have to rule out the second possibility.
How will you proceed now with this?
We proceed with, we admit the patient and then we proceed with investigations. We can start with the complete hemogram. We do CVC. Then we can do an LFT is very important to rule out secondaries in case there are secondaries. You can do RFT. Then you do serum electrolytes, which is important. And you do a weekly serum creatinine, then your blood urea nitrogen. Then we do blood glucose as well. We do those investigations. And then we proceed with, we can do an ultrasound
Endoscopy.
and we can do an endoscopy. We can also,
Ultrasound more important or endoscopy more important?
endoscopy is,
Endoscopy will do. First, we'll do endoscopy, sir. So endoscopy will first make the patient nil per overall, and then we'll introduce the Rales tube, and we aspirate all the contents which is inside, and then we look for the
we do
site
a
of the lesion,
gastric lavage after.
gastric lavage with normal saline, and we look for the size and site of the lesion, and it is also used to take biopsies, sir.
And if we see can cauterize self to help the patient a little more, because he'll also, so he's anemia also. Then after that, we can proceed with a USG, and during self, we can do an ultrasound endoscopically to assess the depth of the lesion. Then after that, we will do
In the endoscopy, what are all the things you will see as an endoscopy?
What will be the picture of electrolytes in this case? What do you expect in this case?
so,
Hypochlorine.
metabolic hypochloremic alkalosis with paradoxical aciduria.
Aciduria.
What is gastric tetany?
Sorry, sir.
What is gastric tetany? Have you heard of this? Gastric tetany.
Mhm.
Okay, go read and come. Gastric tetany.
Okay.
Okay, what will you see in endoscopy? You said endoscopy. When the scope is passed, what are all the things you will see and what you will do?
We will see the mucosa of the stomach, sir. So we'll go through the esophagus. We'll make sure there is no Barrett's esophagus also.
Have you seen an endoscopy being done?
Yes.
Yes, sir.
You have seen.
Yes, sir.
Then you can answer.
Okay.
See, now in the endoscopy, what you see is that the lesion.
We see the
Yeah,
whether the
because it
lesion is polyploidal or ulcerative.
Yes, correct.
Then
You see the morphology. You
Hmm.
said a suspected malignancy, you see the morphology of the lesion and you take a biopsy. How many biopsies you will take?
4 to 6.
4 to 6 biopsy, you gives more sensitivity. Suppose what else you want to, then it comes as biopsy comes as malignancy,
Yeah.
adenocarcinoma of the stomach. What is the next you will do?
We'll do a CTT,
USG.
CET, and we'll do contrast. So it's contrast
Why
enhanced.
do you want to do a CT scan?
CT scan is to
Look for secondary, sir.
No, the correct
cut-
answer is you staging. I want to stage the disease, sir.
staging the
You
disease.
don't have to keep explaining. You say the CT, now you have proved it as malignancy by endoscopy. Now you do a CT for staging of the lesion.
TNM.
Yeah.
TNM staging we
Yes,
will do.
TNM staging, yes.
So,
That is it.
Assess the operability and then.
ma'am, sorry, ma'am.
Assess the operability.
Operability.
What are the
will-
criteria for operability?
Uh, the
If
the
the
lesion is limited to the stomach and there are no adjacent secondaries in the infiltration of the adjacent structures. Then if there are no distant metastasis, like if there's a Virchow's node or or an Irish node, or if there's or if there's a sister Mary Joseph nodule, and then if there's malignant ascites as well, that can be, and then if there are any neurological deficits, that reduces the operability of the lesion. That the therapeutic operability of the lesion will be reduced. Can do palliative operation to increase the patient's quality.
What will you do? Suppose CT shows no metastasis. The tumor is within the confines of the antropyloric region, pancreas infiltration, liver, nothing is there. And the D1 is also not involved, antropyloric region. What will be the plan of surgery for this patient?
We'll confirm with the diagnostic laparoscopy
Very good. Yes.
because
So
CT
never for all of you, don't forget about diagnostic laparoscopy. It comes in the armamentarium of staging. Okay, so don't forget.
will do a
Diagnostic laparoscopy now is not to confirm the diagnosis. Already diagnosis is confirmed by your endoscopic biopsy. Diagnostic laparoscopy is to, what is the purpose of diagnostic laparoscopy?
because CT scan can only pick up lesions that are more than 5 millimeters in size. You do a diagnostic laparoscopy to pick up any secondaries that could be less than 5 millimeters in size.
The
So-
surface of the liver and in the peritoneum and omental deposits, which
Yes,
will
sir.
be missed by the CT scan.
That is the reason for diagnostic laparoscopy. Now to make the diagnosis of CS stomach. So to rule out anything that is less than 5 mm. The less than 5 mm deposits, it becomes inoperable. Unnecessary laparotomy can be avoided by diagnostic laparoscopy prior to surgery.
So what will you do? What is the procedure you will do for you?
We'll do a distal radical gastrectomy and we reconstruct with the Billroth 2. And you do D2 dissection as well.
Yes, D2 lymphadenectomy with distal radical gastrectomy and a Billroth 2 anastomosis. Very good. And in the workup of this patient, do you take any precautions? Because you said he is a BD smoker also.
Yes.
What is the preoperative evaluation to make him fit for the surgery? Any special test you will do? Will be the last question.
Pulmonary function test.
Very good, yes. Don't ever forget the pulmonary function test because elderly man, BD smoker, PFT is more important. Okay. Yes.
You do about the curative resection?
Yes, ma'am.
To a certain extent, yes.
Anterior.
Curative
For CS stomach.
Already you told, just to repeat it.
we do for curative we do subtotal radical
with D2?
gastrectomy with D2
What do you mean
dissection.
by it? What do you mean by D2 resection?
Level 1 and level 2.
What are the level 1, level 2 notes?
Level 1, it is along
Associated with the stomach
stomach, ma'am.
directly anatomically. So it will be the
Will be along the course of
Perigastric nodes.
perigastric nodes,
Perigastric.
along the course of vessels.
that is level 2,
Level 2,
ma'am.
ma'am. That is along the arteries.
Arteries.
Arteries of the stomach.
We'll remove at least 15 lymph nodes.
Suppose inoperable. It shows liver metastasis. What will you do for this patient?
We'll go for
What is-
palliative.
What is the patient's main complaint?
Complaint is abdominal pain, vomiting.
Vomiting. How will you palliate?
Palliatively, we can do
Anterior jejunostomy, sir.
anterior
Just-
gastrojejunostomy, but as a minimal procedure, we can do laser cannulation or we can introduce a stent. Can try that. Or if the prognosis or if that also fails, we can do a feeding jejunostomy.
Role of chemotherapy in CS stomach?
It's an adjuvant therapy,
Adjuvant.
Curative lesion can be adjuvant.
curative.
Suppose the patient has a melena and vomiting of hematemesis or melena. It is negative, but if suppose there is what will be with metastasis, what will you do? And you work up. There is mets also, but there is a bleeding lesion. What will you do?
We cauterize the bleed endoscopically.
Is it possible? But suppose the lesion is operable. You see that it's an operable lesion. What will you do?
We can do resection then itself.
Can do a palliative resection. So palliative because it's a bleeding lesion. So you can do a palliative resection if the ECOG status is good. Yes.
So, listen, whenever a long case is discussed, we are always worried about differential diagnosis. Here, GOO, they made a diagnosis of CS stomach. We are always worried about other conditions that can cause CS, the GOO. Cicatrized duodenal ulcer common, rarely cicatrized gastric ulcer. Other uncommon causes of GOO. Differential diagnosis is important. Luckily, this patient is not having any epigastric mass. Suppose if there is epigastric mass, you will be making a diagnosis of CS stomach. In that case, you have to think about differential diagnosis. Epigastric mass can be from the colon, from liver, from spleen, from pancreas. In that case, your examination findings will be We have to mention so many things. You have to mention site size, shape, movement, falling forward, whether it is intra-abdominal or retrocranial, so many things. Then investigation also, you have to rule out the second possibility, third possibility. So differential diagnosis, you keep it in mind whenever you discuss long case. You cannot confine yourself to only one diagnosis.
Thank you.
Thank you, ma'am.
Thank you.
Thank you, sir. So I request Dachani madam to give the certificate to the students. Well presented. I request Kannan sir give the certificate. Give the certificate, Kannan sir, to all the faculty, chairpersons.
Can we have Muthukumaran Medical College team here? Please come. Have you loaded your PPT, Kanna? Yeah, please come. Anand?
நேத்து விட்டுட்டீங்களா?
Muthukumaran Medical College team, have you loaded, Kanna? Okay, to the stage. Sai Darshini and Murli Karthik, can we have give a big round of applause? Cheer up. You get it. So we request Dr. Sasi Kumar from Sri Balaji Medical College to be the convener. Professor Karthikeyan sir, Umarani ma'am, Vijayalakshmi ma'am. So this will be a case of secondaries of the neck. So we have 15 minutes time. So I request the examiners to handle the salient positive history, relevant findings, and take more time for the discussion. I humbly request you. I request the Vilpura Medical College team to load their presentation, please. All the clinical case presenters, please load your PPT here. So it will be for 15 minutes. You can start.
Good morning, everyone. I'm Sai Darshini, and this is my colleague Murli Karthik. We are final year students from Sri Muthukumaran Medical College under the tutelage of Dr. Vijayan sir and Dr. Ramanujan sir. We are going to present a case of secondaries of neck. I will be presenting the clinical history, and my colleague will take over the examination and diagnosis. We thank you all for this wonderful opportunity. So our patient is a 65-year-old male from Mangadu belonging to a lower socioeconomic class. Yes, sir. So he presented with chief complaints of swelling in his right upper aspect of neck for the past 1.5 years and difficulty in swallowing for the past 2 months. Over the past 1 week, he developed pain over the area of swelling. The patient was apparently normal 1.5 years ago when he noticed a small swelling of about 1 centimeter in size in his neck. It was insidious in onset, and initially it was gradually progressive, but over the past 5 months, it was rapidly progressing in size. There are no aggravating or relieving factors associated with the swelling. However, he developed pain over the past 1 week, which was an intermittent vague pain without any aggravating or relieving factors. The patient also complained of difficulty swallowing for the past 2 months, which was again insidious in onset and gradually progressive in nature. It was more towards solids than liquids and was associated with loss of appetite. Loss of weight of about 8 kgs was noted over the past 6 months. Other than this, the patient did not have any history of ulcer over the swelling, discharge from the swelling, hoarseness of voice, hemoptysis, cough, ear pain or diminished hearing, fever with evening rise in temperature, chills or rigor or associated drooping of eyelids. The past history is not significant of any similar complaints, no known comorbidities or surgical history. There is no relevant family history also. The patient is a chronic smoker. For the past 15 years, he has been smoking one pack of cigarettes a day, which brings his pack years to 15 and smoking index to 300. He is not an alcoholic. He consumes a mixed diet. And apart from his recent loss of appetite, his sleep pattern, bladder and bowel movements were normal. So Murli Karthik will be taking over for the examination. Thank you.
Hello, I will be proceeding with the examination of this case. So coming to the general examination, this patient is conscious, cooperative, oriented to time, place, and person. He is moderately built and poorly nourished. There are no signs of pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema. The vitals were as follows. The temperature was recorded as 98.6 degree Fahrenheit. Pulse rate was 84 beats per minute. Blood pressure is 22/84 mmHg, and respiratory rate is 16 cycles per minute. There are no signs of Horner syndrome in this patient. Patient is able to shrug his shoulders, and there are no tongue deviation or tongue atrophy. So after getting an informed oral consent, the patient is examined in a sitting position. On inspection, a single oval swelling noticed in the right side of the upper part of the neck. It measures approximately 7 × 5 centimeter. It extends superiorly 1 centimeter below the angle of mandible, inferiorly 2 centimeter above the right sternoclavicular joint, and medially 2 centimeter away from midline, and laterally 2 centimeter posterior to the anterior border of sternocleidomastoid. The surface appears to be nodular. The borders appears to be well defined. The skin over the swelling is normal. There are no visible pulsation, and no other swellings were noticed in the neck. So on palpation, there is no warmth, but there is some minimal tenderness, and the inspectory findings were confirmed. Like it is confirmed to be a single oval swelling in the right side of the upper part of neck, measuring 7 × 5 centimeter. It extends 1 centimeter below the angle of mandible to 2 centimeter above right sternoclavicular joint, medially 2 centimeter away from midline, and laterally 2 centimeter posterior to the anterior border of sternocleidomastoid. The surface is confirmed to be nodular. The borders were confirmed to be well defined. The skin over the swelling is normal. The consistency is found to be firm, and the skin over the swelling is pinchable. It is a non-mobile swelling situated deep to the sternocleidomastoid muscle. The right carotid pulse is felt and found to be displaced laterally by 2 centimeter. There are no other swellings palpable elsewhere in the neck. The opposite neck is normal. Left supraclavicular and bilateral axilla were free. On oral cavity examination, the jaw opening was found to be adequate. It permits 3 fingers. Dental caries were present. There were no halitosis. The lips, buccal mucosa, tongue, flora of mouth, retromolar trigone, and palate were normal. And nasal cavity was normal. Thyroid is not palpable. In other systems, in cardiovascular system, the S1 and S2 is heard. No murmurs were heard. RS, normal vesicular breath sounds were heard. There are no added sound. Abdomen is found to be soft, non-tender. So no organomegaly and no free fluid. And in CNS, there are no focal neurological deficit. So summary, this is a case of Mr. Raja, a 65-year-old man. He presented with a neck swelling for 1.5 years, associated with pain for 1 week and dysphagia for 2 months. His clinical history is significant for rapid progression of swelling and undue weight loss of 8 kg over the past 6 months. He is a chronic smoker with a pack years of 15 and a smoking index of 300. On examination, a single oval, firm, non-mobile swelling measuring 7 × 5 centimeter in the right upper aspect of the neck is made out. So my probable diagnosis is a metastatic tumor involving level 2 and level 3 cervical lymph node with a stage N3.
What do you expect that primary focus?
Since here it is level 2 and level 3 is involved, so I expect the primary to be in the oral cavity or in the oropharynx or nasopharynx.
Dysphagia. The
Yeah,
patient
and there
has
is also dysphagia, so it possibly it will be in the pharynx. Esophagus is less likely because esophagus involved means it would be a level 4 involvement. Supraclavicular would have been involved.
You said it is nodular and a single node also.
Yes.
How can a single node be nodular? Always have these basic facts.
Okay.
It's nodular means multiple nodes have joined together. You have a nodular surface. Not necessarily lymph nodes will have a nodular surface. It's not like that.
Okay.
It's a single node or a multiple node. Okay. You want to give a differential diagnosis, go on with a single diagnosis of, you don't have any primary on clinical examination. You have to be dogmatic about secondary nodes, or you want to have a differential diagnosis also.
I will consider differential diagnosis like a cervical lymphadenopathy.
If you think it's nodular means it's multiple nodes
Yes,
together,
sir.
then we'll have a differential diagnosis. If you are sure about single node, then we will think about something else.
I think it's a single node.
Single node. Okay. And single node can be any one level only. It cannot be 2 levels or
Okay.
anything. If you have multiple levels, it is there. Then if you see it's upper deep cervical nodes as a level 2 or you are thinking about, so what will you do to confirm your diagnosis?
First, you have to do an ultrasound neck to make sure whether it is a lymph node or any other vascular structure present, and then you will proceed with the FNAC to confirm confirm it as a metastatic lymph node. And based on the FNAC result, the further investigation will be done. Like if the FNAC comes out to be a squamous cell carcinoma, then the primary is more likely to be in the head and neck region. So I'll take a CT of head and neck and do an endoscopy, like pan endoscopy would be done to find out the primary.
When you have the primary rule is when you have a thinking of secondaries, always search for primary before touching the secondary.
Yes.
So FNAC would not be the first choice. If you have a dysphagia symptom, everything like that, you have to go and look for, if you are thinking about secondaries, then look for pan endoscopy. Do a nasal endoscopy, oral endoscopy, and bronchoscopy if needed. So upper arrow digestive tract, that's what we are looking at. Upper arrow digestive tract, above the vocal cords is squamous epithelium lining only, and above the esophago gastric junction, just lower up to middle third, it's only a squamous lining only. So wherever it could be malignancy, it can reach there. So you have to do these areas you have looked at, then you touch the secondaries. You don't go and touch the secondary straight away. Once you see the primary, look for primary. If no primary there, then you go for the FNAC.
Okay.
That's what else you want to do. When you are investigating a node, don't go just with thinking of secondaries alone. You have tuberculosis in our country, can present anywhere like that. So always have the diagnosis whenever you are dealing with a node. Remember, tuberculosis and lymphomas can also coexist all the time. But you repeatedly said dysphagia, so it needs investigation.
Okay.
So where all will you find the level 2 and level 3 nodes? Where all you will go and investigate or look for the primary? You want to say this is a secondary node?
Yes, sir.
Yes.
Since it's a level 2 involved, so I look in the oral cavity. I'll look in a nasopharynx, the whole of the pharynx I will be looking for. And also salivary gland can also be a concern.
You said something about dysphagia.
So because there's dysphagia, it is more in the pharynx. I would say in the
Would mostly be in the pharynx, ma'am, and we would look into valvular and in the tonsillar bed that could cause impingement and dysphagia.
So you want to say the hypopharynx may be involved.
Yes, ma'am.
So what else will you do for as a next line of investigation? Sir has told you so many investigations. Next, what do you want to do?
next we can take blind biopsies from the hidden sites. Like in the fossa of Rosenmuller, tonsillar bed, vallicula, pyriform fossa, retromolar trigone.
So the places will be around the pharynx.
Yes, ma'am.
Yes. You and the posterior 1/3 of the
First.
chart you want. Next, what will you do?
You get it as secondary lymph nodes, squamous cell carcinoma. It has come as FNAC, and you can't find any primary. How are you going to proceed further?
Then we can first treat the secondary and we have to follow up with chemo radiation, and then we have to follow up the patient like every 3 months. So
Any other investigations from the node we will do? So FNAC you have done, it is squamous cell carcinoma.
yes,
Any other investigations? Because you are saying level 2, 3, and you are worrying about oropharynx and nasopharynx. The biopsy. Any viruses? Oropharynx, what virus is more common? Nasopharynx, what virus is more common? If you are suspecting oropharynx, you can go ahead for going to say something? Yeah, human papilloma virus DNA. HPV, you can examine, and if it is positive, the disease is from the oropharynx. Epstein-Barr virus is positive,
nasopharyngeal
it is from the nasopharynx. So what is level 2, 3? Any boundaries for level 2?
I can get
What are the boundaries of level 2?
level 2. It is superiorly it's the base of the skull, and inferiorly up to the hyoid bone. Laterally it goes from the sternohyoid to posterior border of sternocleidomastoid.
If it is nasopharynx, what is the classical presentation, clinical presentation?
But from these signs, there could be a ear pain and ear discharge can be there, and nasal congestion, and there could be a sinusitis also, ma'am, recurrent sinusitis.
What is the triad? It's classically diagnosed of that.
Protest triad.
What is it?
Protest, it's conductive hair loss, then mandibular neuralgia and palatal asymmetry.
If you have suspected nasopharyngeal carcinoma, what are the important oral examinations you have to do that? Apart from routine, growth and all, what are the important things? How much is extent of nasopharynx? Up to the, I give a clue, up to the base of the skull. What are the important oral examinations you have to do apart from ulcer and all? Any nerve, any cranial nerve you can examine by oral cavity examinations. Any reflex? What's CAG reflex? 9th and 10th cranial nerve, how will you examine that? If nasopharyngeal, it is up to the base, it is infiltration of the nerve, the reflex. And then soft palate will be paralyzed on that unilateral. It's a classical sign. It will be apart from routine. If you are suspected nasopharyngeal, this should be examined.
Yes.
Okay. Yes. And after confirmations, what is your case? You can proceed. Only manage.
Since this node is inoperable because it is fixed to the deep structures, so we can't directly go to surgery. So you have to go for chemo radiation, and then you have to follow up the patient with CT. Once if there are residual nodes, we can take the patient for a neck dissection.
What type of neck dissections you want to do?
In this case, since as my colleague said, since the nodes are inoperable, they are stuck up lymph nodes, we will stick with chemoradiation. And after the chemoradiation, if the lymph nodes become operable, then we'll go for a selective neck dissection, ma'am. And otherwise, primarily in this case, the treatment plan would be based on chemoradiation only, ma'am.
What about the primary for these cases? If you suspect some growth in the larynx with this type of nodes, what is the management?
What is the type of growth histopathologically do you expect if it is in the larynx?
Could be an intrinsic growth, ma'am.
What is it? Whether it is adenocarcinoma or a squamous cell carcinoma or what?
It would most commonly be a squamous cell carcinoma.
Yes. So what is the next line of management you offer initially for a CA larynx?
It would also primarily be a chemoradiation modality.
Chemoradiation or radiation? Why chemo radiation?
Because the chemotherapy would enhance the sensitivity of the tissue to the radiotherapy, ma'am. So, doing a round of chemotherapy before radiation is shown to be more effective.
So you want to say that it is a sensitizer to the radiation. In a case of pure squamous cell carcinoma in a CA larynx, it is mainly the radiotherapy which is needed. If it is going to be a mixed type or anything to do with the adenocarcinoma mixed or pure adenocarcinoma, then you shift your treatment to the chemotherapy, and then whatever is needed, depending upon whether it is stuck up or whether it is resectable, you go in for R&D or MR&D or whatever. Then you can do that.
Only one correction I will do. You cannot do a selective neck dissection in this patient. Okay, selective neck dissection is for N0 patients. N0 means when there is no nodes, we will be doing the selective neck dissection. This much big node, you cannot do a selective neck dissection. So here you have to go for a radical neck dissection or modified radical neck dissection only.
Thank you, sir.
So another indication for that will be your aggressiveness and the differentiation of the tumor to go in for a selective neck dissection. Okay, only if it is going to, even for functional, well differentiated and less aggressive tumors alone can go in that way for a functional or a selective neck dissection. Otherwise, it is the R&D.
Okay, ma'am.
Thank you. Thank you very much. All the chairperson be seated for a short question is 15 minutes only. Please sit down. Candidate. Candidate.
Thank you, sir.
The next topic is cervical lymphadenopathy. Please, students, be seated, madam. Vijay, madam. Hey, போட்டல கொடுத்துட்டான் அதுக்கு முன்னாடி கொடுத்துட்டான். Hello.
Good morning. I'll be presenting a case of cervical lymphadenopathy. A 47-year-old woman, Mrs. Muller, coming from Kallakurichi, presented to the general surgery OPD with complaints of swellings in the neck present on both the left and right side of the neck for the past 3 months. History of presenting illness. History of swelling, initially on the left side and then right side of the lower part of the neck, both for the past 3 months, both insidious in onset, initially small in size and progress to attain their current size. There's also a history of fever for the past 3 months, which was resolved 1 week back, an intermittent low-grade fever associated with evening rise in temperature. There's a history of loss of weight and appetite for the past 3 months, and a history of cough for 1 week, which is insidious in onset, dry cough, no aggravating or relieving factors. There is no history of pain over the swelling, no history of dyspnea, no history of cough with hemoptysis, no history of difficulty in swallowing, hoarseness of voice, jaundice, hematemesis, melena, or altered bowel habits. There's no history of ear pain, ear discharge, or deafness. There's no history of nasal bleeds, oral ulcers, difficulty in chewing, difficulty in opening the mouth, dental caries, trauma, or any other swellings elsewhere in the body. Past history. No history of similar complaints in the past. She is not a known case of diabetes mellitus, hypertension, asthma, epilepsy, TB, or ischemic heart disease, and there is no history of any previous surgeries. Personal history, she consumes a mixed diet. She has normal bowel and bladder habits. She has a normal sleep pattern, and she is a tobacco chewer for the past 30 years. She chews daily with 4 to 5 times a day. Family history, there are no similar complaints in the family, and treatment history, she is not undergoing any treatment or on any regular medication. And now moving on to general examination. The patient is conscious, oriented to time, place, and person. She is moderately built but poorly nourished. Pallor is present. There is no icterus, no clubbing, no cyanosis. There is no pedal edema, but there is significant lymphadenopathy present. Vitals, the vitals are normal. Local examination. On inspection of the neck, attaining consent of the patient, and the examination is conducted in a well-lit room. On inspecting the neck on the left side, a swelling is seen in the in the left supraclavicular fossa, which is approximately 4 × 3 centimeters inside, ovoid in shape. Its extent, its upper border is 6 centimeters from the thyroid cartilage measured diagonally. Lower border is above the clavicle. Its medial border is 4 centimeters from the sternal notch, and its lateral border is 1 centimeter lateral to the lateral border of the left sternocleidomastoid. Its surface appears smooth, and skin over the swelling is normal, and its margin is well defined. This is a picture of the swelling. On the right side, there is a swelling in the right supraclavicular fossa, approximately 3 × 2 centimeters in size and ovoid in shape. Its extent, again, its upper border is 6 centimeters from the thyroid cartilage measured diagonally. Lower border is 1 centimeter above the clavicle. It is medial to the, it is 4 centimeters from the sternal notch, and its lateral border is lateral to the lateral border of right sternocleidomastoid. Like the previous swelling, it is smooth surface, and skin over the swelling is normal, and its margin is well defined. This is a picture of the swelling on the right side. And this is a picture of the both the swellings with the neck extended, and a picture of both the swellings with the neck flexed. On palpation, inspectory findings are confirmed. There's no warmth or tenderness. The swelling is firm. The swelling on the left side is firm to hard in consistency with well-defined surface, and it has a smooth surface, well-defined margin and a smooth surface. Its mobility is restricted, and skin over the swelling is pinchable. The plane of the swelling is deep to the deep fascia. And then on palpation of the left side, a second swelling was found, which is not warm or tender. The swelling was of size 2 × 2 centimeters, felt on the medial side of the left sternocleidomastoid at the level of the thyroid cartilage. It is ovoid in shape, smooth surface, soft in consistency with well-defined margin. This swelling is freely mobile, and skin over the swelling is pinchable. The plane of the swelling is deep to the deep fascia. Though it's not visible, the swelling is in this area. Right side, no warmth or tenderness. Again, the inspectory findings are confirmed. The swelling is 3 × 2 centimeters in size, with a smooth surface, firm to hard in consistency, with well-defined margin. It has a restricted mobility, and the skin over the swelling is pinchable. Plane of the swelling is deep to the deep fascia, and carotid pulsation is checked on both sides, and it is present and normal. Examination of the lymph nodes. The pre-auricular, post-auricular, and occipital nodes are not felt. The epitrochlear nodes are not felt. The cervical nodes on the right side are normal, and the axillary area and inguinal area are normal. Examination of the mouth and oral cavity. Oral hygiene is poor with nicotine staining seen on the teeth. There is no halitosis. The lips, gingiva, buccal sulcus, buccal mucosa, gums, tongue, floor of mouth are all normal. The posterior pharyngeal wall and the anterior tonsillar pillar and tonsils are normal. There is no difficulty in opening of mouth. Bidigital palpation shows no stricture or stones felt, and there is no discharge from stents and stuff. Ear, nose, and scalp are normal, with the ear having no discharge or perforation or polyp, the nose having no discharge, polyp, or nasal deviation, and the scalp having no ulcers or any other swelling. Breast and thyroid examination is also performed with no lumps and nipple areolar complex being normal and the thyroid not being palpable. Other systemic examinations, the abdomen is soft, non-tender, no organomegaly. The respiratory system, bilateral air entry with normal vesicular breath sounds heard. Cardiovascular system, S1, S2 heard and no murmurs. CNS, there's no focal neurological deficits. Digital rectal examination was to be done and pervaginal was to be done, and the spine and cranium are normal. Diagnosis, a case of swelling in the neck, probably lymph nodes, cervical lymphadenitis involving level 3 and 5 nodes for further evaluation. And these are the differential diagnoses which I'd like to give, with tuberculous lymphadenitis being most probable diagnosis.
Why do you think of these differential diagnoses?
Sir, because of the fever history, I wanted to go with tuberculous lymphadenitis, and also because the lymph node swellings in the neck are usually either tuberculosis or lymphomas or secondaries. But considering there's no malignant history, I went with tuberculous lymphadenitis, but again, could be mixed with the B symptoms of lymphoma. So because the patient was treated for the fever, I went with tuberculous lymphadenitis, sir.
Yes. If I ask you to arrange in the order, it will be in the same order, or you want to rearrange it in different order?
For this case, sir, this is the order I'd go with tuberculous lymphadenitis having the first priority and lymphoma having the second priority.
I would think lymphoma will come first because there is only single nodes palpable. There is no matted lymph nodes or anything less. Usually tuberculous, you will have a route of entry will be there where it's also an infection. You should think of an infection spreading to somewhere. If you are thinking miliary tuberculosis, then it's going to be all everywhere. You said there is no other nodes anywhere present. So we have to think of a route of entry, and there is, if the node are happening on both sides, it's a little bit difficult. So lymphoma can present like this. It can be there anywhere. It can choose areas. It's not a problem. Then here, when you do respiratory system, you have auscultated everything. But what I would be more concerned would be a dullness over the medial sternum, manubrium sterni. Most likely there might be a mediastinal node associated with this, which would be more in favor of lymphomas might be there. And then secondaries, I'll put it in the last. Usually when you are thinking of secondaries, you are thinking of a regional pathology which is going into this. You can't think of an area which can give spread to both supraclavicular nodes. It's really rare. Usually if it's lower deep cervical, okay, anterior to the sternocleidomastoid, then we can think about thyroids causing malignancy spreading to both sides. But apart from that, you can't have secondaries going to both sides of the neck at the same time. So I would prefer lymphoma as the first thing, and then tuberculosis second. Secondaries, I'll not have it in differential diagnosis also at this stage. What will you do next?
So to differentiate between the tuberculosis or lymphoma, I do an FNAC. Since the FNAC would rule out lymphoma if there's no histopathological findings.
Confirm your diagnosis itself and then go, or you want to confirm your differential diagnosis? Differential diagnosis will be, as sir said, is tuberculous lymphadenitis in a posterior group of lymph nodes first. Two, the lymphoma is another choice, and secondary is among all this, sir said it may be a lymphoma. So if it is going to be a lymphoma, where all will you look for and confirm or delete that diagnosis?
Ma'am, I would.
What are the investigations you would like to do?
I would do a contrast enhanced CT to check for other lymph nodes in throughout the body.
Where all?
Mainly the chest and abdomen. The chest for the retrosternal lymph nodes and the abdomen for the para-aortic lymph nodes. And then I would also check the pretrochlear, epitrochlear lymph nodes in the arm because non-Hodgkin's lymphoma could spread.
10.
Um,
Any solid organs you want to note?
What
The
we
spleen,
concentrate on
ma'am.
abdomen?
Huh?
What we concentrate abdomen, madam asking. You are suspected lymphoma in abdomen examinations. What are the things you have to concentrate?
The splenomegaly, ma'am, to check for splenomegaly, any splenomegaly is present. Let's see.
Can a hepatomegaly occur?
Abdomen. Yes, ma'am, hepatosplenomegaly.
So you
can-
want to look for the liver, spleen, para-aortic nodes and other nodes which could have been affected as well as the inguinal group of lymph nodes. Then if it is going to be a secondaries, where all can it be?
Ma'am, first I check the oral cavity for any oral carcinomas, then the nasopharynx,
Oral cavity?
Can you think that
or the
level of nodes?
supraclavicular?
level 3 and 5. Level
So
3,
common, where is that primary focus?
primary focus would be in the oropharynx, ma'am.
Then what else?
And then the nasopharynx, oropharynx, and then posterior triangle can.
See, you are telling is a left supraclavicular and right supraclavicular.
Oh, so,
Where is that primary focus you have to
the
examine?
GI system, ma'am, for
Yes, GI assessment, then
GI assessment, breast examination
Yes.
for any CA breast,
yes,
ovarian cancer,
Yes.
ovarian,
And testis male. Ovary and testis you have to examine
so
this.
stomach as well as colon. So you have to look for any primary over there
Yeah.
to rule out this secondary occurring. In addition, the lungs, okay, the lung carcinoma also can get into that place. So all these, to rule out all these, what are you going to do?
we could do a PET CT, ma'am, for a complete this thing to find out any primaries. If we can't clinically find any primaries, then a PET CT would be the best option.
It's you said it's lymphoma, and you have to always remember tuberculosis needs investigation also here.
Yeah.
So even though it's second, you have not mentioned about anything. If you get FNAC, if it's tuberculosis, you see tuberculosis also in FNAC, don't be happy with the diagnosis. Coexistence of lymphoma and tuberculosis is very, very common in our part of world. So that's more important. So tuberculosis means it needs your total
ATP.
count, ESR, MAN2, all these things, just routine things are needed actually. Don't just forget the basics. Tuberculosis is still common in our country. You have to investigate for those things. So of course, if you are thinking of lymphoma, if you have a histological proof, then PET CT would do all the areas, as madam said, all the areas can be covered. You can easily pick up. So even if it's secondary or a lymphoma, it can be picked up very easily.
You said right side node is soft and left side node is firm to hard.
No, sir. Both the right and left were hard, but there was another swelling on palpation, which I could feel at the level of thyroid on the left side. That node was soft, sir.
That's on the right side.
Sir?
That node is on the right side, soft node.
Yes, sir. The level 3.
Okay.
Yes.
So these are hard nodes.
Both of these are hard, yes.
Hard nodes. So hard nodes means mostly from oncological perspective, you'll think it as a secondaries. So when you are thinking of secondaries, for this level 4, you should not say oral cavity, oropharynx, nasopharynx and everything. So it must be below the cricoid cartilage. So whatever thing it may be, hypopharynx, larynx, anything can be there, starting from the esophagus, lung, breast, GI, anything can be there. So you should not say oral cavity, oropharynx and nasopharynx for these patients.
Yes.
Okay, if it is secondary snake, PET scan says there is nothing. Nothing means only these nodes are active. What will you do?
So could you repeat that, sir?
PET scan you have done
Yes, sir.
and FNAC you have done.
Yes.
FNAC shows cancer, malignancy.
Oh,
PET scan shows only these two nodes are active. What else you will do?
First, treat the primary, sir. Depending on where the
Well,
primary.
sir is saying When there is no primary, you have done a PET scan, it shows only lymph nodes are palpable, lymph nodes are visible, taking up hypermetabolic activity is seen in lymph nodes, no other primary is picked up. What will you do?
So we do an excision biopsy, and then we'd send the patient to come back for checkup every 3 months, because within that time the primary could show itself.
Actually, what sort of FNAC, what sort of malignancy you are looking at? In upper deep cervical, just before now we have discussed squamous carcinoma. What will be here?
Upper deep cervical.
Lower, 3 or 4.
Level 3.
What type of malignancy?
So,
If you are thinking of secondaries, what will be the type of malignancy you are expecting?
oh, squamous cell, sir.
You
Okay, if it is squamous cell.
Oh, no, sir, sorry. It will be
Okay,
adenocarcinoma.
It can be squamous cell also. Squamous cell means what are all the places?
The oral cavity would be for squamous.
No, don't say oral cavity. It will be from
sorry,
the
the tongue.
hypopharynx, larynx, upper esophagus, or sometimes from the lung. So these are all the 4 places can have squamous cell carcinoma in level 4. Okay, if it is adenocarcinoma, any other thing you will do? So most thing is we have to do a immunohistochemistry to find the origin.
Yes, sir.
Okay.
So what are the types of lymphomas?
Hodgkin's, non-Hodgkin's lymphoma, and then non-Hodgkin's lymphoma, B cell mediated, B cell, T cell, MALT.
What is the specific cell you look for in Hodgkin's?
Reed-Sternberg cells.
Yes, Reed-Sternberg cells. If it is going to be a Hodgkin's lymphoma, what is the mode of management you want to do?
Ma'am, we could give ABVD, which is adriamycin, bleomycin, vinblastine, and doxorubicin. Oh, wait, then danorubicin.
Okay.
Or we could give Biocope's regimen.
So is there a role of radiotherapy?
Radiotherapy. If based on how based on severity, the radiotherapy could be given initially, ma'am, but for severe cases, chemotherapy is only.
Once you are confirmed, always do the staging investigation
Yes.
to stage the disease. According to the stage, we have to do chemotherapy or radiotherapy.
Yes, ma'am.
For undergraduate level, only the next swelling, there's 3 options already you are giving. If it is tuberculosis, what is the treatment? And if it's lymphoma, any lymphoma, once you are confirmed histological, staging workup is very important.
Yes.
Okay. Yes.
okay.
Oh, thank you.
I request all the chairperson come out. Thank you.
Next, I welcome Vilupuram Medical College, the peripheral arterial disease. I welcome the examiner and faculty, Dr. Ramasubramaniam sir from Chennai Medical College, and Dr. R.Kannan sir, head of the Department of Metabolic Medical College, retired. Welcome, sir. And Dr. Javagar sir. Dr. Javagar sir. from Tagore Medical College. Thank you, sir, for coming. Please, Viluppuram. Is there any Venkateswara Medical College? Any student from Venkateswara Medical College? Okay, thank you.
Good morning, sir. I'm Akilan. I'm coming from Viluppuram Medical College. I'm here to present this case of vascular disease. Patient name Mr. Panir Selvam, 38 male, occupation farmer, is coming from Viluppuram, socioeconomic status class 4. Patient presented to OPD with chief complaints of pain in the right lower limb for past 1 year, ulcer at right leg for past 3 months, blackish discoloration of toes for past 1 month. Patient was apparently normal before 1 year, after which he developed pain in the right lower limb for past 1 year, pain in calf and forefoot regions, continuous and squeezing type of pain. Initially, pain developed when patient walks up to half a kilometer and disappeared when patient rests. Over a period of time, the onset of pain occurred at minimal walking, and gradually patient developed pain at rest for past 1 month. That is grade 4 by Boyd's classification.
Kambi, what is this type of pain?
Claudication pain, sir.
This is the claudication pain.
Yes.
In the claudication pain, what are the grades of claudication is there?
Sir, according to Boyd's classification, there are 4 grades of claudication pain.
In your patient,
Grade 4, for past 1 month, he has been having rest pain, sir.
grade 4, it is a
Yes.
rest pain.
Yes, sir.
What is the cause for the claudication pain?
Sir, actually, it has ischemic etiology, sir. The patient,
It is
due to
a-
poor perfusion
is-
vascular supply,
it is a-
claudication pain
It
occurs.
is only ischemia or some other factors acting on it?
Actually, it is due to accumulation of P substances also, sir. So, it is also poor venous.
You should know why there is an accumulation of P substance.
Yes. Venous outflow and arterial obstruction both causes.
The P substance which is released from the arteries are stagnant here because of the ischemia,
Yes, sir.
because of the inefficient contraction of the calf muscles. So what type of claudication, that is the level of claudication? What is the level of claudication?
Sir, in this case, it is probably at the infrapopliteal region.
No. This is a muscular claudication. First, what you are explaining is the muscular claudication you are explaining. Which level of the muscles?
Popliteal muscles are involved and
Popliteal?
calf region, the
There
pain
a
is
calf
there.
muscles. Huh?
Yes,
You
sir.
told it is a calf muscle.
Yes.
So there is no need of presentation and all. You can tell like that. Huh? So it is a calf muscle claudication. What is important now to asking about the level of claudication?
To find out the level of obstruction or
So what is the level of occlusion in your patient? If it is in the calf muscle, what is the level of occlusion?
in the superficial femoral artery or
So you see,
infra-
that is a one level above the
yes, sir.
claudication. See, if the patient is having calf muscle claudication, the level of occlusion must be above the popliteal.
Yes.
So from the history itself, you should approach your diagnosis. Carry on.
Ulcer in the right lower limb for past 3 months. Ulcer in the lower part of leg just above the ankle joint. Occurred spontaneously as a blister which gradually attains present size. Not associated with any discharge. Blackish discoloration of toes in right foot for past 1 month. Blackish discoloration of great and second toe. Development of insidious in onset and gradually progressive. Associated with loss of sensations. No history of loss of sensation over the right leg. No history of trauma. No history of bleeding. No history of discharge. No history of any other localized swellings. No history of bluish discoloration of feet. No history of fainting, headache or blurred vision. No history of abdominal pain. No history of chest pain. No history of fever. No history of impotency.
What is the importance of asking all these no histories?
Yes, sir. Trauma is for the ulcer. Trauma, bleeding, and discharge. We are asking for ulcer, sir. We are trying to find out the etiology of the ulcer and also what kind of ulcer it is.
No, it is not like that.
This is a, see, from the history, you can able to judge it is a peripheral artery disease. In that case, you should know the affection of the disease to other systems also. There are a lot of other small sized vessels in our body, like carotid, vessels in the arm and all. So you should know the transient ischemic attacks, anginal pain, abdominal angina, like that you should know, you should ask. Then only you can be able to treat the patient well. You should not concentrate only on the toes, ulcer and leg. That is an established ganglion. Your treatment must be in toto. Okay, carry on. So you should, while asking about the negative history, you should know about the importance, not just like rapidly it is not, there is no history of cough, no history of diabetes, not like that. You should know what for you are asking and in what way that will give some indication for the treatment.
You put impotency, no? Why do you want to ask about impotence?
Sir, in Lerich syndrome, that is bilateral internal iliac artery obstruction, impotency occurs due to poor perfusion of pelvis. Sir.
Yes.
Sir, localized swellings and bluish discoloration of feet. I've asked for phlebitis and fainting, headache or blood vision, abdominal pain, chest pain. I've asked for involvement of
you too. Okay, carry on.
Past history, no history of similar illness in past, not a known case of tuberculosis, asthma, dyslipidemia, diabetes, epilepsy or any other skin disease, hypertensive for past 5 years, irregularly consumes oral antihypertensives, not a known case of coronary artery disease, cerebrovascular accident or chronic kidney disease, no history suggestive of any thromboembolic conditions, no history of previous blood transfusion, no previous major surgeries, not allergic to any medication. Personal history, consumes mixed diet, smoker for past 20 years, 1 pack BD per day, number of pack years is 20 and smoking index is 400. Alcoholic for past 20 years, social drinker, drinks once or twice per week, not a pedal nut chewer. Treatment history, unknown analgesics were taken by the patient infrequently for pain from local clinics. Family history, no history of similar illness in family. Summary, a 38-year-old hypertensive, a chronic smoker and alcoholic, presented to surgical OPD with chief complaints of claudication pain in right lower limb for past 1 year. Initially grade 2, which developed into grade 4 past 1 month, that is pain at rest, with ulcer above the ankle for past 3 months, and ischemic gangrene of the right great and second toe with regions of anesthesia or foot for past 1 month. It is probably a case of chronic arterial occlusive disorder evaluated for further diagnosis.
Why you came to that conclusion? Why you came to the chronic arterial occlusion?
Sir, the claudication pain is the first.
See, peripheral, usually arterial disease are either it may be acute on chronic or chronic. In this category, why you put this patient in a chronic?
Sir, the patient has been having pain for almost 1 year now, sir. And it is actually a chronic disease because first the pain was grade 2, which gradually progressed to grade 4. So it is a chronic occlusive disorder. It's a chronic condition, sir. For past 1 year, he's almost having it.
No, not like that. While coming to a diagnosis, I will tell you. Carry on with the examination.
General examination. Informed consent is obtained and patient is examined in the recommend position. Patient is cooperative, conscious, oriented, moderately built and nourished. Patient comfortable in decubitus position. Pallor is present. No icterus, no cyanosis, no clubbing, no pedal edema, no lymphadenopathy. He is slightly dehydrated and his gait is abnormal due to pain in the leg. Vitals, blood pressure 134/90 mmHg, pulse rate 69 beats per minute, respiratory rate 18 beats per minute, and temperature is favorable at the time of examination. Local examination, informed consent is obtained and patient is exposed from zipus sternum to toes and examined in recommend position. Inspection of right lower limb. Both limbs are kept together side to side and examined. Right leg appears pale. Limb attitude is normal. No deformity present. That is inspection of right limb alone. A heel scar.
What is that limb attitude? What you told? Limb attitude is normal. What is that attitude?
Attitude.
See, don't introduce lot of words and all. Whatever you know, you just tell. Huh? You are inviting problems, and you can. Attitude, you should know if the patient is having any deformity or any difficulty in walking or any modalities in change, only you can utter that word. Huh? Okay.
A healed scar of size 3 x 4 centimeter visible in the anterior compartment of leg. No sinuses or dilated veins present. Marked loss of hair over foot and leg. Skin is lustreless with brittle nails. An ulcer of size about 7 x 5 centimeter is present in the anterior compartment of right leg. Ovoid in shape, red to yellow in color. Extent, upper border of the ulcer situated about 20 centimeter from the base of tibial tuberosity. Lower border about 4 centimeter above the medial malleolus. Punched out edges, irregular margins. Upper margin has blackish discoloration. Floor is pale and dry. Granulation tissue present scarcely in the upper part of ulcer and necrotic slough in the lower half. Skin surrounding the ulcer.
This one you should not examine like an ulcer. But in what way this granulation tissue helps for you? Floor in the granulation tissue is a healing sign? No. It is you should not describe the ulcers and all like this. Okay, what do you think about the reason for the ulcer?
Due to
you go in that manner. How arterial disease present as an ulcer? Patient is having ischemia.
Patient has ischemia and the
So what makes to produce an ulcer?
First, there is presence
in this patient is ulcer is related to the peripheral arterial disease or not?
Yes.
If so, what is the reason behind?
The ulcer is not able to heal, sir. Poor perfusion.
Poor perfusion of what?
Poor perfusion of the. So ulcer is not able to heal, sir. It needs good blood supply for its.
Ulcer non-healing is the reason for non-healing may be a ischemia.
Yes, sir.
But what is the reason for you? Don't describe the ulcer to such an extent that is not related to your case at all. What is you describe about the black, that is, the toe is black.
Yes, sir.
Yeah, you describe about that.
Dry gangrenous formation of great and second toe. Line of demarcation not clearly visible.
Why you are telling as a dry gangrene?
Sir?
Why you are telling as a dry gangrene?
Sir, it is shriveled and hard, sir. The surface. While looking at the gangrene, it is the skin of the blackish discoloration appears shriveled and gangrene. It is not associated with any kind of discharge.
Okay. Okay. So instead of
you can't in line of demarcation is not clearly visible.
Yes, sir. Line of demarcation is not visible in this case because there is still the progression of gangrene is not still complete, sir, in the full of extent of the fingers of the toe.
Okay, then tell what is mean by line of demarcation.
The line of demarcation represents the division between healthy tissue and the gangrenous formation, sir.
So is it a healthy tissue? You yourself is telling line of demarcation is not at all formed, having a tendency to extend. Then how come it is a division between the healthy and unhealthy tissue? It is not a healthy one. That line of demarcation is between the gangrene and another pre-gangrenous segment.
Yes.
That is the segment above the line of demarcation is also having a tendency to go for a gangrene at any time. It is not a normal healthy tissue. So that word you should know. You should know it is not a normal thing. Okay, carry on.
Skin surrounding the gangrene
instead of describing the ulcer, you describe here afterwards better to describe the gangrene in this case rather than the ulcer. Okay. In a vascular case, gangrene is important. Okay. Then carry on.
What will be the depth of the line of demarcation? Is it only skin depth or subcutaneous tissue or even can extend up to the bone?
Yes, sir. It can even extend up to the bone,
that's
sir.
you must know that it can extend up to the bone, demarcation.
It
And you must describe the skin above the line of demarcation, whether it is edematous, loss of hair, what are the autonomic changes you have in this case? Skin is dry, loss of sweating, hair loss, right? All these things you must tell. Right. Okay.
Carry on.
palpation of right lower limb.
Actually, in that picture, we can able to see the level of demarcation. Okay, carry on. Oh, okay, carry on.
Palpation of right lower limb. Skin over the foot is cold. Tenderness present over the ulcer area. Inspectory findings are confirmed. Base of the ulcer is mobile and is attached to the muscle beneath. No induration. Dry, hard, and shrivel gangrenous formation of great and second toe. No tenderness along the lines of blood vessels. No local congestion. No palpable lymph nodes. Palpation of left lower limb is normal. Test for assessment of capillary insufficiency. In vascular insufficiency. Test for capillary refilling. 4 to 5 seconds to refill in the right leg, which is higher than the left leg. So left leg is normal. Inference poor perfusion in the right leg. Test for venous refilling. Harvey sign. Normal filling in normal direction in both legs. Inference no venous abnormalities.
In what way venous refilling helps your progression to assess the progression of the disease?
Sir, actually, venous.
What is the normal venous refilling time?
Normal venous refilling time is around less than 10 to 15 seconds, less than that, sir. And in this case,
upper limit is 20 seconds. Okay, carry on.
In this case, the involvement of venous and arterial both occur in case of peripheral vascular disease, and we are testing for venous refilling because it occurs in the acute stage of the disease, sir. Inflammation progresses, there is phlebitis and acute involvement of the venous.
Venous refilling time is very, very important for assessing the prognosis of the disease, how you will treat, how come we can treat and all. So to choose the modality of treatment, venous refilling is very, very important. You should know the venous refilling time, normal time, and also for the impending gangrene also, what may be the venous refilling time. It is not easy like other one, capillary filling. Capillary filling is, we can tell like that, but not the venous refilling time. Okay, then Burgess test.
Burgess test, leg and foot becomes pale when raised above 30 degrees in right leg. That is, the Burgess angle is 30 degrees in right leg. It infers to the point that severe arterial insufficiency in right leg and left leg is normal. No paleness up to 90 degrees.
By Burgess test, what information you are gaining?
By Burgess test,
see, by Burgess test, venous refilling, capillary test, all these test tells you what?
Poor ischemic, poor arterial, poor perfusion to lower limbs.
So all these tests tells vascular instability.
Yes.
So normal, there is a vessels are not under the control of, that is getting away from the control of autonomic nervous system, everything and all. So it is an indication of vascular instability. All these tests are indication. Okay.
Examination of the peripheral pulses, and the pulses are negative in the following: dorsalis pedis artery, anterior tibial artery, and posterior tibial artery, and popliteal artery in the right side.
Have you seen the pulse chart, how it has to be put? 1 plus,
Yes,
2
sir.
plus, 3 plus, 4 plus, like that you should put. Not negative one thing, no?
This is not an acceptable part. You can
So
put
your
as
pulse
a-
chart, you should put 1 plus, 2 plus, 3 plus.
Yes.
No, that is the way it has to be kept. Not felt. Negative, no negative.
So normally where you will feel per dorsalis pedis artery.
Dorsalis pedis artery, we look in lateral to extensor hallucis longus tendon in the foot, dorsal part of the foot, just in the midpoint of the medial and lateral malleolus.
Midpoint of the
Medial and lateral malleolus.
malleolus. medial and lateral malleolus.
Yes.
What
in
is
the
that?
place-
Just below the flexor retinaculum. We should maybe, yes, sir.
Is it dorsalis pedis or is described?
You described is not a dorsalis pedis.
Anterior tibial artery. Sorry, sir. A dorsalis pedis artery, we are palpating in the lateral to extensor hallucis longus tendon in the first metatarsal.
It is at the base of the
Space.
base in
Base
between
of the
the first and second
sir.
metatarsal bone, head
Yes.
of the base of the metatarsal bone.
Yes.
That is the dorsalis pedis
Yes,
artery. Dorsalis pedis artery, where it dips inside, that is, can you able to palpate up to the tip of the toes?
No, sir. We are able to palpate in the intermetatarsal space between the two fingers.
See why that point is very important. So once from that level, dorsalis pedis once going in front, it dips into the sole, that it dips into the sole and it helps in the formation of the arterial arch. So thereafter, it is not possible for you to palpate the dorsalis pedis artery. So that site is very important. You have to choose that site and palpate. What about popliteal?
What is the percentage where dorsalis pedis is absent? You are not able to palpate. Is it palpable in all patients? So there is 10 to 12%, it is not palpable, right?
What popliteal artery?
Popliteal artery, we have various methods, sir, and for
You describe one method.
Fuchs test we can use, sir.
Huh?
Fuchs test.
Fuchs test.
We can place the calf of one leg on the knee of other leg and see for any oscillatory movements or jerky movements to see the pulsating.
Okay. What about the clinical palpation? Clinical palpation. How will you palpate for the dorsalis pedis? Sorry, popliteal.
Sir, we have to make the patient lie in the prone position and we should palpate the calf of the patient.
Palpate the
Calf of the patient.
calf.
Just in the lateral side of the popliteal fossa.
I mean, this is a clinical examination. Instead of putting all these things and all, you should know. See, we can be able to palpate popliteal. Why I am asking is popliteal is it is very difficult to palpate unless otherwise you repeatedly palpate. You are not able to palpate. So in a prone position, if it is in a prone position or in a supine position, two ways you can able to palpate. In a supine position, how will you palpate? You should know that is simply by DAS. Or otherwise, see if if you are palpating the vessel, you should press the vessel against a bony surface. Then only you can able to elicit that pulsation. So for a popliteal artery to observe the popliteal pulsation, where you are compressing against which structure you are compressing the popliteal artery. Which part of bone? That is the fixed bone.
Against tibia.
Against
Tibia.
Against tibia and
Tibial tuberosity at the level of popliteal fossa. We have to palpate. Tibial tuberosity.
Tibia is running from the about to. Okay, these are the few things. These are these and all quite. See, arterial disease. We are not going to ask you angiogram or reconstruction and all. This is the way you should know about all these things instead of going for all these things. Okay, carry on.
In fact, they will ask you to demonstrate in a supine position, in prone position. Both are different. In a prone position against a femoral condyle, whereas in a supine position against a tibial condyle, right?
Okay, carry on. Okay. What is your diagnosis, Mark? What's your diagnosis, Mark? Slides.
Sir, it's
the case.
it is a case of peripheral vascular disease involving the right lower limb. It is probably a case of thromboangiitis obliterans or Buerger's disease with critical lower limb ischemia of the right legs.
So you know critical.
Sir, gangrenous formation and ulcer formation shows critical limb ischemia. Previous.
Won't correlate with the acute limb ischemia. Okay. So if it is a peripheral artery disease, do you want to grade it as a TAO?
Sir, actually, it has smoking etiology
Yeah.
and no other atherosclerotic factors involvement.
So, or other, if you are in favor of TAO, do you know the pathophysiology of the TAO? Just a few lines.
Yes,
How
sir.
TAO, yeah.
It is a chronic inflammatory, it is a chronic segmental inflammatory obliterative and occlusive condition that involves the medium and
No. You explain the term thromboangiitis obliterans.
yes, sir. Thromboangiitis obliterans is an panvasculitis inflammatory.
It is a pan-arteriitis. Okay,
Yes, sir.
that's okay. Then
It involves,
see, why you ask for a smoking history?
sir, it has a strong smoking etiology connection, sir.
Because of the long-standing smoking, that nicotine is getting deposited in the intima of the blood vessel.
Yes, sir.
So this nicotine is a irritant for the intima. So it will go as a angiitis. First change is an angiitis. It is
Yes.
an irritation, angiitis. Because of the angiitis, the vessel wall become still more narrowed. So there will be a stasis. Because so it is a angiitis going to the
Obliterative stage.
so
Occlusion.
it is going for a slight obliteration. Then because of the stagnation, it will goes for a thrombosis. So it is an angiitis, stasis, then thrombosis.
Occlusion.
So that is the pathophysiology.
So how will you proceed?
Sir, we'll have to investigate both the limbs for vascular insufficiency, sir. We can do duplex scanning in both the lower limbs. Then digital subtraction angiography and CT angiogram if necessary before surgery to proceed for surgery.
What is the advice you will give in this patient?
First, it will be cessation of smoking, sir. Cessation of
Yes.
smoking is the primary line of treatment for Bridges disease. So he'll have to stop smoking, and then we can advise drugs such as low dose aspirins and pentoxifillins or silastazole for perfusion to limbs.
Why you are commonly telling about pentoxifillin? What is the role of pentoxifillin in a arterial disease?
The pentoxifillin is a hemorrhagical drugs that alters the RBC's platelet. I mean RBC. It modifies the RBC.
See, RBC as such is having difficulty in entering. If it maintains its shape as a rounded one, it is having difficulty in entering into the
across the thrombus, sir.
Entering into the capillaries. Yes. So while it tries to enter into capillaries, it changes its shape. It changes its shape to the dumbbell shape or any other shape, any shape. So that is a rheology. So this pentoxifillin helps the RBC to change the shape with the help of ATPase increase. That's how this pentoxifillin is helpful for the increasing the blood circulation.
You are well presented, Pa. In the examination, don't get worried when you get a peripheral arterial disease or a varicose vein. A little more effort, you can easily get through the long case.
Yes.
So you should not say always I want to have only a hernia as the long case, right? When you attempt a peripheral vascular disease or a varicose vein, you are sure of your pass, right? Thank you.
It is very easy to get through and very easy to arrive at a diagnosis, and the findings are very, very minimal. If we go methodically with the history, everything and all, diagnosis is quite easier than the other cases. So arterial disease, try to choose the arterial disease as your long case. Thank you. All the best.
Thank you, sir.
Presentation well done and very good discussion, sir. Thank you.
Next case is a carcinoma breast, but the candidate is not here. So it's now it's another candidate we allotted. Then they are getting ready. Meanwhile, I call Dr. Arun Kumar from ADR Plexus for the 2 days events. Completely the ADR Plexus support the ASI, our R&R CME. I welcome Dr. Arun Kumar to the dais for the few words.
So good morning to one and all. So thank you ASA team for giving us this opportunity to be a part of this event. And myself, Dr. Arun Kumar, and I'm the academic director of ADR Plexus. So ADR Plexus is a NEET, and right now currently the next exam we are training doctors for NEET and next. And most importantly for this PG entrance, I was one of the students sitting in the Sacred Hall in 2006, being a part of postgraduate medical entrance coaching. This hall is one of the sacred halls for us, and being a part of this hall, we have been into the post-graduations. And almost 1,600 students would be sitting, and I would be sitting in the last one where almost it would be the last rows. There's a balcony over here, and there's another balcony over there. And from there, we used to listen to the lectures. And from a postgraduate aspirant, I started ADR Plexus in 2008. And as soon as I started, we started for postgraduate PGMR as a MCQ training center. And 2008, again, we started with ADR Plexus, one student. We started ADR Plexus as one student. And gradually in 2009, we had around 50 students. And 2013, we had almost training around 150 students. And after that, we went into training into the CBT centers, establishing the computer-based training centers. And we started some live videos right in 2014. And across India, we were taking the lectures in the form of tablet. 2017 was a breakthrough year for us. We trained almost 300 students in Chennai. And we got one of the toppers, a single-digit rank, Dr. Rupani. She has finished her MD RD from MMC. And from there, we went on to coach approximately 2,500 students right in Chennai. So from one student, we jumped to 2,500, and 2019, we were the maximum, having the maximum number of students in Chennai. After 2019, again, we were back to 0 because of the COVID. And there was a complete lockdown, and we were back to 0 because we were a traditional classroom training center and we didn't focus more on online apps. So what made ADR Plexus successful from one student to 2,500 students in Chennai? We implemented 3 important strategies for addressing the pain point of a postgraduate entrance preparation student, in which the first important thing is going to be the MCQ assessment module, and the next, how we integrated the lectures and effective microplanner. So when we classified the readers, we used to classify the readers as visual, auditory, and kinesthetic readers. But there's a fourth component, which we call it as readers and writers. And the readers and writers is what we engage the student, how actively we engage the student in a classroom rather than a passive coaching. So readers and writers is a component which is effectively used in competitive learning. And we were bringing this hardened rule of integration inside the PG medical entrance training. So what happens before 2014 and what is the change we brought in 1 minute? In 2014, when we used to sit over there, the lectures will be taken over here and people will be taking a great lecture notes with their own notebooks. So this used to happen. And what In 2014, when the exams became computer-based, lot of image-based questions were asked, lot of clinical scenarios were asked. But when the lectures are being taken in a class, you'll be taking excellent notes, but what you miss is going to be the pictures. For example, an histopathology picture or any clinical picture, you'll be, of course, taking photo snapshots and you'll be having a great notes. But this was a pain point while you take in revision. And adding to it, people, what they do is that they buy a lot of textbooks, which is author-based textbooks for postgraduate entrance. So what we did is like, to solve this problem of revision, we brought in something called workbook. You would have seen what is the workbook of ADA Plexus, which is kept in the display. Workbook is something which engages users, the doctors, where they will be writing the notes within the book, which is given to you in a structured format. 50% of the content will be already printed, and 50% the faculty will be writing the notes, which makes it structured. And we follow some color codes, which will be easy for your revision. So this active implementation took ADA Plexus right from 100 students to 2,500 in 2019. So this is one of the formats of learning, but more importantly, what we do is that we assess immediately inside the class. So this assessment is one of the important parts of postgraduate entrance training. And what is the assessment we do? Yesterday, you would have, few of you would have taken the live quiz format. This is called leaderboard assessment, where the faculty gets a feedback. How many of you understood the topic really well? For example, in this question, when 55 I had answered and 38 and 44 and 175 I got it right, 50% of the got it right and 50% got it wrong. This assessment, when it comes to the faculty, immediately on the real time, the faculty will be able to stress that point. And this was a breakthrough. And this is how we brought in the active engagement inside the classroom. And this made us jump from 100 to 2,500 in Chennai. But all these implementations were done in classroom, and we believe in a traditional classroom training, and immediate results will be displayed to the doctors in this format. So the immediate assessment and the immediate results keeps the competitive engagement inside the classroom. And one important thing is that what we do is that we do the micro planning of lectures. Like, if you work with a workbook and enter into the class at 11:05, that topic will be taken. That kind of a discipline and a structured format was put in the classroom. And this is one of the things which we as ADA Plexus did. Okay. Now coming to post-COVID scenario. And this jump happened before COVID. In COVID, since we are a traditional, we are back again to zero. And we have to start it all over again as a center. And 2020 was a real testing year where we have to implement both tests between a synchronous learning and asynchronous. Synchronous is a live Zoom kind of a platform. Asynchronous is recorded learning. What you have in apps, you learn at your own pace. And asynchronous and synchronous is very simple. Synchronous puts you on a real-time environment with the faculty, and you will be able to interact with the faculty. So we chose synchronous learning. We launched the apps, and right now, again in 2022, we were back with other same 2,000 students, where we coach 1,000 in Chennai and 400 in Coimbatore and 200 in Madurai and Puducherry. But one important thing is that for our online live, we have almost 5,000 plus students. For our online live lectures, we have 5,000 plus students. And apart from this, few colleges who would have attended today and yesterday, they knew that we are officially an MCQ training platform into colleges. We are the only institute in Tamil Nadu which is officially training doctors in private medical colleges for MCQ training. And apart from this, the results of 2022, which we incorporated with our thing, we were able to produce the top ranks in 2022, and all these results belongs to Tamil Nadu students. Okay, because we are operating only in Tamil Nadu, but for online, we operate across India. So this is about ADA Plexus. And right now, the next important thing, the implementations guidelines has been already coming, and the next exam is going to happen in December 2023. And this is one of the exams where we have consciously put our efforts, and we have put a curriculum based on it, working with few top medical colleges. With the conveners, we developed a platform, and we developed a curriculum for a CBB assessment, for MCQ assessment for this next one. And this guidelines, yesterday was the last day to submit the comment section for NMC. Probably within a month's time, NMC might come up with the dates for the first next exam, which is going to happen in December 2023. So this is all about ADI plexus, and to sum up, this is going to be completely a clinical exam with high weightage on clinicals. Almost 80% of the questions are going to come from 6 subjects. 10% is from your non-clinicals and paraclinicals. 10% is from PSM. So this proposal is in proposal stage, but already the draft has been announced. Probably in a month's time, they are going to release the final thing. So this is going to be the thing. And what we were into the colleges training for doctors for the next and developing a platform almost 1.5 years. We submitted the proposals to the colleges, and right now officially 4 colleges we are doing this institutional training program for MCQs inside the private medical colleges. So right now, as of now, we are back into the centers. Centers got opened in 2022. And this is a center where, again, we are back to 1,000 plus in Chennai. And right now, these are the other centers where Coimbatore, Puducherry, Madurai, we operate. Apart from this, we developed a strong online platform. Yesterday, you would have experienced what is a leaderboard and how strong our online platform is. So thank you one and all for giving this wonderful opportunity for presenting about ADI plexus. And this is one of my dreams, and this is one of my dream day, because I have been a student sitting over there, and today, on that day, I dreamt, I had a dream that I had to start a center for at least 100 students. God willing, it took 15 years to reach this 2,000 plus students. And today after 15 years, I'm the same stage delivering this. Thank you one and all. Thanks for this opportunity given by ASA and the ASA chairman. And hopefully we'll be again conducting a program, full-fledged program in the same hall. Thank you one and all.
Sir, I request you to do one thing today. You give 10 tips in 10 minutes or 10 like rapid fire, how a student should look forward for their entrance preparation.
The first important thing, they should be completing the internship period successfully without attending any entrance program. That's the first important thing, because the questions are clinical questions. If you tend to skip any of your regular MBBS programs, it's not going to happen. All the toppers we have seen across the years, they are very good at their MBBS internship period. They don't skip classes, they don't go for bunking their classes. They are really good in their undergraduate years. Second important thing, right now the changing pattern, you have to get it aligned with the changing pattern. It's to be frank, I'm a pharmacologist, I belong to paraclinicals, but focus on your clinicals. Clinicals, the questions are getting framed for the clinicals. It's no more a factual question. It cannot be a numerical question. It doesn't be based on your memory. It is based on how you solve the questions. So getting inclined to approaching the MCQs is more important at the early stage. And programs like this will help you, like a quiz program. Attend lots of quiz programs. All the toppers we have seen across these years have been a very competent people who go for quiz programs. The third one. And next is an opportunity where you can even get into your post-graduation even before completing your internship. And for that, probably people say that use postgraduate entrance materials, but as a postgraduate center coordinator, I know that if you're strong in your subjects from your authentic books, you will easily get into it. Okay. So 4 tips is what I will say, and the next tips comes after you come to the stage where most of the people lose their confidence and the discipline. And one important thing, the procrastination. All these you'll be dealing in the entrance programs. And I think 10 points I didn't have, but 5 points is that
I will ask this way. Right.
Yes, student and one important thing, the procrastination. All these
start
dealing in the
because it has now become an order of
and I think
people have multiple choices. Can I go to UK? Can I go to USMLE? Or can I do NEET? Because these are three different verticals. A student will always prefer to say, sir, let me start preparing for entrance from my first year onwards. So when I do physiology, I will do physiology MCQs so that it becomes easy. So for a student who still get undecided whether he's going to do a NEET PG or USMLE or PLAB? What will be the ideal way to prepare?
As of now, if next is getting implemented, all this possibilities are ruled out because next is going to be more of your USMLE step one pattern. So one important thing is that right from your second year, you should have inclination with your professors, get yourself close to your professors who are there. They are the best guides to give you a guidance regarding whether it is USMLE or UK or your Indian exams. Most important, networking is the most important network at this junction. How close you are to the professors, they'll be the best guidance for you. When you get in touch with them, they are the people who are going to give you the reference for USMLE or UK or Indian exams. But if you settle with Indian exams, as I say, you have to start preparation because you have the golden opportunity of not wasting one more year in PG entrance. As of now, this next is going to solve a major problem. After 2 or 3 years, you will see, you will be getting your post-graduation at your final year result. It's like getting a confirmation of about your post-graduation with your scores in your final year itself. You need not come to a coaching center separately and waste one full year. It is all about your discipline right from first year onwards. First year, second year, third year. All the questions are going to come from your cases. And your clinicals are going to be the most important thing. So then what is the role of a coaching center? Coaching center will give you MCQs for those cases. That's the most important thing. So learn from the patients. That's going to be the most important thing. And all your cases are going to be the MCQs. It's not factuals anymore.
Thank you, sir. Thank you very much. Students, very simple. It's like that's take.
Learn from the patients.
Thank you,
That's going to be
ADR
the
Texas,
most
for
important.
Carcinoma breast. Dr. P. Geetanjali from Stanley Medical College. I welcome the examiner, Dr. R.Kannan sir, Professor of Surgery, third from Madras Medical College, Dr. Ramya Ramakrishnan, Madam from SRMC, Professor of Surgery, and Dr. Javagar sir from Tagore Medical College. Welcome, sir. I welcome Dr. G. Muthukumaran sir, JMK sir, as a convener for this. Welcome, sir. PPT shot.
Please start. Myself, Geetanjali from Stanley Medical College, and this is Harini from Stanley Medical College. Mrs. XYZ, a 49-year-old female from Ahmedabad, homemaker by profession, came to OPD with chief complaint of right breast lump for the past 2 months. History of presenting illness. A 49-year-old female presented to OPD with complaint of lump in the right breast for the past 2 months. The patient was relatively asymptomatic 2 months ago. after which she noticed a lump in her right breast, which was gradually progressive in size and reached to the present size. Lump was painless, not associated with redness or any nipple discharge. No history of fever, trauma to breast, no history of similar lump in the opposite side of the breast, no history of weight loss, no history of backache, jaundice, anorexia, cough with hemoptysis or breathlessness. Past history, no known comorbidities present. Operative history of open tubal ligation was done 15 years ago. Personal history, diet, vegetarian diet, bowel and bladder habits are normal, sleep normal, appetite normal, no known drug allergies present, no history of addiction to tobacco or alcohol. Menstrual and obstetric history, she attained menarche at 14 years of age, has 3 children, 2 daughters and 1 son, all by normal vaginal delivery. All children adequately breastfed for up to 2 years. Age of the patient during first childbirth was 20 years. Last childbirth 15 years ago, followed which tubal ligation has been done. Post-menopause age since 3 years. No history of use of any contraceptive pills or hormone replacement therapy. Family history, no history of any malignancy in family and no siblings. Summary, a 49-year-old postmenopausal female of obstetric code P3A0L3 with a painless, gradually progressive right breast lump since 2 months without any nipple discharge, no swelling in the axilla or opposite breast, no history of weight loss, no positive family history.
Go to past history.
Past history.
Here you mentioned only about comorbidities. What are the other things you will inquire in the past history about any case you have to ask about hypertension, diabetes, tuberculosis here, it is important. Most important, chest wall irradiation, you have forgotten.
Yes, sir.
All the predisposing factors should come in the history taking. You understand?
Go to your first slide, Ma. Okay, the next one, please. See, basically you've asked associated with the breast lump, what are the things that you asked? Can you just repeat it? You have missed a couple of points.
Nipple discharge, no?
More than nipple discharge, you should also ask for
retraction of the nipple.
Yeah, it's very important. Recent nipple retraction, nipple discharge. What else about the lump that you would like to ask? You said it's painless. Would you want to ask any other question regarding the lump? What else you will ask? Basically, any secondary changes over the skin over the lump. Is there any ulceration, any discharge, anything that is inflamed skin, reddened skin? All this will tell you maybe it is going to fungate. Is it peau d'orange? That also the history will indicate. Of course, examination, you're going to confirm all those things. So what you missed was most important was nipple retraction, recent nipple retraction, secondary changes regarding the lump. Initially, you didn't mention anything about any other lump in the same breast, opposite breast, any lump or swelling in the same axilla, opposite axilla, even in the lower part of the neck, that is a supraclavicular fossa. So that will complete the history for you.
Doctor, when we were asking the history, the 3 things very important is the lump, either in the right breast you told. What about the left breast? Never say opposite breast. No, ipsilateral, contralateral, right? Then axilla. Is there any lump in the axilla or in the supraclavicular region? This is about the lump. The second is the discharge. Remember, when you ask about discharge, certain things are there. One is whether it is a spontaneous discharge or it is a provoked discharge. Second is whether it is from a single duct or the multiple ducts. The third one is whether the discharge is serous, serosanguinous or multicolored. So which is more important in the discharge? Color.
Serosanguinous discharge.
Serous discharge in a postmenopausal woman is very, very dangerous. Remember, sanguinous, of course, they will be afraid of. And lastly, premenopausal or postmenopausal. Any discharge from a postmenopausal is always dangerous, right? Then the pain. So these four things, if you ask in the history, I think it nearly completes the history. Right?
Family history, again, you said no history of any cancer in the family. So what kind of cancers did you ask? Which side of the family it's important? What cancers you asked for?
Maternal side, ma'am.
Yes, very right.
Breast
Paternal
cancer.
also matters, but maternal is more significant. So what are the cancers you asked for?
Breast carcinoma.
Yes.
Pelvic tumors.
Pelvic tumors mean retroperitoneal sarcoma. It should not be generalized like that. So you want to ask whether any ovarian malignancy, breast malignancy, colorectal, right? And in a male members, pancreatic and prostatic cancer you have to ask. You have to be very specific in asking. Ovarian and breast cancer as well as endometrial cancer, all are estrogen-driven tumors. So that is the significance in asking family history. And maternal side is more important than paternal, as you rightly said. Correct.
Was asked about previous breast surgery on any benign breast disease he has suffered. And as madam told, you have to ask about uterine and ovarian malignancies in the patient itself.
See, again, whenever you are asking the history, just remember the things you read, like the risk factors, the modifiable and the non-modifiable risk factors. There are 8 modifiable risk factors. There are 8 non-modifiable risk factors. Remember those and incorporate in your history.
Okay.
Right?
Written no history of weight loss. Do you expect weight loss in CA breast patients? If you think this is CA breast?
No, ma'am.
Why not?
It's more common in GI malignancy.
Yeah, weight loss. In fact, obesity is an additional risk factor to develop CA breast. Can you tell me why? Why obese women are more prone to CA breast?
Increased estrogen, ma'am, due to
Where will you get the estrogen from?
peripheral conversion.
Very right. So there is peripheral conversion of steroids into estrogens in all the excessive fat cells. So obesity is a risk factor. So no need to talk about weight loss unless you think patient has got stage 4 overtly metastatic symptoms, and you talk about weight loss, right?
So as far as history is concerned, you have to give importance to risk factors, etiological factors, early menarche, late menopause, number of children, nulliparous, all these.
Modifiable and non-modifiable risk.
Sir and madam told about irradiation, ovarian malignancy, everything you have to include.
Okay.
Then purpose of history taking is to confirm the diagnosis of carcinoma and to stage the disease. All this information must be there in your history. After proper history taking, you can come to a conclusion about the diagnosis as well as staging, about the etiological factors.
Again, jaundice you have said. Jaundice is not very common. Why do you get jaundice in CA breast?
Late stage.
Yeah, it's basically end stage when more than 75% of the liver is replaced with metastasis. Of course, you should ask for completion, but you expect more of breathlessness, malignant pleural effusion,
bony
okay?
pain.
The ascites, hepatomegaly is what we should worry about. Okay.
Examination. The patient was examined under bright light after getting consent. Average nutritional status, pulse rate, vitals, pulse rate is 84 beats per minute. Blood pressure is 120/70. No pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy. Inspection. The patient was examined in sitting position with arms by the side. Lump visible in the right breast, upper inner quadrant. Circumferential nipple retraction on the right side. No eczematous changes on bilateral nipple areolar region. No nipple discharge bilaterally. No ulcers, scars, sinuses, or any skin changes seen. No supraclavicular fullness. On bending forwards, both breasts fall forwards equally. On raising both arms above the head, no skin puckering or change in color occurs. No axillary lump visible on both sides. On examination with arms raised above head, left contralateral breast appears normal. Palpation. No warmth and tenderness. A single 3x3 centimeter non-tender lump palpable in the right breast. In the upper inner quadrant, firm to hard in consistency with uneven surface and irregular margin is seen. Lump is fixed to the skin, but not fixed to the underlying chest wall. The contralateral breast appears to be normal and axilla appears to be normal. Single ipsilateral anterior axillary lymph node palpable of 1x1 centimeter, mobile, non-tender and firm in consistency. Systemic examination. Bilateral air entry normal. CVS, S1, S2 audible. Central nervous system. The patient is conscious and oriented. On abdomen, no organomegaly seen, no ascites. Summary. A case of 49-year-old postmenopausal female, P3A0L3, with a painless, gradually progressive right breast lump. For the past 2 months, on examination, there is a 3x3 centimeter non-tender, firm to hard right breast lump between right breast lump in the upper inner quadrant, fixed to the skin but free from underlying chest wall, with irregular margins associated with circumferential nipple retraction is seen. Single ipsilateral 1x1 centimeter anterior axillary lymph node is palpable. Diagnosis. A right breast carcinoma of staging T2N1M0 of stage 2B is seen.
You told there is a lump in the right breast, 3x3, right?
Yes,
in the upper outer quadrant. Why we are worried about the upper outer quadrant? Upper inner quadrant, huh?
Upper inner quadrant.
Because why it is very common in upper outer quadrant.
Axillary tail.
Nearly 50% of the breast tissue occurs in the upper outer quadrant.
Quadrant.
Another 20% in the central quadrant, right? The TDLU, what we are talking about, the terminal ductal lobular unit, 50% is in the upper outer quadrant. That's why. But here it is in the
inner quadrant.
Inner quadrant. So what we have to get worried about it? We'll discuss, right?
Palpation.
Even, okay. Mobility, sir, is asking, what are the 2 types of mobility of lumps in breast?
Intrinsic and extrinsic mobility.
Mobility, whatever mobility is there. No, you said skin is fixed. How do you expect the mass to be mobile? That's what I am asking. Is that skin is fixed? No.
Yes, sir.
The mass is fixed to skin. Then will it be mobile?
No.
Mobile here. Last line. Non-tender mobile.
Moves within the breast or with the breast?
Moves with the breast.
See, we are worried about fibroadenoma. CA breast. CA breast moves along with the breast.
Along with the breast. And fibroadenoma moves within the breast.
Did you mention anything about the so you mentioned about the affected side, right breast, right axilla, right supraclavicular fossa. After that, left breast, left axilla, left supraclavicular fossa.
She mentioned.
Then only it is complete. Both sides you have to examine.
Can you go back to the picture? You said there are no skin changes, no? Skin. Can you show the picture, Parth? Can you show the clinical picture? Model slide kaatanga. Munnadi. One more back. Yes. I can see a puncture mark there. I can see some reddish. Maybe because of the reflection, I don't know. But the skin over the swelling doesn't appear normal. It is definitely reddened. There is one more puncture mark or something there. So you have to mention all that. So what are the skin changes that will affect your clinical staging?
Ulceration, ma'am, satellite nodules, and
Yes.
pudy orange appearance.
So none of those are there. That's why you still put it as only T2.
T2.
So you're very right in saying that. But when you do the inspection description, please mention the skin discoloration. But it's not yet ulcerated because sir correctly asked, no skin, it is fixed. So it's difficult to comment on the mobility of the lump. So it's very important to tell the correct inspectory finding. Good.
What is this pudy orange due to?
Obstruction of the subcuticular lymphatics
What about dimpling?
due to the infiltration into the Cooper's ligament.
When you call the chest wall is involved. Chest wall is it?
In stage 4A, sir,
No, which structure?
in when it infiltrates intercostal muscles, ribs, and serratus anterior.
See, in examination, no, you should more concentrate on the TNM, like the tumor, node, and the metastasis, right? The size of the tumor, whether it is moving with the breast tissue or not. Is there any pectoral fixicity or a chest wall fixicity? Is there any skin involvement? And about the nodes, and you correctly mentioned, which group of nodes you examine?
Axillary group of
That is a spectrum of nodes. You must clearly say.
Level 1, 2, and 3, sir.
How clinically, how will you tell?
Level 1, level 2 is perioperative finding. Clinically.
Anterior or pectoral, posterior or
Lateral.
subscapular, lateral or brachial, central and apical node. These are all the group of nodes that lie in the axilla that we call as the either in the operative stage as levels or Berg's levels. Heard about Berg's levels? Right. Okay. So you must tell which group of nodes you palpate. For example, there is a specific way you have to palpate the central group. There is a specific way you have to palpate the apical group and the anterior group. Against which muscle you will palpate the anterior group?
Anterior axillary fold.
Yes. What muscle is there?
Anterior muscle.
Actually, hold from the what?
When you put the pectoralis muscle into contraction, when you ask the patient to press the arms on the hip, no, you check whether she's put the muscle correctly into contraction. Where do you check? The anterior axillary fold. So it is basically the pectoralis major.
Pectoralis major.
Posterior, like sir said, is subscapularis.
Subscapularis.
So I want to stress the point again about the staging. Tumor size is an important factor. Less than 2 centimeter, T1, something like that, right?
Yes, sir.
Tumor size is important. Then mobility of the tumor is important.
Yes, sir.
When the tumor is fixed to the chest wall, T4.
4A.
So mobility you have to mention. Then you are worried about 3 skin changes. What is that?
Pudy
Ulcer,
orange appearance,
pudy
ulceration,
orange,
and satellite
and
nodules.
nodules. That's all. You can make the staging. Other things for completion sake you have to mention skin tethering, skin puckering, redness, and all pectoral fixation. In the clinical examination, you have to mention, but they are not going to affect your staging system at all. Size, mobility, skin changes, ulcer, pudy orange, nodule. That's all. You can make. In addition to it, you have to examine the axilla for nodes. T and num over.
See, your tumor is in the upper inner quadrant. No, that's why you have to go for a percussion also. Parasternal percussion, second, third, and fourth intercostal spaces for the
Internal memory nodes.
yes, right. You have made a clear-cut diagnosis, the carcinoma of the breast. You put a staging also, very good, early breast cancer. But as undergraduate, you must try to give some differential diagnosis. What are the differential diagnoses you can offer in this case? Other than the carcinoma.
Traumatic fat necrosis.
Yes.
Sir. Giant fibroadenoma.
Right?
Chronic
Fibroadenoma.
breast abscess. Chronic breast abscess.
Chronic breast abscess, specifically what will you think of?
Antibioma.
Tuberculous mastitis can very much mimic a cancer, especially with the skin involvement that you said. No, it's very classical in TB mastitis. Giant fibroadenoma, what is the definition?
More than 5 centimeter.
Then what is the size of the tumor here?
3 cross 3 centimeter.
In this patient only sir asked. Don't tell theory answers here. With this patient, what will you think of as a DD? It's important to understand. So fibroadenoma, again, sir mentioned it has to move freely within the breast tissue. Don't bring fibroadenoma at all into the DD here. It has to be fat necrosis, any chronic abscess, especially
Abscess.
TB, mastitis, antibioma, all those things you should think of. Investigation. Okay, how will you proceed with this patient?
Triple assessment, ma'am. Clinical examination and
That is
radiological
done.
and
What is the next
pathological.
two left? Yeah.
Basic investigations.
No, you said triple assessment. You said first is clinical examination, radiological and
Histopathological.
so what are the radiological investigation you want?
Mammogram and USG, ma'am.
What do you expect to see in a mammogram? If you know, you can answer, please.
Architectural distortions, ma'am. Speculations,
good.
microcalcifications,
Yes.
and branching calcifications can also be seen, ma'am.
Very good.
Want to do unilateral or bilateral now?
Bilateral.
Bilateral always.
Always.
Always bilateral. Okay. So why do you want to add the ultrasound to it? You did say, no, you will do ultrasound also. What is the use of ultrasound?
In size of the tumor, ma'am.
Okay.
Extent can also be seen, ma'am.
Can tell you whether it's cystic or solid. Many
Cystic
times
or
we
solid.
think a firm lump is malignancy. It turns out to be a very tense cyst. Even in this postmenopausal lady, it's possible. And it'll tell taller than wider lesions. It'll tell the distortion of the architecture again. Calcifications, you cannot pick up on ultrasound. Very good. Suppose a mammogram is, how do you rate the lesion in a mammogram? What categorization they will give?
Biraj.
So what does BIRAD stand for and what do you expect in a malignancy? Breast
imaging,
imaging,
and
radiology and data system.
Data system.
Very good.
0 to 6, ma'am.
Hmm.
0 is negative. 1 is benign. 2 is
0 is you need further
further
evaluation or
investigation.
repeat. 1 is normal.
1 is normal.
2
2
is
is benign. 3 is probably benign.
Very
And
good.
4 is mildly suspicion of malignancy. 5 is highly suspicious of malignancy. 6 is confirmed malignancy.
So already biopsy has confirmed malignancy. You're doing the mammogram after that, which should be never done, but sometimes it happens in practice, right? Excellent. So suppose it comes as BIRAD's 5 lesion. So what would you do now? And it's only on one side of the breast. It's a single lesion. Opposite, sorry, not opposite. Sir will scold me. The left breast is normal. Okay. What will you do now? BIRAD's 5.
Core needle biopsy.
Very good. So it's better you do a core needle biopsy, if possible, an image guided, an ultrasound guided, because you want to go to the correct area and take the biopsy. What are the additional information you will get? Why not an FNAC?
ERPR status can be seen, ma'am.
Anything else? Very right.
Type of tumor can be seen, ma'am.
Excellent.
In situ or carcinoma can be.
Very good. Yeah. Super. Brilliant. You're doing better than PGs. Amazing. Okay. So we see hormone receptor status. And what are the other receptors? Is it ERPR? Any other receptors?
HER2 new receptors.
Anything else we see nowadays? A breast panel has almost 6 components to it. Okay, we see androgen receptors also, EGFR along with HER2 new, and we do something called a Ki67 index. That is a proliferative index. All this is done routinely now as a breast panel. Excellent. Suppose this comes as ERPR, HER2 new negative, Ki67 is 13%, AR negative, EGFR negative. How will you proceed next? And it's an infiltrating ductal carcinoma, not otherwise specified.
MR, modified radical mastectomy.
Straight away. What was your clinical staging?
Stage 2B, ma'am.
No, ma, T2,
T2,
N1,
M0.
Don't you want to confirm the M0? So what will you do?
PET CT.
PET CT straight away. Staging investigations pannanom sollanum. What is the staging protocol for early CA breast? It's okay, you're doing very well. Chest X-ray.
Pleural effusion, ma'am. And
very good.
USG abdomen.
What are you looking for in USG abdomen in this lady?
Ascites, metastatic ascites, ma'am. Pelvic tumors.
Ma, pelvic tumors, you're very fond of that word. It's a postmenopausal lady. You should look for liver metastasis, free fluid in the abdomen. Do you expect Krukenberg's tumor in this lady?
No.
Why not?
Postmenopausal age.
Seen in premenopausal. So don't talk about pelvic tumors, ovarian tumors in this lady. Okay, very good. Then everything is normal.
Skeletal survey for bones.
Skeletal survey, it's more for locally advanced breast cancer. Early breast cancer, if you do an LFT, ultrasound abdomen and a chest X-ray, which is normal, you can proceed to planning surgery. Okay, what surgical choices you will give to this patient?
Modified radical mastectomy.
Only that, huh?
No, you,
Followed by
there are 3 into 3 centimeters and a single node is there. It's positive by in ultrasound. So what are the various surgeries you can?
breast conservation surgery.
Yes.
Modified radical mastectomy followed by adjuvant radiotherapy.
Why radiotherapy? Okay, we are going at a PG level discussion, but because you're doing well, very nice. So breast conservative surgery, definitely you should offer, okay, provided you're able to give negative margins and you have to do an axillary dissection because the node is clinically palpable, that option or a modified radical mastectomy. So why radiotherapy, I wanted to know. Okay, radiotherapy only when more than 3 or 4 nodes are positive, when the margins are very close to the tumor, even mastectomy specimen. If it is LABC, we give radiotherapy. Not in this lady, you wouldn't expect radiotherapy. But what you have to give, I said ER, PR positive.
Hormonal therapy.
What hormonal therapy is preferred in a postmenopausal lady?
Tamoxifen.
Postmenopausal lady. Okay, it is usually the aromatase inhibitors, letrozole and all. Premenopausal, you can give tamoxifen. Sir, once.
What is the most important prognostic factor in CA breast? Lymph node involvement. You have to say whether the lymph nodes are involved or not. That is very important. So blind radiotherapy to axilla is not acceptable.
Okay.
You have to know, the status of the axilla. How will you know the status of the axilla? Only by axillary dissection. Axillary dissection will tell you how many nodes are positive. It tells you the prognosis. At least you do, if clinically no nodes palpable, radiologically no nodes palpable, in that case, at least you have to do
Sentinel lymph node biopsy.
Without assessing axilla, you cannot predict prognosis. Blind radiotherapy to the axilla is not acceptable. As madam said, if you remove the nodes, if nodes are positive, you can give radiotherapy. What is the problem with the axillary dissection? What is the complication you can get if you do axillary dissection? Lymphedema. So dissection and radiotherapy combination is again deadly. It will aggravate lymphedema. So your axillary dissection must be good. Unnecessary axillary dissection you have to avoid. That unnecessary axillary dissection is, how will you avoid that unnecessary axillary dissection? By sentinel node biopsy.
See, you are told, no, the 2 modalities of treatment. One is the breast conservation, another is the MRM. So, okay. Radiotherapy is indicated in breast conservation. Whenever you do a breast conservation, radiotherapy has to be given to the remaining breast tissue, right? Whereas in case of MRM, there is no need for an adjuvant radiotherapy, provided the nodal status or the margin positivity. When your resection margin is positive, you have to give radiation to the chest, the breast. Then with the axilla, more than 4 nodes or the extra capsular extension. 2 things where you have to give radiotherapy. I have already discussed.
What are the contraindications for breast conservation?
I wanted to ask that. Thanks. Contraindications for breast conservative therapy. When you will not think of doing that?
Locally advanced carcinomas.
Okay, we leave it. In this case, what will be the contraindications? What will you ask for or what will you check?
Lymph node.
See, breast conservation therapy means we are looking only at the lump. Axilla separate treatment, sir has already told you. Size of the size, it's called a tumor breast ratio. A small tumor and a large breast, you can easily give breast conservative therapy. Whereas a large tumor and a small breast, you cannot. So tumor breast ratio you have to look at. Then what are the other contraindications? See, sir said 100% you have to give radiotherapy to the patient following the breast conservative therapy to the remaining breast. If the patient already has got chest wall irradiation in the past, this time if you give radiation, the skin will break down. Or if they've got collagen vascular diseases, or they have got, or the patient is pregnant. Of course, not this lady. You cannot give radiotherapy. So these are the contra. And when you think that you cannot achieve negative margins, you remove it, the margin becomes positive once, twice, then no other option but to do a mastectomy in those patients. So this you should try to remember. Okay. Any other adjuvant therapy? You said we talked about hormonal radiotherapy. So what is the role of chemotherapy?
Chemotherapy.
What are the indications? And what chemotherapy commonly we give?
CAF regimen.
What is CAF?
Cyclophosphamide, adriamycin, and the 5-fluorouracil.
Okay. Okay, very good. So what are the indications for chemotherapy?
In case of any positive margin.
Positive marginal. Even if the size of the tumor is more than 0.5 to 1 centimeter, you have to give chemotherapy. So this lady is already a candidate for chemotherapy by sheer virtue of the size of the tumor.
Remember, when you ask about chemotherapy, don't never say CMF regimen, because in our institution, what we follow, you must try to understand, no? It is 4AC and 4T. What is it? 4AC means 4 cycles of adriamycin
And
cyclophosphamide, followed by 4 taxanes, right? This is what we are following, not the old CMF regimen, right?
We discussed about surgery, MRM, breast conservation therapy. We discussed about radiotherapy. We discussed about chemotherapy. Hormone therapy, you mentioned about ERPR status, postmenopausal woman. What is the treatment?
Aromatase inhibitor.
Inhibitors. What about Herceptin? HER2.
Trastuzumab can be given, sir.
That also you have to remember.
Nowadays, more than the TNM, there is a molecular basis of classification of the breast cancer. You know any idea about it? Luminal A, any idea?
Luminal A, luminal B, and basal type.
Yes, very right. So 4 types, no? Luminal A, B, HER2 new enriched, and then basal or the triple negative. Very good. Any specific side effect of CAF that sir was telling? No, you don't say like that. But what is the specific side effect of cyclophosphamide and adriamycin? You can tell us. Specific side effect. Everything will suppress the bone marrow. Don't tell me that. Before you do chemotherapy,
cystitis, hemorrhagic.
Very good. C for cystitis. Remember that.
Hemorrhagic
Cyclophosphamide, hemorrhagic cystitis. Adriamycin. The clue is everybody gets an echocardiogram done before the chemotherapy. It's cardiotoxic. Okay. 5-fluorouracil, of course, it's toxicity to all epithelial cells. Thank you very much. I think you did extremely well, both of you.
See,
all the best.
You've been called to present at the end stage. Very nicely presented, though the slides are not of your own. I appreciate both of you from Stanley Medical College.
Sir, I should put some facts to you, senior examiners here. These girls were given case 10 minutes before they come up to the stage, sir. And actually, it was like a real exam for them. So
they have done very nicely.
I think distinction to both of them.
It becomes
sir.
a medal exam now.
Yes,
From UG
absolutely.
Exam to medal
They
exam.
went to the level of PG discussions.
PG
sir.
level
It's
they have
amazing.
presented.
Amazing students.
Very nice.
All the best.
I request
All the best.
faculty to hand over the certificates. Excellent, Ba. And I think we should give a big round of applause to Geetanjali and Harini. Stanley rocks. Now we move on to the next session. We have a few lectures coming up in between. So friends, there is not going to be an official tea break. You can go collect and come back so that we want to save time to give you more academics. So we have the most eminent teacher from Sri Ramachandra Medical College, Professor S. Saravanan sir. The next important exam case is your right iliac fossa mass for the UGs. So we request Saravanan sir to come up to the stage to give his talk how to approach a case of right iliac fossa mass. For that, I request Dr. Sagayam Inbasegar sir and Dr. Tangamani sir to chair the session, please. Sir, Sagayam sir and Tangamani sir, please come up to the stage. Ramya ma'am, I think I will also request you to continue the chairing for the session. Yes, yes, yes. Manoharan sir. Manoharan sir is here. So there are followed by Dr. Tirunavakar is going to speak about on soft tissue tumor, and again Professor Kannan sir on salivary gland tumor. So, sir, next sir, kindly load your PowerPoints, please. So we request the faculty chairpersons, we will limit the sessions to 15 minutes each talks. I will inform you, sir, when it is 15 minutes. Good luck to you, sir.
So good morning, everyone. First, I would like to thank all the dignitaries here and the chairpersons over the dais for giving me this opportunity to talk about approach to RAF mass. Hope I am audible. Yeah, thank you. Yes. So RAF mass, so it's a right iliac fossa mass, is a very important exam, it's a clinical examination case. Okay, I think, we need to have a very good understanding of RAF mass. Next slide, please. Hello. Yeah. So because time is ticking, I have only 15 minutes, and it's quite a large topic to cover. So I know, as you all know, this is a very small space actually, which is bounded by the transtubercular line and the right midclavicular line. It's actually a very small space, and most of the times, it impinges onto the nearby quadrants. Next slide, please. Next slide. No, can I have somebody? That's the next, sorry. Yeah. So, if you actually look at, keep clicking. So if you actually look at the RAF area, there are so many structures which are there right from the skin, from the front to the back. There are so many structures, right from the parietal wall. Can I keep clicking it? I can't do it. We have a pointer over here, so that I can do it over here. A slide changer. Sir, keep clicking it. So we have the parietal wall, the appendix, the cecum, ileum, mesentery, lymph nodes, retropaternal connective tissues. Keep clicking, please. The iliac arteries, iliopsoas sheath, ileum, kidney, undescended testis, tubo-ovarian mass. I think, no, I can't control it, right? No way. Thank you very much. Okay, fine. So these are the various structures which are present in this small area. So, and we can have masses arising from any of these structures. So that is how we need to look at it. Okay, and one is a knowledge of the various structures in that area. And the next is you need to probably group them into GI, urological, and then based on the symptoms, you arrive at the correct organ of origin. Next slide, please. So if you look at the history, the most important thing is age. Somebody, who is of a younger age, more likely to be appendicitis and an appendicular mass. Somebody who is elderly, highly likely to have a cecal growth. Second is the duration of mass. Somebody who has a short duration mass is more likely to be an appendicular mass. And again, even a cecal mass. And associated symptoms like pain. Pain is more prevalent in an appendicular mass to start with. And in a cecal mass, hardly you find any pain associated with it. And also presence of fever, the bowel habits, loss of weight, and loss of appetite. Every aspect of your history is very, very important. History is something, now gradually, clinical science is dying and, people are writing obituary for clinical science. I think, we can't leave it at that. I think, it has to be revived. Clinical science is very, very important, though imaging and all those things have overtaken clinical science. It is imperative that as young surgeons here, we need to take control of the clinical examination. Clinical history is very, very important. And the characteristics, the mass on examination, and finally surgery. Can you tell me some surgery which can give rise to a RIF mass? Any surgery in the past? Anyone? Anyone? Okay, fine. So if you have a history of a cholecystectomy, no, though it has got a very, very, very moderate risk. It is one of the risk factors which has been found to be associated with a colonic growth. So I think, when somebody has history of cholecystectomy in the exams, definitely they will ask you. If somebody comes with the history of cholecystectomy, the examiner is going to ask you what is the relevance of a cholecystectomy to an RIF mass. So because of the biliary salts, exposure to biliary salts, you can have colonic carcinomas are higher, and that too right-sided colonic masses are higher when you have a history of cholecystectomy. And again, when somebody has undergone an appendicectomy, and there's a chance that it might be a mucocele. Okay, so if you don't do a proper appendicectomy and you leave behind some of them, you can have an RIF mass developing in such patients. So next slide, please. So, and again, in general examination, if somebody has a tachycardia, so then appendicular mass to be suspected, and all the more appendicular abscess. And when you have high fever is present, again an appendicular. When you have an emaciated bill, somebody who is losing weight, a CA cecum or a ileocecal tuberculosis has to be considered. Somebody presenting with pallor, a carcinoma is likely. And as you all know, the difference between a right colonic growth and a left colonic growth is the right colonic growth presents with just anemia and mass, with no obvious GI symptoms. So you have to be aware when somebody has a right iliac fossa mass and associated anemia, definitely you need to consider a cecal carcinoma as an important DD. So when somebody has icterus, it could be due to hepatic mets from the seed. When you have clubbing, think about tuberculosis and inflammatory bowel disease. And when somebody has cardiomyopathy, generalized, think of tuberculosis, and definitely look for supraclavicular lymph node, and that tells you the possibility of a carcinoma. Next slide, please. And on abdominal examination, this is the most important thing by which you can differentiate the three most important causes of RIF mass, which are appendicular mass, ileocecal tuberculosis, and CA cecum. So which is when you have a regular ill-defined mass. Many a times, students confuse the regular mass from a defined mass. People think when something is irregular, it is ill-defined. It is not. The classical example I always give is a karungal, the gravel which we use on the road. It is irregular in shape, but you can actually define all the borders. Okay, so you need to understand what is ill-defined and what is well-defined. And regular is different. A classical example is an appendicular mass. When you actually palpate it, it'll appear nice rounded. But when you actually try to find out the borders of these mass, you will not be able to find it at all. Because it is basically a mass formed by various structures covering the appendix. So when you have a regular ill-defined mass, it is appendicular mass. When you have a regular well-defined mass, it is ileocecal tuberculosis. When you have an irregular but well-defined mass, it is CA cecum. Next slide, please. Okay, so with this, these are the various masses which can occur in the RIF, right from the parietal and the intra-abdominal and retroperitoneal. I think we have discussed it. We'll just skip 1 minute. In this, the most important thing is how examination is very, very important. Imagine if you don't look at the genitalia of a patient in an RIF mass, and if there is an absent testis on that side, you're going to miss an undescended testis. So it is very, very imperative that you go through the history and examination. Pakka, don't leave out even one simple point, because each single point is going to give you a clue towards your final diagnosis. Next slide, please. So again, we'll more concentrate on these three, which is the appendix, the ileocecal tuberculosis and the CA-cecum. Next slide, please. So when it comes to investigations, when you have a low hemoglobin, definitely carcinoma has to be considered. Okay, and that is why a patient, Western countries, they have proper screening protocol for colorectal carcinomas, where at 50 years of age they start doing a fecal occult blood test, which we rarely do here. I think it's high time we also start doing a FOBT, because that is going to pick up malignancies like these. Second is when you have high TC, appendicitis is a possibility. When you have high polymorphs, appendicitis. When you have more lymphocytes, think of tuberculosis. And finally, do a chest X-ray to rule out pulmonary tuberculosis and also sometimes from carcinoma of the cecum. Next slide, please. So again, the most important investigation. Now CT has taken over. I think, being in Chennai, we have access to CT scans. And CT scan is going to clinch your diagnosis, okay, with a contrast enhanced CT. But still, ultrasound is the initial investigation which will be needed in cases of abdominal masses, which will tell you about the mass, the ascites, the nodes, and the liver, while CT scan is going to give you better features of the mass and ascites, and bowel is made out only with the CT. And ultrasound is not good at picking up bowel lesions. And nodes and pelvic deposits can also be picked up. Next slide, please. Okay, so this is an ultrasound picture showing a CA-cecum. Next slide. And this is an appendicular abscess, which is again beautifully picked up by a CT scan. Next slide, please. And this is a CA-cecum, and associated small bowel obstruction is also there in this case. Next slide. And barium enema. So definitely, as examiners, we are very much interested in barium enema, though practically we don't do it much. This is not done much today towards diagnosing RAF masses. And you all know about apple core deformity, which is seen in carcinoma of the colon, napkin ring deformity, tuberculosis, string sign of Cantor, again Crohn's disease and ileocecal tuberculosis, pulled up cecum, ileocecal tuberculosis, and internal fistulas. All these things can be made up using barium studies. Yeah, and again, that is a classical apple core deformity on this side, and you can see the string sign of Cantor on the other side. Next slide, please. And colonoscopy. So though your imaging is going to give you the diagnosis, but you need histologically to prove it, and colonoscopy becomes very mandatory. And this is the colonoscopic picture of a tuberculous lesion. And again, you need to take biopsies from it. Next slide. And this is a ulcerative growth in the cecum. Next slide, please. And this is a proliferative lesion, which is the most common type in the right colon, right? We have more of proliferative cauliflower-like growth, while on the left side, you have the stricturous rounded annular growth that gives you the various features, the contrasting features between a right colonic growth and a left colonic growth. Next slide, please.
Sir, 4 more minutes.
4 more minutes. Thank you, sir. Actually running like an express train. Okay. Otherwise, this is not the way I actually run a clinical class. Anyway, so appendicular mass, we all know that, it follows acute appendicitis, and around 5% of the patients, they develop an appendicular mass. Any age group, it can be there. It is formed by greater omentum, cecum, appendix, and terminal ileum. Next slide, please. Yeah, thank you. So, and we all know about Oshner-Sheron's regimen. Definitely, it will be asked in the exam. The most important thing is analgesics, antibiotics, antipyretics, bed rest, and you need to chart of the mass. That's very, very mass size has to be marked. And diet, nil by mouth. I'm not a great fan of nil by mouth, but anyway, traditionally nil by mouth is there, and now with all these nutritional aspects coming into view, nil by mouth can be kept minimum, and IV fluid maintenance is there. And interval appendicectomy is done after 3 to 6 weeks of conservative management. This is mainly to prevent recurrent appendicitis, and probably if you have missed something else, it is a chance for us to find out. And what's the current trend now? It's not always that you need to go for a conservative management. If it's an early mass, and there are a lot of evidence towards doing laparoscopic appendicectomy in the early stage. This one that is little later, then we can go in for an Oshner-Sheron regimen. Next slide, please. So appendicular abscess, definitely, you have swinging pyrexia. And the most important thing is you do either a percutaneous drainage or an extraperitoneal drainage followed by an interval appendicectomy. Next slide. And this is an appendiceal tumor. I hope you can see here. See from there. You can have a mucosal, you can have a carcinoid or an epithelial tumor. If it's a mucosal, it is very, very important you do an en bloc resection. You cannot allow the content to be spilled out. So you have to do an en bloc resection. If it's a carcinoid, it depends on the size of the lesion. If it is less than 1 centimeter, appendicectomy will suffice. If it is more than 2 centimeters, you have to do a right colectomy. If it is locally advanced, you need to add a cytoreductive surgery. And when you have METs, this is one case where you can do a liver resection. And next is epithelial tumors. It can be pseudomyxomas or adenocarcinomas. When it is non-perforated, then appendicectomy would suffice in a pseudomyxoma. When it is perforated, you need to add hypothermic intraoperative chemotherapy. And when it is, again, when you have a pseudomyxoma peritonei syndrome, then you need to do a sugar baker's technique where you do a complete peritonectomy and also add a hypothermic intraoperative chemotherapy. And adenocarcinomas, when it is non-perforated, right colectomy. When it is perforated, you add a hypothermic chemotherapy. And when it is with peritoneal metastasis, then you do a cytoreductive surgery. Next slide, please. So ileocecal tuberculosis, it can, by many ways, it can reach the GI. It can come by hematogenous route, infected sputum, and direct from adjacent organs, and also lymph nodes channels it can come. Next slide. And why is ileocecal region is more favored? Because there is an increased physiological stasis, there is increased rate of fluid and electrolyte absorption, minimal digestive activity, and abundance of lymphatic tissue. So these are the reasons why ileocecal is more preferred for development of tuberculosis. Next slide. So RAF mass, sometimes it presents with features of obstruction and rarely it perforates. Next slide. So we have recurrent attacks of abdominal pain, and as I told you, pulled up cecum string sign of Cantor, and it is sometimes difficult to differentiate from carcinoma, and a colonoscopy will pick up the diagnosis. If there is ascites, you do cytology and adenosine activity. Next slide. So, and you do sometimes a limited right hemicolectomy if there is obstruction. Otherwise, an antituberculous treatment would suffice. Next slide, please. And when it is CA cecum, usually they are age more than 40, anemia, asthenia, anorexia, and a presence of a hard, irregular, well-defined mass is there in case of a CA cecum. Next slide. And that is a CT picture showing a CA cecum. Yes, next slide. And the treatment is a classical right hemicolectomy. Okay, next slide. And amoebic typhlitis, it rarely presents with a mass. Sometimes it can present with a mass. And usually in endemic areas, alcoholic history of diarrhea is there. And there is repeated amoebic invasion. It is very difficult to differentiate from CA without biopsy. Next slide. 2 more slides, ma'am. Crohn's disease, again, this also rarely only presents with a mass. So when it presents, it is confirmed by CT and colonoscopy. Conservative management by immunosuppression is done. And these are, when they are fistulizing, you add infliximab to it. Next slide and the last slide. So actinomycosis is a very rare disorder which can also present with an RAF mass. But the thing is, it will be a hard mass in the right iliac fossa with multiple sinuses, and you have sulfur granules. And sometimes it follows appendicectomy, and antibiotic therapy and surgical excision can be done. Thank you very much for this thing. I think, I ran very fast. I hope I have tried to cover as much as possible. Thank you.
Thank you, Dr. Saravanan. I think it was really excellent in the sense you have covered everything and within the given time. So I hope the students appreciate that it's a absolute lovely DD of the right iliac fossa mass, both the clinical and the treatment part of it. Thank you very much. Any questions, you can interact with Dr. Saravanan during lunch break and sort it out.
Thank you.
Sir?
Thank you very much. And thanks everyone for the opportunity. Thank you.
Since we are short of time, we proceed on to the next talk.
Morning. Next lecture would be on soft tissue sarcoma by Professor Dr. Tirunavukarasu. He is a faculty in Kilpack Medical College, a well-known colleague for most of us. and popular surgeon among students and colleagues also. Please do take over, sir.
Good morning, one and all. First of all, I thank the organizers, Chennai Chittipuram office bearers, for the opportunity. How many of you have seen the soft tissue sarcoma in your clinical posting? Can raise your hands. Only one. Two. Okay. So soft tissue sarcoma is a rare tumor. 2 to 4 per 1 lakh population. It constitutes 1% of the malignancy. We have to know some differences between carcinoma and sarcoma. Carcinoma arises from epithelium. Sarcoma arises from mesenchymal stem cell. Okay. Carcinoma more common in older age group. Sarcoma common in younger age group. Carcinoma, it is stage-wise manner it progress. Normal cell, dysplasia, severe dysplasia, carcinoma in situ, then carcinoma. But sarcoma arises de novo. Carcinoma spread by lymphatics. Sarcoma spread by hematogenous spread. With this, I am starting. Next. Sarcoma can arise from bone or soft tissue. Osteosarcoma is the commonest sarcoma. Soft tissue is the tissue that connects, surround, and support the skeletal system, which is non-epithelial extraskeletal tissue, excluding reticuloendothelial system, glial tissue, but it also includes peripheral nervous tissue. Embryologically, it is mainly from mesoderm, but few from neuroectoderm. Next. It constitutes 1% of adult malignancy and 15% of pediatric malignancy. Incidence according to the site, 35% occurs in the lower lung. It is the commonest site. 15% in upper limb, 15% in retroperitoneum, 10% in trunk, 15% in viscera, 10% other areas. Next. Soft tissue sarcoma present in the following syndromes: von Recklinghausen disease, Gardner syndrome, Goldin syndrome, tuberous sclerosis, basal cell nevus syndrome, Lee-Fraumeni syndrome. It is associated with the chemicals are PVC, tetrachlorodibenzoadioxane, arsenic, vinyl chloride, thorostat. It is associated with the viruses are HIV and cytomegalovirus. Ionizing radiation is one of the important etiological factor. Lymphangiosarcoma in post-mastectomy lymphedema, that is towards Treves syndrome. Next. Special features of the soft tissue sarcoma are they are much more aggressive, rapidly growing tumors. It occurs in younger age group compared to carcinomas. They are not encapsulated, but often have pseudocaps. They spread through blood, especially to lungs and also to the other organs. Next. Any painless lump greater than 5 centimeters. It is deeper to the deep fascia. You have to think of soft tissue sarcoma. On examination, it is smooth, firm to hard in consistency, warm because of the increased vascularity. Features of secondaries in the lung are cough and hemoptysis and chest pain. Lung is the most common state of secondary. Next. Sarcoma spread by blood spread. Lymphatic spread is very rare. The mainly spread is lung. Extremity sarcoma spread to the lung. Visceral sarcoma spread to liver. Next. 5 to 10% of the sarcoma spread by lymphatics. The sarcoma spread by lymphatics are epithelitis sarcoma, pediatric rhabdomyosarcoma, clear cell sarcoma, myxofibrosarcoma, angiosarcoma. Next. Sarcoma is named after resemblance of the cell which is present in the tumor, not by the cell of origin. All the sarcomas are cell of origin is undifferentiated mesenchymal cell. For example, synovial sarcoma, if in your examination, what is the origin? You should not tell from the synovium. Cell of origin is mesenchymal stem cell. If the fat cells are present, it is liposarcoma. If fibroblast present in the histology, that is fibrosarcoma. Histiocytes are present, malignant fibrous histiocytoma. Smooth muscles are present, that is leiomyosarcoma. Skeletal muscles in rhabdomyosarcoma. Chondroblast in chondrosarcoma. Blood vessels in angiosarcoma. Next. Liposarcoma is one of the commonest soft tissue sarcoma. It is present in the thigh, retroperitoneum, back and shoulder. Microscopically, it contains lipoblast with signet ring malignant cells. It is low grade type. Treatment is wide local excision followed by radiotherapy. If needed, the margin positive, we have to go for radiotherapy. Next, subtypes are well differentiated, dedifferentiated, mixed-site, round cell type, and pleomorphic. Other than well differentiated, the dedifferentiated, mixed-site, round cell, pleomorphic are more prone for distant metastasis. Next, fibrosarcoma common in deep soft tissues of lower extremities with intact overlying skin. Spindle fibroblast with the herringbone pattern are typical on microscopy. Fibrosarcoma is slow-growing tumor which attains large size. It compresses or infiltrates the adjacent structure like neurovascular bundle. Next. The subtypes are well differentiated, poorly differentiated, dermatofibrosarcoma, protuberance, aggressive fibromatosis. Next. Malignant fibrous histiocytoma. This is the one. Previously, this was the commonest soft tissue sarcoma, but not now. Now, liposarcoma is the commonest. The name is changed into what is the present terminology for the malignant fibrous histiocytoma? UPS. Undifferentiated pleomorphic sarcoma. That is the present terminology for malignant fibrous histiocytoma. UPS classified under undifferentiated unclassified sarcoma. MFH is one of the most common soft tissue sarcoma in adult. Lower extremity is the most common. It is present as solitary multilobular lesion. It spreads along the facial plane or between muscle fibers, which is probable reason for local recurrence. Types include mixed-site, giant cell, inflammatory, angiomatite, pleomorphic. Next. Next. Leiomyosarcoma. Cut section shows world appearance. It is common in retroperitoneum and viscera, but can occur in limbs and skin. Uterus is also common size. It can occur in the piloerector muscle of skin, inferior vena cava, pulmonary artery. Desmin and actin are the most common immunohistochemical strains. Next. Rhabdomyosarcoma, it is most common in children. It can occur retroperitoneum, pelvis, and genitourinary tract. More aggressive tumor with poor prognosis. Next. The subtypes are pleomorphic, embryonal, patrioidal, alveolar. Pleomorphic is more common in adult, embryonal more common in children. Next. Chondrosarcoma, it attains larger size with slow growing nature. Common sites are ribs, flat bones. Next. Angiosarcoma, the most important primary sites are trunk, head, and neck. Next. So how will you assess the extent of the tumor? MRI is the gold standard for soft tissue sarcoma. It determines the vascularity relation to the vessel and facial planes. Soft tissue delineation is very well given in MRI. CT scan also can be used to see the extent of the invasion, but not equivalent to MRI. Advantages are easy availability, relatively cost effective, best to determine bone involvement, useful for guided biopsies. Ultrasound is less sensitive investigation. It is useful in extremity lesion to assess vascular system. It is initially first investigation done in GI sarcoma, retroperitoneal sarcoma. Next. How will you evaluate the metastasis? Chest X-ray is enough for the low-grade sarcoma. Chest X-ray alone enough for the low-grade sarcoma. CT chest is ideal to see early lung secondaries. PET scan or integrated PET scan with the CT is often useful to identify metastatic diseases. Ultrasound abdomen is sufficient to check liver secondaries, but CT abdomen may be better choice. Next. In tissue diagnosis.
You got 5 more minutes.
Okay. Incision biopsy is the ideal tool to control sarcoma histologically. True cut biopsy, core needle biopsy is an acceptable first diagnosis step. It is technically easier, not costly, but it is not useful in visceral soft tissue sarcoma. Again, if it is inadequate, one should not be hesitant to go for incision biopsy at the earliest. Excision biopsy is done only in sarcoma less than 3 centimeters, which is cutaneous or subcutaneous in location. FNAC is of less value in soft tissue sarcoma. It is significant only if it is positive. It is useful in local or distant recurrence in documented sarcoma patient or to evaluate nodal status if enlarged. Next. Incision biopsy. Incision biopsy is the most reliable method of diagnosis. It provides adequate tissue sample. Incision should be placed such a way that it can be included in wide tumor excision at later period, as biopsy tract is always contaminated. The advice is the surgeon going to do the future surgery should do the incision biopsy, not other persons. One should achieve absolute hemostasis to avoid hematoma as tumors are vascular. Proper site of incision biopsy should be decided. One should be a shortest possible route should be selected. Next. Smallest longitudinal incision is used to provide adequate specimen. Transverse incision is contraindicated. Minimal tissue disturbance and avoiding raising flap are crucial. One should avoid crushing, destroying the specimen. Drains are not used routinely in incision biopsy. If used, exit near, close to the wound and not away, distant from the incision biopsy wound. Next. This is the longitudinal incision we should make. We should avoid the transverse incision. Next. These are all the some stains. Immunohistochemistry stains are used: CD31, CD34, CD59, CD99, desmin, vimentin, S100, cytokeratin. Next. Staging for head and neck and other extremities different. Head and neck, T1 is tumor less than 2 centimeter. T2 is tumor 2 to 4 centimeter. T3 tumor greater than 4 centimeter. T4 tumor with invasion of adjacent structure. Next. N1 is regional lymph node metastasis. There is no stage grouping for head and neck. Next. Extremity sarcoma, T1 tumor less than 5 centimeter in greatest dimension. T2 tumor greater than 5 centimeter and less than 10 centimeter in greatest dimension. T3 tumor greater than 10 centimeter, less than 15 centimeter. T4 tumor greater than 15 centimeter. Next. Next. Grading is given weightage in sarcoma staging. G1, G2, G3. G1 is some scores are given. G1 2 to 3, G2 4 or 5, G3 6, 7, 8 comes under G3. How this scoring system in grading system? There are 3: mitotic and differentiation, necrosis are taken into account. Next. Differentiation score 1, 2, 3. Next. Mitotic account 1, 2, 3 and necrosis score 0, 1, 2. Altogether, it is total score is 8. Next. In stage grouping, we have to notice if the node is positive in the sarcoma, it comes and directly goes to stage 4. And some weight is given to grading also. Okay. Next. Surgery is the mainstay of treatment modality. Neoadjuvant chemotherapy, perioperative, postoperative RT also play a major role. In low-grade tumor, if the tumor is less than 5 centimeter, wide local excision alone enough. If the tumor is high-grade tumor less than 5 centimeter, wide local excision, if you are done 1 centimeter clear margin, that is enough. If your margin is less than 1 centimeter, you have to go for EBR. Next. Next. In high-grade tumor, which is between 5 to 10 centimeter in size, functional limb sparing are complete wide excision, perioperative brake therapy or post-operative EBRT is given. In high-grade tumor, more than 10 centimeter in size, initially neoadjuvant chemotherapy followed by wide local excision, then EBRT. Next. In sarcoma surgery, we need to understand some of the terminologies. What is clear margin? That is R0 resection. There is no positivity in the margin. Dirty margin, if you are doing R1 or R2 resection, you will get dirty margin. Tumor positivity in the margin. What is intralesional excision? Done in inside pseudocapsule, very high recurrence rate. Intralesional excision is you are going through the tumor. Marginal excision, you are going through the reactive zone. Recurrence rate is high again. Wide local excision, this is the now treatment protocol in the all the sarcoma, wide local excision. Means en bloc resection done through normal tissue beyond the reactive zone. It means if the margin is less than 5 centimeter, tumor is never visualized during surgery. It has recurrence rate of 30%. Wide margin is classified as adequate if margin is at least beyond 1 centimeter outside the reactive zone, or inadequate if the margin is within 1 centimeter. Next.
Any more slides, sir? How many more slides? The time is done.
Previously, compartment excision was done. Now it is not done. The treatment is wide local excision. Next. Next. This is the tumor. Then next one is reactive zone, intralesional excision. If you are going through the lesion, that is intralesional excision. If you are going through the reactive zone, that is marginal excision. If you are going through the normal tissue, that is wide local excision. Next. When will you do amputation? In major neurovascular encasement, bone involvement, multiple compartment involved, limb itself is disease like lymphedema, recurrence with multicentricity. Previously, 20 years ago, amputation was the treatment. Amputation rate was very high. Now it is very much reduced. Next. Radiotherapy, it is mainly radiotherapy alone, not very much useful, but combined with the chemotherapy and radiotherapy, post-operative radiotherapy, it is very much useful. Next. 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 Chemotherapy, VAC regimen and MAID regimen. Post-operatively, it is used. VAC regimen is vincristine, adriamycin, cyclophosphamide. MAID regimen is mesna, adriamycin, ifosfamide, decarpacin. Next. Neoadjuvant chemotherapy is used to make primary tumor better operable. It makes eventual surgery better, provides early treatment for micrometastasis, gives idea about the response for chemotherapy. Drugs used are adriamycin and ifosfamide. Next. The prognostic factors are, these are all the bad prognostic factors. Size greater than 5 centimeter, high grade, more than one compartment involved, deep tumors and multicentric neurovascular invasion, lung secondaries, and dirty margin. Next. If you concentrate in this slide, you can write X-ray. If you know this mnemonic, yes, size plays a major role in the prognosis and also in the management. You have to know the anatomical landmark, where it is arising from. Is it a subcutaneous or intramuscular or from neurovascular bundle or arising from bone? Regional nodes, whether the regional nodes are there or not, you have to know. If the regional nodes are involved, directly it goes to stage 4. Compressive effects are there or not, you have to know, decide preoperatively neurovascular bundle is involved or not. By clinically, you can examine distal, is there any neurovascular deficit is there or not. Metastasis. We have to rule out that metastasis and amputation is needed or not. We have to decide. Okay, thank you.
Thank you, Dr. Thiru. Very detailed material packed up in the allotted time. Thank you so much.
Thank you. The next speaker is Professor Kannan from Madras Medical College. He'll enlighten us on salivary gland tumors.
நான் கொடுத்தேனே PPT. ஒரு பென் டிரைவ் கொடு.
I think Professor Kannan sir needs no introduction. He is a former director of Institute of General Surgery, a reputed institute. Welcome, sir.
So, good afternoon. I'll be talking about the neoplasms of salivary gland. You can see the picture, no? Such a huge salivary gland, parotid swelling. I saw this patient in Stanley Medical College when I was an assistant professor. Because it is slow growing, painless, and the patient is afraid of surgery, right? Somebody would have told that they will undergo surgery, means they will have a facial palsy. So they will try to avoid surgery. It's such a huge swelling. That's what we call it as twin head appearance. Another terminology in the newer Bayesian law, twin head appearance. Next slide. So it's a heterogeneous group of tumors, but remember it's very, very rare, less than 3%. Benign tumors are more common than the malignant counterpart. Next slide. It's common in the 4th decade, equal in both sexes, but what we commonly see is the pleomorphic adenoma. It's a little bit common in women, whereas Warthin's tumor is very common in smokers and especially elderly male. Next. As any head and neck tumors like the thyroid or the breast, this also there is an etiological factor like radiation exposure. When you think of Warthin's tumor, elderly males, smokers, as well as sometimes 10% it is bilateral also and lower pole. Remember these things. Then the viral infections like Epstein-Barr virus, cytomegalovirus, polyomavirus, even hair dyes in beauty salons are all the etiological factors. Woodworking, nasopharyngeal carcinoma. So big list given in the new Bayesian law. Pleomorphic adenoma. Then you remember Warthin's tumor. The third one is oncocytoma and the fourth one is basal cell adenoma. Just remember these 4, that is enough. When you consider the malignant counterpart, remember the mucoepidermoid carcinoma, which is more common. Next is the adenocystic carcinoma, acinic cell carcinoma, then the ductal adenocarcinoma, squamous cell carcinoma. Other than that, you need not worry about it. Next slide. So we grade them as the high grade and the low grade tumors. High grade mucoepidermoid tumors, salivary duct carcinoma, adenocystic carcinoma. Whereas low grade, you have the low grade mucoepidermoid carcinoma and acinic cell carcinoma. Next. There is a rule of 80 commonly seen in the parotid. 80% are benign. 80% of the parotid tumors are pleomorphic adenoma. 80% of salivary gland pleomorphic adenomas are in parotid. 80% of the parotid pleomorphic adenoma occurs in the superficial lobe, and 80% of untreated tumors remain benign. That's why they come very late. Next slide. The commonest tumor, the pleomorphic adenoma, occurs more in the females. Parotid is more involved. Remember, the parotid is divided into a superficial lobe and the deep lobe. There is a plane that divides it, called the faciovenous plane of Patty. So it occurs more commonly in the superficial lobe. Malignant transformation is very rare. Next slide.
painless, well-defined mass, which is mobile. See, you can have a swelling in front, below and behind the earlobe, lifting the earlobe. But remember, you can have a cheek swelling also presenting as a parotid swelling, as well as a paratonsillar bulge. When there is a deep lobe enlargement, you can have a paratonsillar bulge also. Remember, whenever you think of parotid tumors, it's ectodermal in origin. They will say you must either do a superficial parotidectomy or suprafacial parotidectomy, conserving the parotid gland, the facial nerve. Why the facial nerve is incorporated into the swelling, the parotids? That is, the encapsulation occurs later in salivary gland, especially the parotid. That's why the nerves and the vascular structures, they develop before encapsulation. So it is incorporated to the parotid salivary gland. That is why it's very, very difficult for us to do without leaving even a small bit of the tumor. That's why they say you have to go for a superficial parotid, that is removal of a whole superficial lobe. If there is involvement of deep lobe, you have to go for total conservative parotid. Next. In examination, see here also, it's also ductal cells are the most important involved in but you can also have the mesenchymal component also, either cartilaginous appearance or osteoid appearance can also occur. That's why it's called as mixed parotid tumor or pleomorphic adenoma. Next slide. I told you the another picture in the bilineal lobe, the twin head appearance. Next slide. Next slide. Next slide. So malignant transformation. So long duration presence of a tumor, sudden increase in size, or either it becomes painful, it becomes harder in consistency or variable in consistency, fixed to the underlying structures like masseter, as well as the mastoid tip, involvement of facial nerve, lymph node involvement, restriction of the jaw movements, and other histological changes, differentiate it from the benign to the malignant. Remember the word carcinoma ex pleomorphic adenoma. That means when you take a slide, both the benign and malignant component are present in the same slide. That is, the benign malignant tumor has converted into a malignant tumor. Also, you have traces of the benign tumor in that. That's why it's called as ex pleomorphic adenoma. When there is a total malignant change, you can call it as a malignant pleomorphic adenoma. Rare tumors like carcinosarcoma can also occur in the parotid. Next slide. Warthin tumor, the very next common tumor, males, and parotid is exclusively the parotid. Next slide. Soft, cystic, lower pole, two layers are there, both the epithelial component as well as the lymphoid component that is there. That's why it's called as adenolymphoma or also called as lymphomatosum. Papillary cystadenoma, lymphomatosum. Next slide. Common in males, slow growing, 10% bilateral, 10% multifocal. But remember, it never turns to malignant and it never involves the facial nerve. Next slide. Next slide. The difference is the Warthin's tumor and the oncocytoma are identified by the technetium per technete scan as hotspots. Why hotspots? Because of the presence of mitochondrial rich oncocytes in the Warthin's tumor as well as the oncocytoma. That is why they are hotspots. Next slide. Previous slide. The most common malignant tumor of parotid is the mucoepidermoid carcinoma. The most common occurring in the major salivary glands. Most common in parotid. Most common in children. Most common tumor post irradiation is also mucoepidermoid carcinoma. Here, there is a spectrum of tumor. Either you can have a benign, borderline, or malignant. More squamous epithelial are there. That means it's going for malignancy. Next slide. More epithelial, more malignant. Low grade, intermediate grade, and high grade. Next slide. The adenocystic carcinoma, the next common. Here it is very common in the minor salivary glands. And the other than the parotid salivary gland. Perineural involvement is there in a adenocystic carcinoma. The other name given for adenocystic carcinoma is cylindroma. Next slide. Perineural invasion is the most important thing. Next slide. Next. Then the next is the acidic cell tumor. It's a slow growing, painless tumor, common in women. Next slide. Remember the parotid tumors, you can do the investigations like ultrasonogram, CT, MRI. Next slide. See, in our times, whenever we have salivary gland tumors, no biopsy. That's what we were taught. But now they allow FNAs. Fine needle aspiration cytology, they allow. This is reported as per the Milan system. You can go through in the text. Next slide. Core needle biopsy, never mention this in your examination. Next slide. Staging. The major salivary glands as per the edition of AJCC, minor according to the origin, and the node and metastasis are according to the head and neck squamous cell carcinoma. Go through this 2 to 4 centimeter, more than 4 centimeter advanced. Next slide. This I think you have seen the nodal status as in the any other secondary snake. Next slide. Remember, treatment of the parotid tumors. See here, the main thing is remove the tumor completely. Otherwise, when there is a recurrence, it will be multicentric. Normally, you have a unicentric tumor, but recurrence is multicentric. So you have to go for a removal of the tumor with a normal tissue. As it is common in the superficial lobe, go for a superficial conservative parotidectomy. If it involves the deeper lobe also, go for a total conservative parotidectomy. Suppose it is a small tumor infiltrating the nerves, go for a radical parotidectomy. That means when there is a malignant tumor, you have to go for radical parotidectomy. You read the recent books, they say extracapsular parotidectomy, adequate parotidectomy. There are so many terminologies are there. But remember, you always tell for benign tumors, superficial conservative parotidectomy or suprafacial parotidectomy. For a deep tumors, total conservative parotidectomy. The conservation is the facial nerve. When it is a malignant tumor, it's operable, go for a radical parotidectomy. Next.
Sir, 4 more minutes.
Yes, sir. Next slide. I already told you this. Next. So then incision. Lacy ends incision or the modified Blair's incision. That is what it is. Next slide. Next. See, you have to create a plane. Next slide. These are all the steps of the, remember the branches of the facial nerve, temporofacial and cervicofacial, right? They divide into two. How to identify the Conley's point? You have to identify the Conley's point or tracing the branches. Hamilton-Bailey's technique. Next slide. Next slide. Next. So the complications of parotid surgery, infection, hematoma formation, facial nerve weakness, parotid fistula, psilocele, facial numbness, and they will be asking about the Price syndrome. What is Price syndrome? Next slide. When you damage there is apparent cross innervation between the secretomotor parasympathetic fibers of the parotid gland with the sympathetic fibers that supply the sweat gland. So you will have sweating and erythema at the region of the parotid gland. Next slide. How to prevent it? That's why they are devising the extracapsular parotidectomy, leaving the capsule and then going into the adequate parotidectomy. That's what they remember. Next slide. It's only conservative. They recover within 6 months. You have to apply antiperspirant like aluminum hydroxide or the denervation by the tympanic neurotomy. Recently, what we use is the botulinum toxin. Next slide. Thank you for listening to me. Just before ending, the parotid is a serous secretion. It is by the stimulated secretion, whereas the submandibular is a resting secretion. So which salivary gland produces secretion during sleep? Anybody? Minor salivary glands. Thank you very much.
Thank you very much, sir, for the highly enlightening lecture. Thank you so much.
So we invite the speakers, previous speakers also to come and receive the certificates. Dr. Saravanan sir, Dr. Tirunavakar sir,
So next is the obstetric jaundice from Stanley Medical College. I invite the examiner, Dr. P. Thangamani sir, Dr. S. Jaswant sir, welcome sir, Dr. Rajkumar Ratnasamy sir, Dr. Balaji Singh sir, Dr. Balaji Singh sir, please sir, please. Obstetric jaundice case. The convener is Dr. Balaji Singh sir, the examiner and the faculty Dr. P. Thangamani sir, Dr. S. Jaswant sir, Dr. Rajkumar Ratnasamy, and Dr. Periyasamy sir. Okay, okay. Dr. Rajkumar sir. Okay.
Good afternoon to everyone. Good afternoon, everyone. Good afternoon to everyone. Now we will present a case of jaundice. Okay. Start on this. Start on this. A 52-year-old male, Mr. Munusamy, residing at Minjo.
Can you be bit louder, please?
Came to the Stanley Surgical OP with the chief complaint of yellowish discoloration of eyes and urine for past 2 months. History of presenting illness. Patient was apparently normal 2 months ago. Then he noticed yellowish discoloration of eyes and urine for past 2 months, which was insidious in onset and waxing and waning in nature. History of itching all over, present all over the body for past 2 months, which is more in trunk than extremities. History of loss of appetite for past 2 months and unintentional weight loss over 5 kgs in past 1 month. And history of melena is present. No history of abdomen pain, no history of fever, no history of passage of clay stool, no history of easy fatigability, breathlessness or palpitation, no history of passage of silvery white stools. No history of hematemesis, hematochezia or vomiting, no history of lethargy, irritability or drowsiness, no history of swelling in the abdomen or elsewhere in the body, no history of abdomen distension, cough or lower backache, no history of reduced urine output or hematuria, no history of nocturnal diminution of vision, pathological fracture, numbness, tingling sensation, and bleeding tendencies. Past history, no history of similar complaint in past, and a history of 1 episode of jaundice present in childhood, which is resolved spontaneously in a week. No history of prior hospitalization, no history of cholecystectomy or any hepatobiliary surgeries in past. No history of tattooing or branding or any medication.
So, when from HOPA, what do you think you are dealing? Sir? So you have been history of presenting illness, you said, right? So what do you think you are dealing with?
Since jaundice is present, insidious with the waxing and waning type, it could be probably a obstructive jaundice.
Why do you say, first of all, obstructive jaundice?
Itching is present for past 2 months. Sir.
Only with itching. What else?
And no cause of no history suggestive of medical
See,
jaundice.
first of all, it's painless jaundice.
Painless jaundice.
Number one, painless jaundice. Number two, itching. Number three, passing clay colored stools. These three triad should be there to tell it's obstructive jaundice due to malignant cause.
Malignant cause.
Isn't it? Of that, there is waxing and waning, which probably may be due to periampullary carcinoma. That's all. So then based on that, you take history of metastasis, whether it has metastasis or not. So for that only you said, what did you say? There is no abdominal distension. Why did you say that?
Ascites, if any ascites,
very
it is
good.
no
Okay, then where else it can metastasis to?
It metastasis liver mets with the
Liver
lungs.
is already jaundice is there. So how do you
Lungs.
identify?
Lung metastasis can be.
Maybe dull aching pain in the hypochondrium.
Okay.
Why do you get dull aching pain in hypochondrium in obstructive jaundice?
Due to
Napa?
cholestasis.
Cholestasis. What does it causes? So
Subscription.
Glissen's capsule. Okay, very good. So you should say that Glissen's capsule that. Okay, then of course you can also get pleural effusion.
Pleural effusion.
Isn't it? Okay, why? What are the cause of pleural effusion obstructive jaundice? One is metastatic. Anything else? You said about kidney and all, right? So you can also get hepatorenal. When there is this thing, you can also get pleural effusion.
Hepatopulmonary syndrome.
So from HOP itself, you know it's obstructive jaundice, probably periampullary, right?
Yes, sir.
And you stress it is painless jaundice.
Painless jaundice.
That is important from the history. Then past history has no similar history. Why did you ask that?
To rule out any intermittent jaundice.
Napa?
Intermittent jaundice in case of CBD
Obviously,
stones.
see, past history of jaundice mainly cholelithiasis to be ruled out, but it is painful. They'll have biliary colic, or they can have pain due to cholangitis.
Cholangitis.
Okay, so how will you differentiate biliary colic and cholangitis pain?
Intermittent pain,
Charcot
fever.
striate. What is Charcot? Intermittent
Intermittent
jaundice?
pain, intermittent
pain.
fever, and intermittent jaundice.
Right. Okay, so that will be there. Charcot striate will be there. Understand? That's so biliary colic will be.
Colicky
Only
pain will
different,
be there, sir. Colicky pain will be present.
Colicky pain radiating to
Tip of the right.
shoulder.
Right.
Okay, so that is classical. So in that case, you have to tell that, right?
Okay.
Is there any other reason for asking past history of jaundice?
Might be a viral
Napa?
Viral
Very good.
hepatitis.
Viral hepatitis. So what can it cause?
It can cause chronic
Nausea.
hepatitis. Cirrhosis can occur.
Cirrhosis and chronic active hepatitis, and you can get HCC. How HCC can cause obstructive jaundice?
Hepatocellular carcinoma can cause intrahepatic cholestasis, sir. That might be reason for
But how can you cause obstructive? We're talking with obstructive jaundice.
lymph node compression.
Good. Lymph nodes in the porta can press upon the common hepatic and can cause obstructive jaundice pattern, right? So that you have to tell, because if it is HCC causing jaundice, mainly it should involve more than 70% of the liver parenchyma to represent clinically as jaundice. But obstructive jaundice can occur because of nodes in the porta hepatis. Okay, right? That's maybe the reason. So in history, these are the things we ask the undergraduates, right? These are the things. Why history? Because for undergraduate, history taking is main important, and arriving at a provisional diagnosis is important. We are not bothered about to a certain extent, surgical aspects of it, we don't go in depth. Mainly from the history, how do you arrive at a diagnosis? What will be a provisional diagnosis? What are the basic investigations to be done? Okay, good.
No history of tattooing, no history of branding or alternate medication, no history of previous blood transfusion incidents. Comorbidity, not a known case of any comorbidities. Family history, no history of similar complaint in the past, no history of diabetes mellitus or hypertension in the family, no history of any cancers others, of colonic carcinoma, lung, breast or ovarian carcinoma in the family. Personal history, consumes vegetarian diet, normal bowel and bladder habit, Sleep pattern is disturbed. Nocturnal awakening is present with daytime sleepiness is present. Loss of appetite for past 2 months. Consumes alcohol for past 20 years. 180 ml of brandy thrice a week. And smokes 4 cigarettes per day for 20 years. And no history of allergy for drugs or food or doesn't. Summary: a 52-year-old man, Mr. Munusamy, came to the OPD. The chief complaint of yellowish discoloration of eye and urine, which was waxing and waning type associated with the which was painless, and loss of appetite for past 2 months, and with significant weight loss with melena and disturbed sleep pattern. Consumes alcohol and smoking for past 20 years with no comorbidities. With the history, it is suggestive of obstructive jaundice of malignant type.
Okay, one common question which would be asked is how you differentiate from medical jaundice. As sir rightly told,
first of all, color of
painless,
painless
passing, clay-colored stools, itching. In addition to that, what you will have to tell is absence of prodromes.
Prodromal symptoms.
That's the first
Nausea,
thing. Usually a medical jaundice is also prodromes and constituted the patient very ill. It's not so with surgical jaundice. Right? Okay. And in past history, I think any surgical history you tell. Also, any endoscopic interventions if present. You mentioned that?
No, sir. No endoscopic.
Not only surgery, any also sometimes may result in a stricture of the biliary tract leading to obstructive jaundice. You should also mention that.
Okay.
Hello. Before examination, you said that yellowish urine. And you said that in the history, there is no decreased urine output and hematuria. How will you differentiate between a yellowish discoloration of urine and hematuria?
Hematuria is pure with the blood.
How will you confirm that it is not hematuria, it is only high-colored urine? Or how will you confirm that it is high-colored urine, not hematuria?
Microscopic examination,
what?
it reveals of the urine sample, it reveals the RBCs, number of RBCs per IPAR field you have to look for.
Urine has to be present. Why did you ask that question? There is no output on hematuria.
As a result of obstructive jaundice, there can be secondary biliary cirrhosis, which leads on to portal hypertension. As a result of which, hepatorenal syndrome can occur, or it can be because of septic shock in can occur.
Hepatorenal. For a secondary biliary cirrhosis will take years to come. In obstructive jaundice, to have a secondary biliary cirrhosis, it takes months to years. So that is not the primary cause for hematuria. Anything else?
Septic shock, which can occur in cholangitis.
Septic shock patient will not be kept in your examination. Don't worry. Anything else?
Acute tubular necrosis due to the bile pigments in the tubules.
Yes, that is one of the reasons. In obstructive jaundice, patient might end up in an acute renal failure. That will lead to acute tubular necrosis. Anything else? Most common cause. Any vitamin deficiencies?
Vitamin D deficiency.
Correlating with coagulopathies.
Vitamin K deficiency causes hematuria.
Yeah, in obstructive jaundice, you have a fat-soluble vitamin deficiency, ADEK. So in vitamin K deficiency, naturally, patients of obstructive jaundice would be having a vitamin K deficiency, which may lead to altered PTINR and coagulopathy. That might lead to a hematuria. So patient might also having a bleeding tendencies like epistaxis or hematuria, something like that, bleeding from gums. All those things is also to be asked in the history of present illness. Now, proceed.
Next slide. So I would like to proceed with general examination. After obtaining consent from the patient was examined in well-lit room. On examination, he was comfortable at rest, afebrile, hydration status is adequate, moderately built and poorly nourished. ECOG score is 2. Icterus present. There is no pallor. There is no cyanosis or clubbing. No generalized lymphadenopathy. No pedal edema. Vitals, pulse rate 87 beats per minute was regular and normal volume. Blood pressure, systolic is 110 mm of Hg and diastolic is 70 mm of Hg. Measured in right upper arm in sitting position. Respiratory rate 14 breaths per minute. It's abdominothoracic type of respiration. Temperature 98 °F. Head to toe examination. Icterus was present. Scratch marks in the chest, abdomen, in upper and lower limb, and no other signs of liver cell failure.
Where did you look for icterus and what sort of icterus did you observe? And can you correlate that type of icterus with the possible problem you are dealing with?
Icterus, you have to look for the upper sclera through the bulbar conjunctiva. Visualize through bulbar conjunctiva in upper sclera. It will be in obstructive jaundice. It will be greenish yellow in colors because of the biliverdin, which get the bilirubin deposition that might cause greenish.
Other jaundice also you got bilirubin. What type of bilirubin makes this greenish tinge to the
a conjugated bilirubin?
Predominantly bilirubin, conjugated bilirubin imparts that.
What other features you look for? You said there is no other features for liver cell failure. What other features you look for?
First, you have to look for head to toe. The first alopecia, madrosis, and the Nifeta hepaticus, and that is icterus. You have to look for, sir. And subconjunctival hemorrhage, and in the chest you have to look for spider navy and loss of the pectoral hair and the facial hair loss, and gynecomastia, and ascites, and also bilateral testicular atrophy and the pedal edema. In hands you have to look for asterixis, the Dupuytren's contracture, and palmar erythema, clubbing might.
See, what happens when you present undergraduates, like the patient well-oriented and conscious, you tell, right? For every patient you tell, you need not tell when you have taken a good history. Whereas for patients with obstructive jaundice and portal hypertension, we expect that because they'll be delirious. Moreover, he is alcoholic. Okay, so alcohol, he is in the hospital. So he will be on alcohol withdrawal. So he can be delirious. So he may be disoriented. Understand? So for all the cases, you don't tell patient is conscious oriented. But in exam, we expect in obstructive jaundice, being an alcoholic, he is on withdrawal. He'll be in hospital for 7-8 days. You won't have taken alcohol. So he'll be having withdrawal symptoms. With that, he can have delirium tremens. Okay. Yes. Number 2, he can have encephalopathy, for which again, he can be disoriented. So this is what 2 long cases we expect you to tell about that. Yes. Otherwise, routinely for other patients, when you have taken a very good history, you need not tell. Obviously, good history itself tells that he is oriented and conscious. Understood?
Yes, sir.
Right. So then what do you think, what are the causes of pedal edema? Where did you look for pedal edema? What are the causes in obstructive jaundice? Obviously, what will happen?
So, due to biliary stasis, there will be biliary cirrhosis of the. So, due to the cirrhosis of the liver, we can see pedal edema.
Sorry for the interruption. With the intent of giving chance and accommodating many students, I think we have another presenter coming in to continue. Excuse us.
This same topic will be
You can stay
discussed
there.
by the
The presentation will be shared by him. You all both can respond to the questions, right? Okay.
same topic.
Same topic. One more presenter will be there to accommodate that.
You have to accommodate him also. That's all.
Yes.
You know the case? Do you know the case?
Yes, sir.
Huh?
You can start from systemic examination.
Do you have a separate slides? Do you have a separate slides?
Yeah, we understand. Project.
File name.
Top 2023.
I think.
See, I think you can summarize the case instead of making a long presentation. Can you do that?
Yes.
The third presenter.
Yes, sir.
You know the history? Can you summarize your case instead of a long presentation? You know your case, no?
You have your own case, and can you summarize it now instead of
A long.
Can you just summarize? Just summarize.
Talk into the mic.
A middle-aged patient of 42, a middle-aged patient who is a chronic alcoholic and a chronic smoker comes with chief complaints of abdominal pain for the past 6 years, which has aggravated in the past 3 months. The patient also has mass by abdomen for the past 3 months, weight loss for the past 3 months, loss of appetite and sense of fullness for the past 3 months, and also the patient has yellowish discoloration of skin for the past 1 month, high colored urine and clay color stool for the past 2 months, fever for the past 1 month, and also generalized fatigue and weakness and fatigue for the past 1 month.
What's your impression?
Yeah, sir, actually in this case, my diagnosis was obstructive jaundice with carcinoma head of pancreas, sir.
What do you think of?
Why do I think of that? First of all, the reason being obstructive jaundice, as I told you, obstructive jaundice means when since the patient is having yellowish discoloration of skin, which definitely means jaundice. There is weight loss which is observed over there, and also, sir, can I mention about the examination as well? In the examination,
How can you come from the history? You said it's from the pancreas.
You're talking about history, no? Okay, sir. So, like obstructive. Actually, I had 3 probable diagnoses.
See, we have got only 3 questions to answer. Why do you think that this is obstructive jaundice from your history? And why do you think that a malignant problem causing this obstructive? You answer only this.
Sir, first of all, why do I think it is obstructive jaundice? As I told, there is yellowish discoloration of the skin for the past 1 month. The patient is having loss of appetite for the past 1 month, and also the patient is having abdominal pain, which is of cramping type for the past 3 months, which for the past 6 years, which has aggravated in for the past 3 months, cramping type, and also the patient is also having
These are all specific for obstructive jaundice.
Yes, sir. That is what I'm saying. But sir, when we are here talking about pancreatic pathology, why do I think it's pancreatic carcinoma? The reason being, there is abdominal pain which is radiating back region. So one diagnosis is over there, sir, and that's also, I think.
Patient is having pain abdomen for 6 years, no?
Yes, sir.
Pain abdomen for 6 years.
Abdominal pain for the past 6 years, yes, sir.
What is the cause for pain? 6 years pain.
Yes, sir.
Why 6 years pain? Patient is having pain for 6 years, no?
So 6 years. So abdominal pain is present for the past 6 years because of the celiac plexus, which will be affected in the abdominal area, which will lead to abdominal pain, sir.
That can give rise to pain.
Yes, sir.
Malignancy for 6 years.
You mean to say that malignancy is there for 6 years? Is that what you want to convey?
So
see, you said 6 years and then pain.
So the
yes. Still you can explain.
Sorry, sir. I want to correct something. So the nature and severity as of
if you don't know, I'll answer.
Yes,
There
sir?
is chronic pancreatitis. That can have pain. Malignancy can develop on chronic pancreatitis. Got the point? Patient will be having pain for 6 years because of chronic pancreatitis. Malignancy can develop on chronic pancreatitis, very common.
Okay.
In that case, there was jaundice, loss of weight, loss of everything. So in that case, you suspect pancreatic malignancy superimposed on chronic pancreatitis. In that way, you can explain. Okay.
This.
Systemic examination.
Summarize your
Findings. So, students, first of all, sir, I would like to start systemic examination. No? Okay, sir. So, systemic examination. Local examination of the abdomen. Sir, inspection. One slide before. One slide before. One more slide. Okay, sir. Sir, first of all, according to the inspection, when I'm inspecting the abdomen abdomen appears to be flat. Umbilicus appears to be in midline. There's a small small globular mass which is present on the upper. There's a small globular mass which is present on the upper on the right hypochondrium and right epigastric region, sir, which is like 7 into. On C,
There
it
is
is
no
like
right epigastric region. It's
Yes,
only epigastric region, right hypochondrium.
sir, it's both epigastric hypochondrial.
There is no right epigastric region. There is only epigastric region.
No,
And
sir,
right hypochondrium.
I mean to say epigastric region, right hypochondrial region, sir, and also after that it appears to be like 7 to 5 centimeters, and it is around 6 centimeters away from the right costal margin, and also there were multiple burn heat scars which are of plus shape were observed on the epigastric and the right hypochondrial region, sir, and also after that on inspection there is no visible peristalsis, no dilated veins have been observed, and after that no visible. And hernial orifices are appearing to be free, and the external genital area is appearing to be normal. After that, on palpation, there is tenderness which is observed over the right on the epigastric right hypochondrial and the right lumbar region, and there is a diffuse palpable mass which is which is present around 3 fingerprints, like 6 to 7 centimeters from the right costal margin, sir, which is extending towards the epigastric region, which is having a smooth surface, firm consistency, and it is and it also moves with respiration. And also after that, there is also a round, a small shaped round globular mass which is of 7 into 5 centimeters in length, and also it is having 6 centimeters away from the right costal margin, and also, sir, it is also having smooth surface, firm consistency. It also moves with respiration, sir. And after that, the moves with respiration. After that, can you please go outside? Smooth, and after that, on palpation, gallbladder appear. Sorry.
What is the structure you are palpating?
Yes, sir.
What is the structure you are palpating?
Mass there.
What
is that?
Sir, it appears to be gallbladder to me, which is a small round globular mass.
All right, gallbladder. Why do you say it is gallbladder?
Sir, because there is a round shaped globular mass which is present around 6 to 7 centimeters away from the right costal margin, sir. So for me, it's actually gallbladder, sir.
What is the superior extent of the swelling?
Superior extent of the swelling is corresponding to the lower border of the liver.
What is that part of your examination?
Insinuate your finger. Are you able to insinuate your finger between the costal margin and the mass?
Insinuation of fingers, did you do?
Can you just
Can you tell?
if it is a gallbladder, if it is from the gallbladder?
All of you can stand in a line and tell. Yes.
He says it is a gallbladder.
Yes, sir.
What are the findings which would point to that the mass is a gallbladder?
It will be a globular swelling which is having a tense and cystic consistency, which will impinges the finger on inspiration.
In abdomen, you don't get tense cystic intra-abdominal. It is firm. It is inside the abdomen overlaid like by the parietal. It won't be cystic anymore. It's a firm swelling, right?
Globular swelling, and it impinges the finger on, it impinges finger on inspiration, moves down with inspiration.
Okay, movement on respiration accepted then.
And it exhibit transverse mobility to little extent, sir. And transverse mobility, side to side mobility will be there.
Not essential. Presence of parietal, you cannot always do that.
And we are able to feel the lateral medial margin, inferior margin. Superior margin will goes under right costal margin. So we are unable to feel for the superior margin.
Exactly. The superior aspect of the swelling will be distinct, and in continuity, the insinuation of fingers will not be there. That should be your answer. And in your inspection finding, he said absence of visible gastric peristalsis. Has it got any relevance to the obstructive jaundice? If so, tell me.
Sir, in case of intraduodenal carcinoma, affecting the first and second part of duodenum, it might cause gastric outlet obstruction that might present with visible gastric peristalsis. It can be a cause for obstructive.
Okay. We can proceed with the
Next, further, is there any other?
You proceed with your palpation findings.
What is liver span? What is mean liver span?
Liver spine, sir.
What is a normal liver span?
12 to 15 centimeters.
Yes, but then 6 centimeters and capotomody. The liver span is a superior border to inferior border, not from the costal margin. That is liver span.
Said that there is no dilated veins over the anti-abdominal wall. So what are the dilated veins you look for? If so, how would you explain that in obstructive jaundice?
Around the umbilicus, we have the paraumbilical veins present, and superficial epigastric veins also be dilated. And it might be because of portal hypertension, or it can be due to IVC obstruction, inferior vena cava obstruction.
So in obstructive jaundice, what do you expect? Is it a portal hypertension or IVC obstruction?
Portal hypertension.
Yes. So in the CA end of the pancreas, where there is a direct compression of the portal vein, might lead to portal hypertension, which has got a retrograde flow of the caput medusae from falciform ligament. So you might have the ectopic varices or the caput medusae umbilical veins. Dilated anti-abdominal veins, because of the IVC obstruction, it is unlikely, very rare in case of obstructive jaundice. It might be due to.
See, in palpation, we'll usually ask, other than the gallbladder, what all did you try to palpate? You always say number one for hepatomegaly. One is because of cholestasis. In that case, hepatomegaly, the surface will be smooth.
Surface.
Or it can be due to metastasis. In that case, surface can be nodular. Finish off. Then, other than that, I look for mass in the epigastric region. Number one, intra-abdominal, intraperitoneal. Why CA stomach? CA stomach can present with obstructive jaundice. If gallbladder is palpable, it is the suprapyloric nodes that obstructs the common bile duct, and gallbladder will be palpable. If there is no gallbladder palpable, it will be the porta hepatis nodes that can cause obstructive jaundice. So I look for that. Then you should say, I look for a epigastric mass, intra-abdominal, retroperitoneal, because at times cystic neoplasm of the pancreas can present with obstructive jaundice. So we'll expect, other than the gallbladder, what did you look for? Liver, epigastric mass, intra-abdominal, intraperitoneal, intra-abdominal, retroperitoneal. That's all we expect on palpation. Understood? So be clear. Other than then, as SARS asked, why did you say it is gallbladder? You have explained it correctly. One is the site, right hypochondrium. Okay, you felt all the borders except the superior band and cannot insinuate your finger. That's it. And you don't tell cystic, because you presume that it contains bile, you can't tell it's cystic, because you are palpating through the parietis. So anything abdominal, even if it is a mesenteric cyst, it will not be cystic. Understand?
Yes.
So remember that abdominal will be firm.
Yes, sir.
Or hard. That's it.
Yes.
Okay, this is what we expect in palpation. Right, sir?
You can continue with your presentation.
So my final diagnosis is obstructive jaundice with a carcinoma of pancreas, sir.
Okay. What's the significance of a palpable gallbladder in this case?
The palpable gallbladder with it basically explains that there is accumulation of bile within the gallbladder, which basically leads to palpitation, sir. So
That's not the answer.
Sir,
Obviously, a distal gallbladder will have a bile in it.
Sir, but there will be obstruction. No, since there is obstruction, sir, so there will be inflammation of the gallbladder, sir, because of which there is palpation of the.
No, palpable gallbladder with obstructive jaundice. What is your diagnostic significance? You have any law to back up your diagnosis?
Any law related to the
Courvoisier's law, sir.
Guru. Yeah, tell me what's Courvoisier's law.
Sir, it is a region where the gallbladder will be palpable in the right costal margin, sir.
Don't go give your own law. Can you tell? Talk into the mic, please.
Okay.
I think you will answer from the beginning. What's the significance of a palpable gallbladder in such a scenario?
It indicates there is obstruction of the common bile duct due to the periampullary carcinoma. In periampullary carcinoma, the gallbladder will be palpable.
Only periamp CA?
Even in carcinoma of the head of pancreas, the compression, extrinsic compression, and also in the exceptions of the Courvoisier's law, also gallbladder will be palpable. Courvoisier's law is it states that in a person with obstructive jaundice, if the gallbladder is palpable, it is not due to stone disease.
So main thing is you rule out stone disease. That is the purpose, and think in terms of malignancy. That should be your answer. Don't go periamp, head of pancreas. Those things doesn't come under Courvoisier. That's an extension of that. Okay, right. Now having come with the exceptions, can you tell that once again?
Exceptions of Courvoisier's law: the double impaction of the stones, one in the cystic duct, another one in the common bile duct, and the oriental cholangiopathies and Klatskin tumors and mucociliar empyema of gallbladder or pancreatic duct, the calculi obstructing the pancreatic duct that causes gallbladder swelling. These are exceptions.
Why in stone disease gallbladder is not palpable or not distended?
Because of repeated inflammation, there'll be fibrosis of the wall that cause shrunken gallbladder, so gallbladder is not palpable.
And why there is palpable in double impaction?
There will be.
Won't you get in contracted gallbladder in double impaction?
There will be a.
You said that there is an exception. Double impaction,
Yes.
you have a distended gallbladder. That is also stone disease.
Yes. Sir.
But
Yes, there will be dilated CBD. Mucocele of the gallbladder.
yes. So it is a mucocele. It is more common in acute cholecystitis, whereas in chronic cholecystitis, it is thickened contracted gallbladder where the neck of the gallbladder is almost closed. So there is less chance of the stone to migrate into the CBD, causing a double impaction. So in a double impaction means we are dealing with the acute cholecystitis. Majority of the times it is distended because of the mucocele, and one of the stone might have slipped into the CBD, causing obstructive jaundice. So that is why double impaction is an exception. Go ahead.
In the symptomatology, can you give a narrow diagnosis of what type of malignancy could it be there?
Since there's a waxing and waning pattern of the obstructive jaundice, it could be probably a periampullary growth in the CBD, distal CBD. That's it. So it could be a periampullary carcinoma malignancy.
What is fluctuating jaundice and intermittent jaundice?
Intermittent jaundice is it's a phase of jaundice in which the jaundice is completely disappear type. In waxing and waning type, it will be rising and falling, but never touches the baseline.
Okay. What conditions you get intermittent? What condition you get fluctuating?
Intermittent in CBD stones and cholangitis, and waxing and waning type in periampullary growth
Can proceed. How will you proceed? The man with the coat.
Yes, sir.
What would you like to do for the patient? There's a provisional diagnosis of periamp CA, right?
No,
Causing obstructive jaundice.
he is saying that it's because of her head of pancreas, isn't it?
What's your diagnosis now?
What is the diagnosis?
So obstructive jaundice with CA head of pancreas.
Okay. What will you do? How will you proceed?
So first of all, sir, we will go for the investigation. So there will be two types of investigations which we will do. First, the investigation which we will do for the diagnosis, and the other one we will do for the treatment. First, when we are talking about investigations for the diagnosis of the patient, so here we can go for magnetic resonance cholangiopancreatography. After that, also CT, MRI, abdomen can also be done, and magnetic resonance imaging.
Hello. Be slow. I'll tell you. Start with basic investigations. Understand? Lab. I'll tell you for undergraduates to please take your biochemistry book and read about LFT, liver function test. It is asked in medicine. It will be asked in surgery. It will be asked in pediatrics as well. Okay. So read about liver function test. Refresh your biochemistry. So what is the test done for urobilinogen?
Yes, sir.
What is the test done for urobilinogen? Bedside we used to do. When we were undergraduates, we have to do. What test do you do?
What is the
Urine test for urobilinogen. Tell urine test for urine, bile pigments and bile salts.
So Ehrlich's test is done.
Ehrlich's aldehyde test is for urine. Urobilinogen is what? What test you do? Foucher's test. Ehrlich's aldehyde test is for bile pigments. AS test is for bile salt. So bedside we used to do those days for urobilinogen, whether it's present or not. With that itself, you know it's obstructive. What will happen in obstructive jaundice? Urobilinogen will be
Urobilinogen is reduced, sir, in urine.
absent.
Absent.
Okay, urobilinogen will not be there. Same way when they ask you LFT, what test you do for serum bilirubin?
Serum bilirubin, sir. Vandenberg reaction.
Vandenberg's test. Okay. So these are things you should remember, right? What are these specific enzymes that rise in obstructive jaundice?
Alkaline phosphatase, gamma glutamyl transaminase, and 5' pyrimidinase.
That's all. So this is what they'll expect in the exam, right? So these are three important enzymes that rise in obstructive jaundice. So where are the OT and PT raised?
in obstructive jaundice?
Vitamin K. Deficiencies.
Vitamin K deficiency, sir.
He is asking, in obstructive jaundice, will the SGOT, SGPT rise?
Is it possible for SGOT and PT to be raised in an obstructive jaundice?
Biliary cirrhosis can cause elevate.
Whenever there is a parenchymal
involvement.
So when there is cholangitis, SGOTH will be raised. When it is raised, we suspect cholangitis, either clinical or subclinical. And otherwise also when there is sudden obstruction, say CBD stone, it causes sudden obstruction, you can raise in thousands. When there is sudden obstruction, because back pressure, the enzymes will be released, damage. The two conditions.
Yes.
Sudden obstruction or in cholangitis.
Sir, you should tell the laboratory investigations pertaining to the jaundice first, then tell about imaging, then scopies, then biopsies. You always, in exams, you should mention them in that order, right?
Yes,
okay, proceed to the next.
1 second. First to confirm the jaundice. Then it is obstructive or not. Level of obstruction, cause of obstruction, this malignancy, then metastatic workup.
Yes.
Then for treatment purpose, divide like this: diagnosis, level of obstruction, cause of obstruction, which is malignancy, metastatic workup, and for treatment purpose.
Yes.
Proceed with the investigations.
Proceed.
Imaging invest.
You proceed. You have to proceed and they will answer.
So first of all, here in magnetic resonance cholangiopancreatography, we are going to see the obstruction which is present within the bile duct. CT, MRI, computed tomography abdomen, where there we will see that there will be any sort of extent of any sort of calcification or any sort of obstruction which might be seen within the.
See, I'll tell you, imaging, you start from plain X-ray of the abdomen. Okay. So in plain X-ray, what can you anticipate? If there is a CA of pancreas arising from chronic pancreatitis, you can see stones. Okay, chain of legs. So X-ray first. Next, go for ultrasound. Ultrasound, what all will you look for?
Ultrasound, CBD stones can be seen
See, in obstructive jaundice, we are telling, as soon as you keep the ultrasound probe, intrahepatic and extrahepatic biliary radical dilatation, hepatomegaly. Okay, if nodes are larger, you can find out. If it is a head mass, you may or may not. Okay, you can find out ascites. This is what you do in ultrasound. So in ultrasound, intrahepatic and extrahepatic biliary dilatation will be seen, right? So depending on the site of the lesion, if it is in the head of the pancreas, till the lower end of CBD, it will be dilated. If it is cholangiocarcinoma, mid or lower CBD, it will be dilated. That's how you have to tell, right? So ultrasound can pick up these things. Large nodes, more than 2 centimeters, can pick up. Free fluid can be picked up. That's all. Then comes your CT scan, right? So again, there is a debate. Undergraduate level, you tell CT, no problem. CT, what all will you look for? Other than the findings of ultrasound, you can make out the lesion in the pancreas. Okay, you can see in the pancreas. Nodes can be picked up. This is what we undergraduate, we expect only these things, right? So notes can be, yeah, in CT, if you are very good, they'll ask you, what is CT pancreatic protocol? Meaning to know the invasion of the vascular structures. Okay. For PGs, yeah, we'll ask in depth. But for undergraduate, you should know these things, right? Because you can't read surgery alone. You have to read 5 more subjects, right? So you have to know the basics. Then, as Sir said, then comes your endoscopy. Endoscopy, what for? From esophagus, you tell it can be a cardiac growth, it may be a pyloric growth, see a stomach causing obstructive jaundice. Nodes can be there. Then you go to D2 level. D2 level, you see if there is a periambulary lesion or there is a bulge. Okay, if there is a bulge, likely to be pancreatic malignancy. If you see a growth, take a biopsy. For this, if the examiner asks you what type of endoscope is better, you always say side viewing endoscope is better, where you can visualize the ampulla and you can say, if at all you want, if the examiner asks you how to take a biopsy, you can tell one breast cytology. Through ERCP, you can do it, or endoscopic ultrasound guided biopsy can be done because of the important structures there. And to focus the lesion, you can take a biopsy. This is what we expect in the exam for undergraduates. Right, sir?
Thank you, sir. Thank you. Certificates for presenters.
Please come, sir. Kindly honor this. Tappani eliputtu. Tappani eliputtu. Kai thatti. Student certificate, sir. And Opa. Hey, won't get put it.
Give a certificate to the chairperson, sir. Dr. Balaji Singh, sir, give a certificate to the chairperson. Certificate to the chairperson, sir, please. Thank you, sir. Thank you for coming.
Thank you.
Next case presentation is the lipoma from Madras Medical College. I invite the chairpersons, Dr. MGM Bhaskar sir, Dr. R.A. Pandey sir, Professor of Surgery, Head of the Department of Madras Medical College, retired. Sir, please, on the side. Dr. Saravanan sir from SRMC, Dr. Maniselvi madam from Professor of Surgery from Madras Medical College. Dr. Balay Singh sir, sir. Welcome sir, please.
I'll announce it. Before, just a minute, before we go on with the lipoma discussion, I'll announce the list of finalists for the quiz, which is to take place in the evening. I'll read in the, not in the actual list, but randomly I'll start reading. Dr. Sukrit from Madras Medical College. Vaishnavi from Madras Medical College. These are the finalists. Krishna Priya from Madras Medical College. Sujit Raj, Tanjavur Medical College. He is a finalist. Subhash from Madras Medical College. Sri Sai Nagar Anish from Stanley Medical College. Sharat Kumar from Madras Medical College. Neelavadi from Madras Medical College. Yatam Vivek Reddy from Madras Medical College. Parthivan from Stanley Medical College. And one more. One more. Prerna from Omandar Medical College. Prerna. So please kindly inform, all these will appear at for the quiz at 4 o'clock for the final rounds. Thank you.
Next slide. A 30-year-old male, Mr. Krishnan, who is an accountant by occupation belonging to middle class from Egmore, Chennai, came with complaints of swelling in the front of the right side of the chest for the past 1 year. Patient was apparently normal 1 year ago when he noticed a swelling on the right side of his chest, which was insidious in onset, gradually progressed to the current size, not associated with pain or discharge. There's no history of skin changes over the swelling, no history of evening rise of temperature, cough or weight loss, no history of trauma, and no history of similar swellings elsewhere on the body. Past history, no history of previous similar complaints, no history of previous surgeries. Patient is not a known case of diabetes mellitus, hypertension, tuberculosis, asthma, epilepsy, heart disease or liver disease. There's no history of contact with the tuberculosis patient. Personal history, patient consumes a mixed diet, has normal bowel and bladder habits, normal appetite, no altered sleep pattern, no adverse social habits. Family history, no history of similar complaints in the family. General,
you are presenting short case or long case?
it's a short case.
Then you are telling such a long history. No, see, this is a short case session, am I right?
Yes, sir. Yes, sir.
These are all not needed. There will be given 5 or 10 minutes in the exam. So try to give a short, brief history, then give the findings. Directly go for the findings and have a discussion. That's all. Family history. How? What about family history?
So there are certain conditions wherein a patient may have swellings over their body, like Men's syndrome, and then multiple lipomatosis.
See, these are all not needed. If you get a patient who has a lipoma, if you ask whether your grandfather or someone has it, they will say yes. They will not say I have MEN syndrome or hypothyroidism, all that thing, they will not talk. So go talk in your level.
Cure of hydromatosis.
Yes, ma'am.
That is genetic. Okay.
Yes, ma'am.
Straight they go to local examination.
Next slide. So this is the picture of the swelling. Local examination. On inspection, a solitary hemispherical swelling of approximately 4x4 centimeters visible over the right anterior chest wall, extending approximately from 3 centimeters medial to the right mid-clavicular line.
Is it circular?
What are the different types of swellings you get in lipoma? In inspection, what are types of presentation of lipoma?
So, ma'am, it can be localized or it can be diffuse.
It can be encapsulated.
Encapsulated.
It can be encapsulated or diffuse.
Diffuse.
So yours is an encapsulated one.
Yes, ma'am. Visible over the right anterior chest wall, extending approximately from 3 centimeters medial to the right mid-clavicular line to the right costal margin horizontally and vertically from the tip of the right costal margin below to 4 centimeters above it. Skin over the swelling is normal. The surface appears smooth. No scars, sinuses, dilated veins, visible pulsations or central punctum visible. Margins are well defined.
One of our swellings, you don't tell margin. Margin is only for ulcer. Very clear. Okay. So what will you tell instead?
Edges.
Edges again is borders. It is borders. Okay. Borders are well defined. Margin is only for ulcer. Edge is again for ulcer, right? So don't do a mistake. Right. Good. So in like any other swelling, side, shape, size, surface, skin over the swelling, surrounding skin and borders. That's all.
Okay.
So as a routine, anywhere, any swelling. Okay, right. Go ahead.
On palpation, no warmth or tenderness. Inspective findings are confirmed. Swelling of size 4x4 centimeter, hemispherical in shape over the right anterior chest wall. Extent 3 centimeters medial to the right mid-clavicular line to the right costal margin horizontally and vertically from the tip of the right costal margin below to 4 centimeters above it. Surface is lobulated. Borders are well defined and slips under the palpating finger. Slip sign is positive. Margins the borders do not yield. Soft in consistency, not compressible. Skin over the swelling is pinchable. Freely mobile, not fixed to the underlying muscle or bone. No fluctuation, transillumination or pulsations are felt.
See, 1 minute. See, actually, most of them don't like skin is pinchable. You say skin is free. Especially when you take exams abroad, they don't want you to pinch the patient, hurt the patient. You say skin is free. Number 2, instead of telling not fixed to the underlying muscle or bone, but tell the plane of the swelling, whether it's subcutaneous or deep. So which muscle did you put to contraction for this?
So for this pectoral is major, sir.
Major. So again, depending on this side, okay?
Yes, sir.
If it is lower down, you have to put serratus anterior.
Yes, sir.
Next question they'll ask you is, how will you put serratus anterior to contraction?
So we will push against the.
Very good. Push against the wall. How do you put pectoralis major into contraction?
So we place the hands over the hip and we press against it. So it
How
makes
will you
it-
know he has contracted?
So you can feel
Feel
the
the anterior axillary fold.
Yes, sir.
It should be taut.
Yes, sir.
Because you just keep it. You don't know, right? So that's what they'll expect.
Yes, sir.
Okay, so don't tell underlying structures, fixity and all.
Okay,
You ask, then they'll ask you, what are the structures that will be fixed? Okay, then they keep on going into it.
Okay.
So, right.
You have put no fluctuation.
Yes, sir.
Why fluctuation? What fluctuation you get in a lipoma?
So pseudo fluctuation.
Then why you said no fluctuation?
So in a soft swelling such as a lipoma, when we use our 2 fingers, even if we compress on one side, there will be no expansion on the other side. It will only yield on one side.
You know why? Why?
Sorry, sir.
Why?
So because at body temperature, the fat is semi-solid.
Liquid.
Long-standing cases,
Almost
it gets
liquid.
liquefies.
Okay. So you have to say pseudo fluctuation, but you have put no fluctuation. And why you want to add transformation also? Are you dealing with the lymph cyst?
So I'm,
Don't tell irrelevant things. See, when you are told it is not compressible, no need to tell no pulsation felt.
okay.
What pulse?
That area. Pulsation, expect that.
So,
On the left side. Cardiac.
yeah, Madam, on the left side.
Suppose if
So
you
it's
have
a
swelling in the posterior aspect, what did you
I
do?
would have accepted it. Oh, okay. Right.
No, no, posterior aspect of the chest wall, any other test you want to do? Suppose you are having a swelling there. Cough impulse. Yes.
Lumbar.
Okay.
Next.
Less aspect.
Systemic examination, abdomen soft, not warmer, tender, no organomegaly. CVS, S1, S2 heard, no murmur. RS, normal vesicular breath sound. CNS, no focal neurological deficit. Summary, a 30-year-old male presented with painless, gradually progressive solitary swelling over the lower aspect of right side of anterior chest wall for the past 1 year, which was on examination found to be hemispherical, soft in consistency, non-fluctuant, freely mobile in the subcutaneous plane, with well-defined margin, with well-defined borders and positive slip sign. Diagnosis, lipoma of right anterior chest wall. Specific investigations.
No. Lipoma and it's a small patient himself will tell. That's not the diagnosis. You have to tell encapsulated solitary
Subcutaneous.
lipoma over the chest wall. That's it. Plain.
Subcutaneous.
And subcutaneous plain. Right? You have to tell that. Just lipoma alone won't be enough. Clear? Yeah, Kolupukatini he'll tell. So now no point in telling that. You have to tell the, as we said, like, because why? There are two types clinically. Diffuse and why do you say it's encapsulated?
Well-defined margin.
Slip sign is positive. In a diffuse lipoma, slip sign may not be positive. Very clear, right? That's how clinically you have to differentiate. Or it may be multiple lipomas kept and we'll ask you to examine the forearm. Right? In that case, you say that particular, it's a multiple, okay, encapsulated lipoma, the largest one in the forearm, subcutaneous plain. So you have to tell these things, right?
Where will you get diffuse lipomas?
So, ma'am, over the back in the neck. Location. Back, neck.
Thigh.
Thighs.
Thighs.
Okay, where are diffuse fat is there, you can get. Nape of the neck, back and thighs.
And intra-abdominally, where can you get?
Retroperitoneal. Specific investigations, chest X-ray, ultrasound, and fine needle aspiration cytology. Treatment, excision under local anesthesia.
FNAC.
Why FNAC?
FNAC. So why FNAC? How will you do FNAC?
So, with a 22 or 23 gauge needle.
Okay, after aspirating, what do you do?
So we'll put it in. So formalin.
Formalin.
You get
FNAC you put in formalin.
No,
எங்க போடுவாங்கன்னு சொல்லிட்டு சார்.
See, first where do you? I'll tell you, ma'am, it's very simple. If they ask you any procedure, you first tell, indication is said. What are the requisites? What you need to do it? Okay, what you need? You need a syringe and what gauge needle?
22 to 23.
21 or 22 gauge, and you need 4 slides, and you need a jar. What does the jar contain? Fixative. Fixative. What is the fixative used? Absolute alcohol and ethyl alcohol is a fixative. There are 2 types. One, you can give a dry slide, FNAC, okay, or put it in a fixative and give. Dry has to be immediately examined by the pathologist. which normally we do for a frozen or anything else, right? Whereas this one, you can use in a fixative and send it to the pathologist. Same way, you have to tell when you do a procedure, consent under aseptic precaution. This all will add on to you. Right?
Marks.
Okay, add marks to you. You say, after obtaining the consent, these are the requisites. Under aseptic precautions, I use this needle. Explain the patient the procedure. Make multiple punctures with negative pressure over the plunger of the syringe. And of the negative pressure, remove it, smear it on the slide. Then you send it for cytology, either in a fixative or dry site. This is what you have to tell the pathologist, FNAC. Okay, most often done for thyroid. Lipoma, when do you do it? Here we agree, right? So small lipomas you need not. But soft tissue tumors of more than 3 centimeters is recommended. Not FNAC, true cut biopsy. So here FNAC, you need not tell at all. So if you tell us, if you suspect a soft tissue tumor, more than 3 centimeters, true cut biopsies. Previous lecture was on that, right? So it was on soft tissue tumors. That's how you have to decide. Otherwise, excision is enough. You need not do all these things. And under what anesthesia you do is what we ask. What anesthesia you do?
So local anesthesia.
Local. Local, next they'll ask you, how will you classify local anesthetics? Little bit of pharmacology. How? Short acting, intermediate acting, and long acting. Then what do we use? Normally short acting. Right? So how do you give a block? What are the complications of anesthetic agent? For any swelling, it matters. That's why I'm asking you. What are the complications of local anesthetics?
Persistent numbness.
One is anaphylaxis, for which we do a pre-terminal test, a lot of controversy. But in undergraduate, you say anaphylaxis is one. Okay, number two, to give in excess dose, before injecting, you aspirate, right? It should not be in a blood vessel. Why? It is again used where? For arrhythmias. So if it goes to the heart, what can happen? Cardiac arrest. Okay, and similarly, excess of xylocaine or local anesthetic can cause convulsions. It is a cerebral irritant. Okay, these are the complications. So they'll ask you. So you infiltrate around and then you make an incision and you remove it. This is what? Excision biopsy. Why biopsy? They'll ask you why biopsy. Tell me why. So what are the pathological types?
So what is the percentage of lignocaine you use there? It's 2%. 2% lignocaine. So what are the other sites you get lipoma?
Other sides of on the extremities, like on the limbs. Then
Subcutaneous, you said
subcutaneous,
subcutaneous.
subfacial, intramuscular, retroperitoneal, subserosal within the organs.
Is there any other name for lipoma?
Hello.
Universal to ubiquitous tumor.
Where else you don't get lipoma?
So the brain. There's no.
But brain, generally people say has lot of fat, the glial tissues. No.
So it is a benign tumor arising from
Which tissue?
adipose tissue.
tissue.
Containing adult fat cells. See, you have to tell it's a benign neoplasm arising from adipose tissue containing adult fat cells. So there is no adipose tissue in brain. So except brain, you can get anywhere in the body. That's why we call it as a universal tumor. It doesn't cause much of symptoms. That's why we call ubiquitous tumor.
What is Brown's tumor?
So what is?
Brown's.
So the one which arises from the brown fat. So
brown color. See, it's again a lipoma. It's from adipose tissue. especially in the cold-blooded animals. They have a brown thing which supposed to keep the temperature. Okay. Brown fat. It's called brown fat. Okay. See, Professor Balaji has told you about FNAC. FNAC is comes as a short question for you.
Short, yes.
So actually, if you have listened or taken it, that's more than enough. FNAC we don't use for any formalin. Formalin is for a histopathology, right? For there's a smear, what you take had to be applied over a slide. See, one fallacy now is you have to use a fixative, but in a FNAC of a lipoma, you cannot use that fixative. Reason is the fat will be dissolved in alcohol, so you'll get all vacuoles from it, right? An excision surgery is we call as excision biopsy, because the whole thing we send for biopsy, only not a part of it. Okay.
But why can't you do enucleation?
So,
Why not enucleate?
Where you do?
enucleation.
When it's in the enucleation means with
So
the
we leave the capsule behind and we only remove the, and it has its.
That if for this case, what will happen to this? Sorry. What will happen to the large standing lipoma?
Complications. Sarah is asking what are the complications of lipoma?
Saponification, myxomatous changes can occur,
Then
calcification,
Calcification, saponification.
very rarely what happens? Change into
De novo.
lipos.
What is Derkham's disease?
Derkham's disease, it is a multiple lipomatosis condition which is commonly seen in females. The ratio is 30:1, and the lipomas are more common over the trunk and
Is it painful or painless?
tender, ma'am.
Tender.
Painful.
Okay.
What are the indications for excision in a lipoma? Because we don't excise all lipomas, right? So when do you excise a lipoma?
So cosmetic, then if the
I think we
patient
can
is having
put that,
pressure
you can put that
symptoms.
last, right?
Yes, sir.
Yeah. So what
So-
are the indications for
A
excision?
very large lipoma, it can cause pressure symptoms.
Size criterion? What's the usually accepted size when you excise? More than 5 centimeters? Yes, then? When you have pain. So that's what sir was asking. What are the subtypes of lipoma? When you have neurolipomas, what is Derkham's disease?
So Derkham's disease is a multiple lipomatosis condition in which has more female preponderance.
Yeah,
And
so ma'am just
it will
asked.
be tender.
Okay, fine. So there it will be painful. When you have a painful lipoma, symptomatic lipoma, when you have some any other, impingement, pressure symptoms. So those are the indications for excising lipomas. Otherwise, we have a lot of patients, coming up with lipomas every day. We don't excise each of them. Okay, so you need to know the indications for excision of lipoma. Okay.
So if at all, if you're very good, finally they'll ask you, can you tell an acute complication of a lipoma? If it is a submucosal lipoma in the intestines,
Intersusception.
you can get intersusception. That's all. This will be the last question asked if you're very good. And they'll give you full marks for it. Okay, that's all. Fine. Next case we'll go.
Thank you, sir. Thank you, ma'am.
Okay. What are the case you're presenting?
Thank you, sir. Thank you. Please, students, please come for collect the certificate. Come. Sir, please give the certificate to the Bhaskar, sir, please. From Madras Medical College, madam. Students. So please, certificate to the chairperson, sir. Sir, please give the certificate to the sir. Avatham kudu. Sir. Thank you, sir. Thank you. Thank you, sir. Bhaskar, sir, certificate. Sir, Landon, sir. Madam, just that 10 minutes, there's a break. Okay. For the faculties to take the lunch. I think students already completed. Finished now? Finished. Okay, 10 minutes for lunch. Go and take the lunch. Okay, sir. Next is the case presentation from Vellupuram, that is a Vellore Medical College, varicose vein. Okay, then there is a talk, please.
I remind about the quiz. All the finalists to assemble at 4 p.m. If the finalists do not know though, please convey the message to your friends.
I welcome the Vellore Medical case presentation of varicose vein. I welcome Professor Ali Madam. Next. The chairpersons. I welcome Professor Ali Madam. The Dean. Madam, please. Dr. Varadarajan sir. Professor Varadarajan sir from Chettinad Medical College. Professor Ravindra sir from Panimalar Medical College. Please, sir. Jilesh Madam from Madras Medical College. I welcome the convener of this varicose vein, Professor Dr. M. Ali Madam, SLMSC. No, madam. Lalitambike Medical College. Sri Lalitambike Medical College and Hospital. Yes. Okay.
Good afternoon, everyone. Myself Akash, and this is my colleague Badri Narayan from Vellore Medical College. This is our clinical case picture. A 35-year-old gentleman, Mr. Ravichandran, team master by occupation from Vellore, presented to the surgery OPD on 23/1/2023 with chief complaints of multiple dilated tortuous vein over the left lower limb for the past 4 years, at the pain in the left lower limb for past 6 months. History of presenting illness. The patient was apparently normal before 4 years, after which he developed multiple dilated tortuous vein in his left lower limb that was insidious in onset, gradually progressed from mid-leg below to the inner aspect of the thigh above. Duration of past 4 years, which get prominent on prolonged standing and walking, relieved by lying down. The patient also has complaint of pain in the left lower limb that was insidious in onset for a duration of past 6 months. And the nature of the pain is intermittent dull aching pain in the inner aspect of the leg, which get aggravated on standing and relieved by taking rest.
What is the cause for pain?
So due to chronic ambulatory venous pressure, there is dilation of stretching of the venous valves.
Stretching of valve will produce pain?
Stretching of veins. Due to chronic ambulatory venous hypertension, there will be stretching of veins, sir. And there is also due to any inflammations.
Is there any claudication pain?
No, sir. There is history of prolonged standing, no history of fever, no history of trauma, no history of prolonged immobilization and night cramps present, no history of night cramps and no history of breathing, breathlessness, coughing and coughing up of blood, no history of abdominal distension, abdominal mass, difficulty in passing stools, complications like history of itching and skin discoloration present, and no history of ulcer, swelling of leg, bleeding or deformities. No history of dilated tortuous vein elsewhere in the body. Past history. No history of similar complaints in the past. No history of diabetes mellitus, hypertension, tuberculosis, epilepsy, asthma, and thyroid disorders. No history of past surgeries done. No history of prolonged hospitalization. Personal history. He consumes mixed diet, normal bowel and bladder habits, normal sleep patterns. Does not consume alcohol or smoke. No history of any allergies. Treatment history. Intermittent usage of elastic compression stocking for the past 3 months with no relevant family history. Summary. A 35-year-old male with no comorbidities presented with multiple dilated veins for the past 4 years and pain for the past 6 months that aggravated on prolonged standing and walking and relieved by rest. The patient also has itching and hyperpigmentation of skin with no other complications. There is no history suggestive of DVT. From the history, The venous system of the left lower limb is involved, and I would like to examine.
What was his complaint?
There is history of multiple dilated veins, ma'am, for past 4 years, and with pain for
No,
past 6.
what you have written?
No coma.
First slide, first slide. See, the complaint should be in patient's words. Okay, it should not be technical or medical word. You have told dilated and tortuous vein. What is varicose vein? Define varicose vein.
Multiple dilated, elongated, tortuous vein of more than 3 centimeter diameter, 3 millimeter diameter.
No, that is not the definition. Can you tell the other person?
Multiple dilated tortuous veins in the lower limb of size more than 3 millimeter, ma'am.
Which book it is given multiple? Dilated, tortuous and elongated veins of more than
3 millimeter, ma'am.
3 millimeter, and then one more with reflex, with the demonstrable reflex. That is the definition. Okay. Whenever you tell complaints, it should be in patient's words. Okay.
General examination. With the consent of the patient and under adequate lighting and privacy, he was examined and he was exposed from umbilicus to the toe. The patient is conscious, oriented to time, place, and person. He is moderately built and nourished. There is no pallor, no icterus, no cyanosis, no clubbing, no pedal edema, and no generalized lymphadenopathy. Vitals. Temperature, the patient was afebrile, 98.7 degree Fahrenheit. Pulse rate, 74 per minute. It is normal in rate, regular in rhythm, no special character, normal volume pulse. All peripheral pulses were felt, and there was no radio-radial delay or radiofemoral delay. Respiratory rate, it was 16 per minute. Abdominothoracic pattern of respiration. BP, it was 120 per 80 mm mercury, measured in the left arm in supine position. Examination of the left lower limb. Inspection. The patient is inspected in standing position. Attitude of the limb is normal with no deformities. Multiple dilated tortuous veins are seen over the medial aspect of the upper two-thirds of the leg and lower two-thirds of the thigh. Hyperpigmentation is seen over the medial malleolus. Multiple scratch marks are seen below the knee. There is no edema, loss of air, or brittleness of the nails. No ulcers seen. No dilated veins seen over the posterolateral aspect of the legs. And the right lower limb appears to be normal. Palpation. There is no local rise of temperature, no tenderness, no pitting edema is seen, no palpable lymph nodes. All arterial pulsations, femoral artery, popliteal artery, posterior tibial artery, and dorsalis pedis artery are felt. Sensations over the lower limb is intact. Special test. Brody-Stendelenburg test is positive. Test 1 is positive. The veins are seen filling rapidly from above downwards, indicating saphenofemoral incompetence. Test 2 is also positive. Veins are seen to fill gradually from below upwards, indicating perforator incompetence.
To the test.
Ma'am, Brody-Stendelenburg test. First, ask the patient to lie in supine position, ma'am. Explain the patient the procedure. Milk the veins and then raise the leg above the head. Milk the veins. Tie the tourniquet below the saphenofemoral junction. 4 centimeter below. 4 centimeter below lateral to the pubic tubercle, ma'am. And then after milking the veins, ask the patient to stand. Removal of the tourniquet will result in rapid filling of the veins from above downwards, indicating saphenofemoral incompetence. Test 2, the tourniquet should be kept in place and the patient is asked to stand. And the veins are seen filling gradually from below upwards, indicating perforator incompetence. Multiple tonic test. It is positive, indicating incompetence of the adductor, Boyd, and dot perforators. Morris's cough impulse test. Impulse felt at the saphenofemoral junction on coughing, indicating saphenofemoral incompetence.
In which position you will examine this?
Ma'am,
Morris's cough impulse?
Standing position, ma'am.
Standing or lying down?
Standing position.
Is it given in DAS? I think in DAS it is given in the lying position.
Okay.
Hmm.
Modified Perthes test. There is no increase in pain is seen, indicating there is no history suggestive of DVT. Homan sign. There is no pain in dorsiflexion. Figan's test was done and 3 blowouts were seen over the medial aspect of the leg and thigh. Pratt's test, it was not done, and Moses sign is not done in this patient. Percussion. Squash test. Impulse felt at the saphenofemoral junction on tapping the single long vertical column of blood. Auscultation. No bruit or venous hum is heard over the saphenofemoral junction.
How will you do Schwartz test?
Ma'am, ask the patient to stand, ma'am. There will be pooling of the veins and the varicose becomes prominent. Place the index finger over the saphenofemoral junction. On tapping the single long vertical column of blood, the impulse will be felt at the saphenofemoral junction over the index finger,
How
ma'am.
will you feel the impulse?
The index
How it
finger,
will be?
index finger will be thrusted outside, ma'am.
Pardon?
Index finger,
No. How it will be the feel?
you can feel hit like sensation, ma'am.
It will be like a thrill.
Thrill. And all arterial pulsations are felt equally on both the sides, indicating there is no arterial pathologies, no palpable inguinal lymph nodes seen, and there is no evidence of muscle wasting or any muscle atrophy. Other system examination. Abdomen, it was soft, non-tender. There is no organomegaly and no evidence of free fluid. Cardiovascular system, S1 and S2 heard, and there is no murmurs. Respiratory system, normal vesicular breath sounds heard. Bilateral air entry was present, and there was no added sounds. Central nervous system, there is no focal neurological nerve deficit. Spine and cranium was found to be normal. Summary of the case. It's a case of primary varicose veins of the left lower limb involving the great saphenous system with saphenofemoral incompetence and incompetence of the mid-thigh, above knee and below knee perforators with complications of itching and hyperpigmentation. Provisional diagnosis. It's a case of provisional diagnosis. Primary varicose veins of the left lower limb involving the great saphenous system with saphenofemoral incompetence and incompetence of the mid-thigh, above knee and below knee perforators with complications of itching and hyperpigmentation. The CEAP classification, it is C4A, EP, ASP and PR. Investigations.
What are the reasons for this dilated varicose veins?
Ma'am,
What all have you elicited in this patient?
first history, ma'am. The patient is a tea master, ma'am. Long-standing history is present, ma'am. And then
So generally, what are all the causes that contribute to this dilated veins?
primary and secondary causes, ma'am. Primary causes can be a congenital valve defects in the veins. Secondary causes can be because of prolonged standing, pregnancy, hormonal fluctuation in women, post DVT, and then any other abdominal tumors compressing over the major vessels in the abdomen, ma'am.
Which vessels?
External iliac vein or IVC.
So basically, it is the lower abdominal.
Lower abdominal,
mass,
pelvic mass.
Any mass. So in this case, except for the long-standing nature, nothing else. Is there.
No other history.
So is it unilateral or bilateral?
Unilateral case of varicose veins.
What else can cause the varicosity? What is the duration of this?
This is for the past 4 years, ma'am.
Past
4 years.
4 years.
Congenital causes can be, family history can be positive in some patients, ma'am. Park-Weber syndrome.
Can any coagulopathy can cause this? Any thrombosis or
Yes, ma'am.
then where do you expect that?
Factor V Leiden mutation, ma'am. Deep vein thrombosis.
Deep vein thrombosis, okay, in the pelvic
Ma'am?
abdomen, lower abdomen.
Ma'am, protein C, protein S deficiency.
Any iliac vein thrombosis, which
Iliac.
occurs due to increased coagulation tendency. So coming on to the test, various tests you have done.
Yes, ma'am.
What all tests have you done for the superficial venous system?
For the superficial venous system, Brody's Trendelenburg test 1, ma'am. And then Morris's cough impulse test, Squat's test, and then Fegan's test, ma'am.
Vegans test. So for the perforators,
Perforators, Brody's Trendelenburg test 2, multiple tonic test, and then the Homan sign is positive, ma'am.
Homans is for what? Is
Pain.
it for the perforator or something else?
It is for deep veins, ma'am.
So for the deep veins, what have you done?
For the deep veins, Homan sign, ma'am. Ma'am, ask the patient to dorsiflex the,
Only that is.
ma'am.
Homans.
Oh, yes, ma'am. Dorsiflexion of the foot causes pain, ma'am, increasing pain in DVT cases.
So when you should not do that?
It's a contraindication if DVT is positive, ma'am.
Yes, if you suspect a DVT, you should not do that. Otherwise,
We can do
so what are the named perforators?
deep anterior perforators in the adductor, the mid thigh, ma'am. Above knee is dot perforators. Below
peripheral pulses, and then sensation. If it is a diabetic ulcer, you have to mention about the sensation, and then regional lymph nodes. And then on palpation, you have to mention about the induration around the ulcer and location of the base of the ulcer where it's situated. And then depth of the ulcer, you have to mention in a millimeters. You have to measure with a probe test. Next one. Next. And I would go fastly. Then if it is a lipoma, it's a soft tissue swelling, slip sign positive and pseudo fluctuation is present and the skin is free. It is a universal tumor. Then you have to tell about the types of lipoma. You have to examine, you have to tell in the exams. And then in sebaceous inspection, punctum seen and the skin not pinchable. Sealed on pressure and fluctuation positive, transillumination negative. And then in dermoids, it occurs in a embryonic fusion areas and swelling is round, smooth surface, fluctuant and the margin sealed on the process. And skin over the swelling is free. And you have to palpate for the bony indentation is important in dermoids. Because if the bony indentation is present, you have to ask for the X-ray of the skull or anything and then see. Next one. Next. Then for the hernia and hydrosis, commonly you'll get the short cases, no? If the calf pimples present or absent. If it is present, inguinal hernia, absent hydrosis. If it is a reducible inguinal hernia, and then able to get above the swelling, the hydrosis. And then in testis, palpable separately in inguinal hernia, and not palpable separately in hydrosis. And the fluctuation positive in hydrosis, transillumination is positive in hydrosis. Next one. Next. And then inguinal hernia, always note the risk factors for developing the inguinal hernia. Tests are done only in the reducible inguinal hernia. Usually in the exam, they'll give a reducible inguinal hernia. So you have to do the test in a reducible inguinal hernia. The examination first done in a standing position, in a hernia, and then in a supine position. The test would not be done if the hernia is irreducible, already told. And after hernial examination, do not forget to mention the examination of the other side and then tone of the abdomen. That is malganglis bulge. Is it important? Malganglis bulge is important. And then perirectal and perivaginal in female and urethral examination. Next one. And coming to thyroid. Thyroid, the history taken, present about the symptoms suggestive of, like that you have to mention. Don't tell all the symptoms. The symptoms which suggestive of hypothyroidism and the symptoms suggestive of hyperthyroidism. And then compression, pressure symptoms and history of any malignancy symptoms are there or not. In general examination, mention about the skin and eye signs and tremor. All eye signs need not be mentioned. In SRV, they are giving more eye signs. No need to tell. Whatever given in the DAS, you can tell. And then in local examination, and you can see the lower border. If you are seeing inspection, I'm seeing the lower border, palpation at the lower, no need to tell the Pemberton's test. What is Pemberton test? Anybody? What is Pemberton's test? Pemberton sign. Tell me. And if the trachea is in midline, do not mention about the Coccus test. Okay, in the PG exam, it's happened. One PG, present Coccus test is positive. Coccus test. Then the examiner asks, why? What's the point of telling the Coccus test? Already the trachea is in midline. So don't mention the Coccus test. And then give the full diagnosis, anatomy, which lobe, and then physiology, whether hypothyroid, euthyroid, or hypothyroid, and pathology, whether it's a benign or a malignant or colloid nodular goiter. Next one. Next. And common thyroid diagnosis, it's a nutshell. If it is a diffuse swelling and euthyroid, colloid goiter, and physiological goiter with a smooth surface. If it is hyperthyroid, it's a Graves' disease. And single nodule with the rest of the gland impalpable. In a euthyroid, it's a solitary nodular goiter. And then a single nodule with the rest of the gland palpable in a euthyroid, dominant nodule of the multinodular goiter. And it's a palpable nodular uteral multinodular goiter. Next one. Next. So in thyroid, don't tell about the subtotal thyroidectomy or neototal thyroidectomy. Only two surgeries, semithyroidectomy and total thyroidectomy. And in investigation, you have to mention the thyroid function test first. The non-invasive, the invasive, the thyroid function test first. According to the thyroid function test, the patient is euthyroid or hyperthyroid or hypothyroid. Euthyroid, you have to tell about the ultrasound. So why we are doing thyroid function test first means, if the patient is hyperthyroid, no need to do a FNAC. The FNAC is contraindicated in hyperthyroid case. That's why the thyroid function test you have to do first, and then ultrasound of the thyroid gland. And two surgeries, semithyroidectomy and total thyroidectomy. And near total, subthyroid should not be mentioned. Next one. Next. So coming to the breast, in history, mention about the previous breast surgeries, and then any biopsies, and any oral contraceptive pills and hormone replacement therapy in a menopausal age groups. And then breast examination should be done, the patient in a 3 positions, arm above the head, by the side, and on the hips, and leaning forward, 4 positions. And note for the skin changes on each positions. And then level of the nipple areola complex. You have to see both levels of nipple areola complex in the same position. And then inframammary folds, you have to mention on the axilla. And don't forget to include the other breast, right or left breast, and axilla in the examination. The kinds of the skin involvement should be defined clearly. Then dimpling and tethering, puckering are not included in the malignant skin changes. And then only the purely orange ulceration and sac-like nodules are the skin changes. And then give your diagnosis, mentioning the side of the lump and PNM staging, whether it's an early breast carcinoma or a locally advanced or a metastatic. So coming to the abdomen examination, then carcinoma stomach, the gastric outlet obstruction in olden days were due to the cicatricial duodenal ulcer. After the PP era, the GU due to duodenal ulcer have become very uncommon. Nowadays, the GU is mainly due to carcinoma stomach. The patients with GU, you have to tell the succussion splash should be elicited at least 2 hours nil oral. Then in examination, inspections, umbilical nodule should be mentioned. The mention about the movement of the mass with the respiration, whether it moves with the respiration or not. The succussion splash should be elicited first, then go with VGP. The swelling above the umbilicus, mass above the umbilicus, you have to mention about the head raise test. Then those mass below, lump below the umbilicus, Cornet test, leg raising test. Next one. Always make in a GU note of the nutritional status of the patient in your examination. The abdomen examination is incomplete without the examination of the external genitalia and left supraclavicular fossa examination. The before upper GI scopy, you have to correct the hydration, electrolyte imbalance, and anemia should be corrected. And then Ryle's tube insertion and stomach was must be given before proceeding the UGI scopy. Next one. Then coming to the obstructive jaundice. So obstructive jaundice already they discussed elaborately in the morning, but anyhow, we'll go through fast. Then intermittent jaundice, if it is painful, choledocholithiasis. So in history alone, we can come to the conclusion whether it's a stone disease or a malignant disease. Then if it is a painless, periampullary carcinoma or waxing and waning will be there. So if it is a progressive jaundice, we have to think in the possibility of carcinoma head of pancreas. Then history for differentiating medical and surgical jaundice. And then icterus should be checked in the sunlight. If icterus is present, a lot of the people are telling no, not anemic. Don't mention about the pallor. If already the icterus is there, what is the point of telling pallor? Then signs of liver cell failure should be mentioned. General examination, the management of the stone disease and periampullary carcinoma. You have to mention the basic radiological investigation. We start with ultrasound. And then the last should always be tell in the whatever given in the book, you have to tell the law. Don't tell in your own words. That's important. Next one. Then coming to the RAF mass. So RAF mass, you have to tell movement with respiration need not be mentioned for the lower abdominal masses. Then do make a note on the ovarian pathology in the case of females. And then basic imaging investigation in the RAF mass is ultrasound examination of the abdomen. And if the ileocecal tuberculosis, the mass is mainly due to the hyperplastic tuberculosis type. Then short duration of the illness is there, consider the inflammatory pathologies, and longer duration, it is a malignant pathology. Next one. So coming to the vascular varicose veins. So the primary varicose veins empty on rising the leg, whereas secondary varicose do not. So varicose veins examination should be done. All the tests should be done after the milking the veins or emptying the vein. The varicose veins examination should include the test for, you have to SFJ, that is saphenofemoral junction incompetence, and then perforators incompetence. What are all the tests for SFJ incompetence? Trendelenburg 1 and Mousy's cough impulse test. And for the perforator incompetence, Trendelenburg 2, multiple tonicus, and the Figans and Pratt's test. So in exams, tests for DVT need not mention. If the examiner asks, what are the tests for DVT, you can mention. Otherwise, no need to tell about the DVT test. Then the peripheral arterial system mentioned in the venous caches. And the complete diagnosis must be based on the CEAP classifications. And then investigation mainly duplex scan in a standing positions only you have to do. Then the viscous regime is mainly for the varicose ulcer. So you have to treat the varicose veins first, they're automatically healed. So if the patient presents with varicose vein with the ulcer, you have to treat the vein first. And then newer therapy modalities, you have to read RFT, laser, everything. Next. Thank you.
Thank you, madam. That's a very excellent topic. This is an overview of overall the clinical points. They are covering all the exam topic. I welcome Professor Rajavelu sir from Vedur Medical College, Professor and Head of the Department of Surgery, to give the certificate to Head of the Department of Surgery, Kilpauk Medical College, Professor B. Sani, madam. Welcome, madam. Next, I welcome Tagore Medical College to the stage. The case of parotid. I welcome the chairpersons, Dr. R. Rajavelu sir, Professor Rajavelu sir from Vellore Medical College as a chairperson. Please, sir. Professor Ithirai sir from ACS Medical College. Professor B. Santi madam. Santi madam, the chairperson. Welcome, madam. Okay, let's start.
Okay, good evening, everybody. So we will be presenting a case from about swelling of salivary gland. So let's start. A 38-year-old male, Mr. Arumugam, coming from Tiruvallur, belonging to lower middle class according to modified Kupusami scale, who is a construction site worker, came to the OPD with chief complaints of swelling over the right side of the face below the ear for the past 6 months. History of present illness, patient was apparently normal before 6 months, after which he noticed a swelling over the right side of the face below the ear lobule for the past 6 months, which was insidious in onset. Initially, it was 1 × 2 centimeter in size, and gradually it progressed to attain the present size. There was no history of pain over the swelling, no history of fever, halitosis, increase in size or pain during meals. Next, please. No history of sudden increase in size of the swelling, no history of any ear pain, no history of difficulty in chewing, drooling of saliva, facial asymmetry, deviation of angle of the mouth, no history of difficulty in closure of eyes, no history of difficulty in swallowing, no history of swelling in eyelids, no history of dryness of eyes or mouth, joint pain, no history of swelling elsewhere in the face, neck, or the opposite side of the gland. Past history, no history of similar illness in the past, no history of previous head and neck surgeries, mumps infection or any other viral illness, radiation exposure, exposure to any sexually transmitted diseases, no history of any other comorbid illness. Next. Personal history, the patient consumes mixed diet, normal sleep and appetite, normal bowel and bladder movements. He was a chronic smoker for the past 5 years. He consumes 1 pack per day. He is not a known case of any alcoholic. No any other adverse personal habits. Family history, there was no similar swelling or any malignancy among the family members. So summary, a 38-year-old male who was a laborer by occupation with no any other prior comorbid illness presented with complaints of swelling of right side of the face below the ear for the past 6 months, which was insidious in onset, gradually progressive with no history suggestive of infection and inflammation or obstruction of the duct, malignancy or involvement of facial nerves. So next examination will be presented by Danesh. Yes, sir.
No history of
No
pain.
history of pain.
No history of pain.
No history of pain. Only swelling, ma'am. Examination, next slide.
General examination. The patient was examined after getting consent in a well-lit room with adequate exposure in sitting posture. Conscious and oriented in time, place, person, moderately built and nourished, afebrile, no pallor, icterus, cyanosis, clubbing, pedal edema, and generalized lymphadenopathy. Vitals, temperature 98.4 degree Fahrenheit, BP 120/80 mmHg, measured in right upper arm in sitting position. Pulse rate 86 per minute, regular in rate, rhythm, volume, no specific character, no radiofemoral delay. SpO2 98% in right arm. Respiratory rate is 12 per minute. So this is the photograph of the case. Yeah. On local examination on inspection, swelling of size approximately 6 × 5 centimeter noted in front, below and behind the right ear lobule, extending from tragal cartilage about 4 centimeter below the ear lobule, approximately 4 centimeter anterior and 2 centimeter posterior to ear lobule, obliterating the retromandibular groove and lifting the ear lobule. Appears well defined, surface appears smooth, skin overlaying the swelling appears normal, no ulcers or fistulous opening noted, no scars, sinuses or dilated veins. Swelling becomes more prominent on clenching the teeth. Facial symmetry appears normal. No other swellings noted on opposite side and in the neck. Palpation. All inspector findings are confirmed. No warmth, a non-tender swelling of non-tender swelling of size 6 × 5 centimeter, palpable in the right parotid region. Well-defined margins, surface smooth and firm in consistency. Skin is pinchable, not fixed to skin and underlying structures. Side-to-side mobility is present. Upward mobility restricted. Curtain sign positive. Parotid duct on bidigital palpation. No deep lobe involvement. The parotid duct is normal. No deep lobe enlargement. That is also bidigital palpation. Opposite side parotid gland not palpable. That is in tonsillar fossa, ma'am. In
oral examination inspection is tonsillar fossa normal.
Oral cavity examination taniya kodu. It's in separate syllabus.
Go ahead. Go ahead. Go ahead.
Oral cavity examination, mouth opening, normal mouth opening, oral cavity hygiene fair, nicotine staining noted in buccal mucosa. no halitosis, no discharge from parotid duct orifice, no deviation of uvula. Tonsillar fossa normal, tongue normal, buccal mucosa gums are normal, temporomandibular joint normal, no cervical lymphadenopathy.
Duct opening. Sorry, cavity. Where is the duct opening? You have to tell about the duct opening, no? Where the Stenson's duct open?
No discharge from parotid duct orifice.
No discharge. Okay.
Halitosis.
Where parotid Stenson's duct, where it will open?
The upper second alveolar space, opposite,
Opposite
to the
to second upper molar.
second molar.
No, no.
Upper
Crown, the second upper molar.
When you describe it in correct terms, where you're supposed to see. Okay, that is all. That's what madam is telling. Okay.
Examination of facial nerve, motor component, facial symmetry is maintained, wrinkling of forehead present, able to frown, able to close eyelids, nasolabial folds normal, no deviation of angle of mouth, no drooling of saliva, able to blow cheek, able to whistle, able to stretch his neck. Sensory, taste in anterior 2/3 of tongue is normal. Systemic examination, other systems, cardiovascular system, S1, S2 heard, no added murmurs. RS, normal vesicular breath sounds heard, no added sounds. Abdomen soft, non-tender, no organomegaly, normal bowel sounds heard. Central nervous system, no focal neurological deficit. Summary, on examination, 6x5 centimeter, non-tender parotid swelling with well-defined margins, lobulated surface, firm consistency, with no fixity to skin or masseter, involving superficial lobe of parotid with no involvement of facial nerve, no cervical lymphadenopathy, or no evidence of metastasis. Provisional diagnosis, case of swelling right parotid region, it's most probably a benign swelling. It could be pleomorphic adenoma without deep lobe or facial nerve involvement. Investigations. Yes, sir.
Any other differential diagnosis you really think of?
Other epithelial benign conditions.
Like?
Wathen's tumor.
Or
then?
Or it could be a case of parotitis.
Parotitis. There is no pain actually.
Parotitis, you usually have pain.
There's no
Said
pain.
there is no pain at all.
Tenderness
And
It
that
could
too,
be-
there was the period of 6 months.
Slow growing. This is. It could be probably silosyl, accumulation of fat, or
What is that?
silosyl.
Then?
Parotid calculi. If there was calculi.
Pain during meals or something, it could be a calculi, but it is very rare.
I think you have to put differential diagnosis before going into investigations.
Okay.
Because many things point towards a benign parotid swelling. You have to have think of other causes of parotids and any other pathology in that region other than parotid. Okay. Can you have just muscle hypertrophy there? But usually that will not be nodular or anything.
The
like that.
muscle hypertrophy will be smooth.
Usually it will follow a trauma, something very rare. Okay. Anything else? Madam? Okay, carry on. You must have differential diagnosis. Okay.
Investigations, routine investigations, complete blood count, ESR, bleeding time, clotting time, serum, urea, and creatinine. Specific investigations, FNAC of parotid swelling, high resolution ultrasonography.
Anytime
what is-
non-invasive investigations should come first. What is the non-invasive investigation?
Ultrasound.
Yes. After doing ultrasound only, you have to do a fine needle aspiration cytology. Okay.
I would like to add something what madam said. See, whenever we have a diagnosis, we always have some differential diagnosis. Okay, we do not know what exactly is the anatomical origin and what could be the pathological part in it. So the first investigation of choice, whether it is malignancy or non-malignancy, whatever it can be,
First thing is to confirm our diagnosis, confirm the anatomical structure from which it is originating. Okay, then always non-invasive should come before the invasive ones. So in the order, it is always better to go for an ultrasound, soft tissue ultrasound. It is quite available everywhere, non-invasive, painless first, and then follow with an FNAC, which will give us a clue what is anatomical structure, what is a pathological structure. Then we have to decide what we should do. Whether we'll give a conservative treatment or a surgical treatment, whatever it is. Okay. Based on that, we'll have list of investigations. The basal investigations, specific investigations for that particular pathology. Okay.
Okay.
It is whatever the case may be. Anywhere, that is the actual protocol that we have to follow. Actually, we are doing that in a clinical practice. But when we describe in classes, we do it like this.
Okay, sir.
Yeah. Can you think and tell me what will happen if you do FNAC first and then you do ultrasound later?
There will be formation of hematoma. So ultrasound, we cannot delineate the tissue easily.
That's right. Good.
It will be misleading, no? Okay.
Management, superficial parotidectomy with facial nerve conservation on right side.
No, even here, you must say, if the FNAC comes as, okay, a benign swelling or what is the probable diagnosis that we expect?
I'm not able
What
to.
is the probable diagnosis we expect in a histopathologic examination in this case? What is the commonest?
Pleomorphic
Pleomorphic.
carcinoma.
So if they see those pleomorphic cells and give the report like that, if that is the case, then we'll go ahead with a superficial
parotidectomy
or suprafacial parotidectomy with facial nerve conservation. Okay, that is how you have to frame your terminologies.
It is a lazy S incision, ma'am, which starts in front, below the zygomatic process in front of the tragus, and it courses along the ear lobule, and it comes down obliquely along the anterior upper third of the sternocleidomastoid. It is also called as modified Blaise incision. There are two methods for identification, ma'am. You can identify either anterograde or retrograde. Anterograde, you have Conley's pointer, that is tragal pointer, which is cartilaginous part of the bony canal. It is 1 or 1.5 centimeter deep and antero-inferior. Or you can retrogradely trace the branches, buccal branch or marginal mandibular branch. Also superficial in anterograde mechanism, you can tympanomastoid suture, it lies distal to it.
Posterior big digastric.
Posterior digastric muscle can be dissected and it lies.
Suppose you make say first thing, why a lazy S? Why not a sharp? Is it you know lazy S is you make a curve.
Because sir, nerve injuries are very common, so we have to avoid marginal mandibular nerve.
That is not for the nerve injury.
Okay, sir.
Okay, the corners will go for necrosis.
Okay, sir.
While healing, the sharp ones. Okay, if you give a curve, the vascularity will be maintained. Okay, so that is the reason for that lazy S. And suppose there is a damage in while doing either one of the branches or the main trunk of the facial nerve, how will you manage? First thing you have to identify on the table. Then any method of management.
Nerve graft can be.
What? How is that?
Greater auricular nerve or sural nerve is taken and
sural nerve.
Greater auricular is most commonly used, but
so what they do actually? Where is that greater auricular nerve?
it lies near to.
Can you actually see it while doing it itself? While doing the surgery?
While parotidectomy surgery is done, greater auricular nerve can be seen, sir. If it is in the way,
people
can be divided.
Some people, what they do, just first trace the greater auricular nerve, harvest them, keep it aside, because if you cut that, it is not a problem. In case you make some damage, they'll use this for the grafting. Okay.
Can you do CT in this case, or when will you do the CT?
What is the indication of
What is the indication of CT
in this
head and neck?
patients?
To check for the deep lobe involvement.
Deep lobe involvement.
Correct.
Skull base involvement is there, then CT can be done.
Any chance of malignant transformations these cases?
It is very less, sir. Parotid mostly it is 80% benign, but there is the chance, very less chance.
See, this parotid, mixed parotid tumor is a benign condition, right? Why can't you just enucleate it? Why do you want to do a superficial parotidectomy?
So because it might infiltrate the underlying structures, and if it might enlarge into the deep lobe, so it might cause.
The question is, why not just enucleate and leave it? Why do a complete superficial parotidectomy?
So because if we enucleate, the tumor grows in a way like pseudopods projected. So if we leave it behind, it will cause recurrence.
It doesn't have a true capsule. You cannot actually enucleate it.
Yes, sir.
Anything else, sir? Any questions from the audience? Yeah. Sagai.
Already, Dr. Kannan elaborately told the surgeries in the morning, no?
Yes.
Okay.
Yes, ma'am.
Yes, sir. Already Kannan sir, all classes.
Anything else? What was the question? What are the different surgeries for malignant parotid tumor? I think Professor Kannan took a class on that.
If the facial nerve is not involved, we can do a total conservative parotidectomy, or if the facial nerve is involved, or if there are any symptoms of facial nerve palsy, we have to do a radical parotidectomy.
Fine. Thank you. Hey, that was a good presentation by both of you. Well done.
So excellent presentation from Tagore Medical College. Congratulations. Congratulations. I welcome the Professor of Surgery, Tagore Medical College, to the stage. Welcome, Professor of Surgery, Tagore Medical College. The chairperson, Professor Rajgaru sir, Engineer sir, Next, only a fast review of only 2 presentations. One is about radiology in surgery by our Professor Anandi Madam. Next, the instruments, that's a slide show. After that, the quiz, final. Thank you. Welcome, Madam.
See, this will be a brief presentation on all the X-rays which will be projected in your examination. Okay. So what do you mean by X-rays? It is nothing but an imaging tool which is going to be used for diagnosing certain important conditions. Whenever a person comes with an acute abdomen or a chest trauma or a headache or any road traffic accident, we will be doing a lot of imaging investigations, among which we'll be seeing these investigations in a nutshell. Okay, so in an X-ray, various colors would be seen. The first color is going to be a black color or a
light gray, or it could be a white, or it could be a metallic white in color, right? So where do you get this black color? In case of a yar, you have a black in color, right? Next slide. Next slide. Next. Right. So in a fat, you do get a dark gray color. And in case of soft tissue, you do get a light gray. In the bone, you get a white. When you have a metal, you get an intense white color. When you have any foreign bodies, you get a intense white color. Next slide. Next. So start with, we'll be seeing about chest trauma. Whenever you have any trauma to the chest, what will happen? There can be a fracture in the ribs, and there can be a air leak, or there could be a blood which can be collected, or there could be both air and both the blood. So when you have an air within the lung, you have a pneumothorax. So this is a pneumothorax. Whenever there is a pneumothorax, this air will cause a compression of the lung. So this is the collapsed lung which you can see. When you have both blood and air, you tend to have a air fluid level kind of an appearance. So this is a hemopneumothorax. In this picture, you can see there is some collection which is present in the left lung. So this angle is called as the costophrenic angle, which is getting obliterated. So whenever there is a costophrenic angle which is getting obliterated, it indicates there is a fluid which is collected within the pleural's cavity. So remember, hemothorax, hemopneumothorax, and pneumothorax. Along with that, there might be some fracture in the ribs. And one more important thing which you have to remember is called as a tension pneumothorax. In the case of a tension pneumothorax, you can have a lung which is going to be collapsed, which is present here. Can you see a collapsed lung? And this is the air column which is present here. This causes the shift of the mediastinum towards the right side. So whenever you have a tension pneumothorax and have an mediastinal shift, you need to have immediately decompress it with a needed thoracocentesis. Next slide. So this X-ray shows a radiopaque shadow, which is circular. This is called as a cannonball appearance. Usually in case of a lung metastasis, you do have a cannonball appearance. Other conditions where you can have a solitary metastasis, bronchial cancer, adenoma, you do have these kind of shadows. Next slide. So this is the most important X-ray which will be kept in your exam, which is called as a subphrenic air or a air under diaphragm. So when you see an X-ray chest, first thing you should see the image and see which side is the right and which is the left, and whether the bony window is seen, the clavicle and the diaphragm. So normally you do have a gas shadow on the left side. This is about the fundic gas shadow. This is normally seen on the left side. Whereas on the right side, if you see an air, which might be of a smaller volume or a moderate or a bigger volume, it doesn't mean about the volume at all. Okay, when you have an air on the right side, it is a pneumoperitoneum. It is called as a hollow viscous perforation. So whenever you have a perforation, clinical finding, the liver dullness would be obliterated. So this is a surgical emergency. You need to take the patient immediately to the theater and you need to do some surgery. Whatever viscous has perforated has to be taken care of. Next slide. So perforated duodenal ulcer is the commonest cause. The other things would be stomach, small intestine, colon, which can go for perforation. Apart from that, any patient who has undergone any abdominal surgery, if you are going to take an X-ray in the postoperative period for some other instance, for a chest X-ray or something, you might find an air because of the air which is getting trapped inside the, above the liver and under the diaphragm. Next slide. So this image, you can see a metallic object, as I said, with an intense white image. This is a coin shadow, wherein it is present initially at the cricopharynx. Here it has reached almost up to the stomach. And here in this patient, it has reached up to the iliac region. So when you find an coin at the iliac region, what should you do? You need to wait and watch, right? It will pass via naturalis. Likewise, you can also pass via naturalis in your exam if you go through all the questions correctly, right? But if you have got any obstruction here somewhere like this, then some instrumentation might be needed, right? Next picture. So we'll go on with the abdomen X-rays. Next one. So this is the normal abdomen X-ray, wherein you are supposed to look for the liver at this place, the kidneys on these sides, and these are the Stroya shadows. And this is the area where you need to look for the urinary bladder. Next slide. So what do you see in this X-ray? Here, what do you see? Here, one thing is written. This is called as a slide marker. Here, R is written. So this is the right side. So all X-rays will have a marker which will be written. So according to which the X-ray has to be loaded either onto the right side or onto the left side. Here you can see one more thing. There is a gas shadow. As I said, the normal gas shadow would be always present where? On the left side. But here the gas shadow is on the right side. What does it indicate? The heart is almost towards the right side. What does it indicate? When you have a heart shadow usually to the right, it's called as a dextrocardia. Right? When you have the fundus gas shadow also on to the right side, then it becomes a situs inversus totalis. Next slide. So in a normal plain X-ray abdomen, you do have normal gas shadows because of the large bubble. The colonic gas shadows may be around the transverse colon, the sigmoid colon, or in the right iliac fossa and the cecal region, you do have a gas shadows. But the small bubble, they don't produce much of a shadows. So whenever you see a air shadow within the stomach, in the small bubble region, that is around the center of the film, think some abnormality might be there. Next image. So when you have a plain X-ray being taken for an intestinal obstruction, the intestinal obstruction might be either in the small bubble or in the large bubble. In the small bubble, you do have a proximal jejunal obstruction or distal ileal obstruction. When you have a jejunal obstruction, what will happen? The ileums all will be collapsed. Whereas in a jejunal, when you have a ileal obstruction, when you will be having both the jejunum and all the ileum would be dilated. Next slide. So in this image, you can see the jejunum is being dilated and it is distended. Usually the small bubble, the maximum diameter it can go is up to 3 to 5 centimeter. When it is going to reach up to 5 centimeter, usually it tends to go in for a perforation. And one most important thing that to say this is a jejunum is, you can see there are lines which are going transverse across the lumen of the intestine, giving an appearance as if it is going to be a coin stacked appearance. This image is called as a valvulae conniventris appearance. So to diagnose jejunum, look for a valvulae conniventris appearance. Whereas an ileum doesn't have any feature. So it is called as a characterless, right? So try to look for this. So this image is a supine picture where the patient is lying down. But when you make the patient stand up and take an image, you can see there is an air and a fluid. Whenever there is air and a fluid, you tend to have this transverse line. So with this transverse line, you try to count how many loops are present. 1, 2, 3, 4, 5, 6. When you have multiple air fluid levels, it is going to be present. It indicates it's a case of a small bowel obstruction. Next slide. So coming on to the large bowel obstruction, the commonest one is going to be a sigmoid valvulus. The sigmoid valvulus is nothing but the sigmoid getting enlarged and it is going to twist around its own axis. So this sigmoid can twist because of lot of reasons which you can go through. When you have a sigmoid which is going to be twisted, it gives an appearance called as an omega loop, or it is also called as a coffee bean sign. And usually this direction would be pointing towards the pelvis, the downward direction. Next thing. Now we'll go on to the contrast slides. In contrast slides, usually there is a barium which is going to be used as a contrast. There is a swallow which is meant for the esophagus. Meal is meant for the stomach and enema is meant for the colon. So these are the 3 barium studies which are going to be done. Next slide. So this is a normal barium picture wherein you can see the esophagus is being imaged. It is smooth one. There are not much of any constrictions except for the indentation of the cardiac image you can see. Next slide. This is a normal barium meal wherein you can see the contrast is filling into the entire lumen of the stomach and you can see the gastric air bubble. These 2 are normal pictures. Next slide. Here it's a case of an achalasia cardia wherein there is going to be an aganglionic segment which is present at the distal part of the esophagus, wherein the proximal esophagus is going to be dilated. So when the barium is going to be given in, the barium is going to be loaded inside the esophagus. With this gives an appearance of a bird beak. A bird beak appearance is it can be used for diagnosing a achalasia cardia. In an achalasia cardia, the next important thing is when you take, there will not be any air shadow at the fundic region in the stomach because this barium is a contrast. It is not allowing the air to come here. Next slide. So in an esophageal cancer, as you can see, there is a growth here and there is a rat tail appearance. It indicates it's an esophageal cancer. Sometimes you can have an irregular filling defect also when you have a growth like this in the mid or in the proximal esophagus. Next slide. Here you can see a case of a benign esophageal stricture. Usually when the patient takes some corrosive poisoning, you can see a smooth tapering which can be seen in case of a corrosive esophageal stricture. Next slide. This is a case of a duodenal ulcer. Usually in an ulcer, what happens is, imagine this is going to be the stomach wall. There is going to be a crater on the other side of the mucosa. So there will be an ulcer barium which is going to be loculated at that side. This gives an appearance called as a trifoliate deformity in a duodenal ulcer. Next slide. So again, in a gastric ulcer, you can see there is a filling on towards the mucosal side. Next slide. So this is a gastric cancer. In a gastric cancer, what happens? There is a mucosa which is filled with a barium. But here what happens? There is a growth which is present at this side, which is pushing onto the barium. You can see then irregular line which is present here. This is for your gastric cancer. Usually gastric cancers are more common on the lesser curve side. Next slide. So this is also a gastric cancer which is involving the pyloric antral region where you can see this indentation. Next picture. So in the case of a linitis plastica, you don't have a distensible stomach. So you do have only a thin barium which is entering inside, right? So linitis plastica is not usually diagnosed with a barium picture, right? Usually when you do an endoscopy, a non-distensible stomach, even after insufflation, you suspect it's going to be a linitis plastica. But nowadays we don't use a barium for diagnosis. It's only majority for an academic importance. Next slide. So this is a case of an intussusception. This is an ileocolic intussusception. You can see this claw kind of an appearance, which gives the most diagnostic sign for an intussusception. What is the commonest presenting finding for an intussusception in a child? Louder. What is the color of the stool? Red currant jelly stool. What are the components of intussusception? Intussusceptum and intussuscipiens. The part of the bowel which is going inside the other bowel, trying to telescope inside, that is called as the intussusceptum. The one which is receiving is called as the intussuscipien. So in a child, usually they try to do a hygroscopic reduction method, whereas in an adult, usually they tend to have a leading point, which might be a polyp or a malignancy, which might require a resection. So this is about your intussusception. Next slide. So this is about Hirschsprung's disease. Again, there's an aganglionic segment which is present, and there's a proximal dilatation which is present here. So what happens? The patient will be having a habitual constipation. At one point, the patient will be having a abdomen which is going to get distended, and then you need to take the patient immediately for surgery. Most of the time, the emergency will be doing a transverse loop ostomy, which could be done, and later a definitive procedure would be a pull-through surgery, which could be done for a Hirschsprung's disease. Next slide. So this is the barium enema picture, wherein you can see the dye which is coming inside the colon, and here there is a small segment of a narrowing, and again there is a dye which is present in the cecum. So this appearance is called as a apple core deformity of the ascending colon. Or apple எடுத்துட்டு எல்லா பக்கமும் கருவி வச்சிட்டுனா நடுவுல மட்டும் இருக்கும்ல ஸ்டாக். Similarly, there's a stalk here, and this is called as a shouldering effect. You can see the barium is being stacked. So this gives the appearance called as an apple core deformity. So any cancers you need to evaluate and definitely go for a definitive surgery. Most of the times it will end in a hemicolectomy, radical right hemicolectomy. Next slide. Coming on to the next thing is the inflammatory bowel disease. The components would be a ulcerative colitis and a Crohn's disease. In case of an ulcerative colitis, you tend to have a colon. Usually a colon would be having horstrations. So the horstrations would be not complete through and through, it will be only halfway through. But here in case of inflammatory bowel disease, all the horstrations, everything would be disappeared, and it gives an appearance as if it is going to be like a lead pipe. So this is a lead pipe appearance. It is characteristic of a ulcerative colitis. Next slide. Again, the inflammatory bowel disease can involve the terminal part of the ileum, wherein it can cause a considerable narrowing, and this appearance is almost called like a string sign. This is called as a string sign of Cantor. Next slide. So this is an image of a double contrast barium enema. So when you're going to give a barium enema, what happens is it almost floods the entire thing. So you don't image anything. So whenever you want to do a barium enema, first give a barium and then you evacuate it, and then you insufflate air so that whatever barium is going to be left and coated, this will give a clear outline of the picture. So here you can see the horstrations are present halfway through. Can you see? You'll be able to appreciate it. Full length half. Next slide. So with this double contrast barium enema, you'll be able to evaluate diverticulosis. And next slide. You can easily pick up polyps also in a double contrast barium enema. Next slide. Next. So now we'll go on to the imaging of the kidney, urinary bladder, and the urethra. along with the ureter. So this is a normal IVU picture. In a normal IVU picture, first you can have to look for the nephrographic window. Usually this will appear within 5 seconds or within 5 minutes, you'll get the nephrographic window. At the end of 5 minutes, you tend to have the pelvic calyceal system, which is going to be imaged. At the end of 15 minutes, you'll be able to see the ureter. By the end of 30 minutes, you can see the contrast appearing into the bladder. So once the bladder is full, you ask the patient to go and void urine. After he comes back, you take again a film. You can see whether there is going to be any retained urine or not there, which indicates a post-void or a post-evacuation picture. These are the series of images which are going to be taken with an IVU. The contrast used is urographene. It is also called as a sodium diatriazolate. That is the contrast which is going to be used through a IVU. Next slide. Only thing you need to do an IV contrast test dose has to be given before doing this procedure. So here you can see a 2 collecting system. Can you see? And there are 2 ureters. So this is a double moiety. When you do have 2 types. So what is the rule which is associated with a double ureter? Any idea? Weigert-Mayer rule. What is this Weigert-Mayer rule? The upper moiety usually will go down and the lower moiety will drain up. Okay. So when you have a double moiety, sometimes they tend to fuse with each other and they try to empty as a single moiety also. When you have a fusion of both the moieties, then you tend to have a reflex called as a yo-yo reflex. So this will cause a lot of urinary tract sepsis. Next slide. So this is about your hydronephrosis, wherein you can see a stasis of the contrast in the pelvic calyceal system and the ureter, which is going to be distended. So the normal ureter usually lies on the transverse process of this vertebra. And when it comes to the sacroiliac joint, it goes medially. And after the sacroiliac joint, it goes a little bit laterally and comes again medially so that it enters into the bladder. Next slide. Here you can see a mega ureter. Can you see how big it is distended? Right? It is because of the stone which is present at the vesico-ureteric junction. Next slide. So here you can see the stones, which is giving as if it is going to be like a horn. So this kind of a horn you can see in a deer, which is called as a stag horn. Almost it takes the shape of the renal pelvis. So this stone is a triple phosphate stone. Okay. How do you tackle these stones? Usually for surgery when you have a bigger stones. When you have a smaller stones, other methods can be tried like a ESWL, okay, or a ureterorhinoscopy. It depends upon where the stone is going to be located. Next slide. So again, here also you can see there is a filling the dilated ureter, which is almost here. Even at the end of 2 hours, you can see still the contrast is being retained here. I said by 15 minutes itself, you can image this thing. So at the end of 30 minutes, it has to reach the bladder, but it is not completely reached it. So that indicates there is some obstruction here. It might be because of the stone which is present. Next slide. Here you can see a case of bladder stones alone. If here there are multiple stones, here there's going to be a single radiopaque shadow, which is a bladder stone. So for a bladder stone, the treatment is going to be vesicolithotomy if it's going to be a huge stone like this. But if a smaller stone, you can do a cystoscopy and you can try to remove the stone. Next slide. So in the plain X-ray abdomen, usually when you find calcifications, we think in terms of a stones in the kidney. But sometimes it might be a stone because of a gallbladder, but only 15% of the gallbladder stones are radio-opaque. But 85% of kidney stones are radio-opaque. But the best modality to diagnose a gallbladder stone is going to be an ultrasonogram. Whenever you take an ultrasonogram, you can see a shadowing. This shadowing is called as a post-acoustic shadowing because the sound waves comes and hits the stone and reflects back. So it tends to have a hyperechoic shadow in the stone, and there is going to be a radio-opaque black color thing beneath this, which is called as a post-acoustic shadowing. Next slide. So coming on to the T-tube cholangiogram. What is T-tube cholangiogram? We are trying to see whether the biliary tract is going to be normal after doing any hepatobiliary procedure. So what you tend to do is insert the T-tube into the bile duct and you inject some contrast on the table itself and you try to check up. This is done post-surgically. So when you're going to see, what happens is the contrast has to enter into the bile duct and it has to flow into the duodenum. When it flows into the duodenum, that indicates there is going to be no obstruction distally. You can remove the T-tube out. Okay. But intraoperatively, after putting this, when you're going to inject something or we can put in a infant feeding tube and you can palpate it on the duodenum itself and see whether it is within the duodenum or not. So this is about a normal T-tube cholangiogram. Next slide. So whenever you are going to have a stone which is going to be missed, so when you are going to inject the contrast, it enters here and the stone you can see as a radiopaque shadow, right? So there can be a missed stone even after a CBD exploration. So in those cases, you need to wait for the track to mature and you can do using a choledocoscope, you can try to retrieve these stones. Next slide. So this is the ERCP, which is done for stones which are going to be present in the CBD. When you're going to do an ERCP, you can see the stones which are seen, and this is called as a meniscus sign or inverted epithelial. This is called as a meniscus sign. Whenever you see a meniscus sign, you think of a proximal stones which is going to be present. So whenever you have a stones in the distal part or the terminal part of the CBD, you can do a sphincterotomy and using a Dormier basketing, you can retrieve all these stones. But if the stones are quite bigger enough, then you need to go for an open CBD exploration and retrieve the stones. Next slide. So here in this junction, we have done an ERCP, wherein you can see there is some amount of narrowing here, which indicates it is some growth which is present at that site, wherein there is a proximal dilated hepatobiliary radicals. Next slide. So this is a percutaneous transhepatic cholangiogram, wherein from externally a catheter is going to be introduced through a needle. First thing you have to introduce this. What is the name of this needle? It's called as a Chiba needle or a Okuda needle. Okay, using this Chiba needle, you introduce the needle into the intrahepatic biliary radicals, confirm that you are within the radicals. Then into this needle, you cannulate the catheter and remove the needle. And then you start injecting the contrast. So the contrast will flow into the biliary ductal system and you can see what is the level of obstruction. So whenever you have a higher level of obstruction, which cannot be approached through your ERCP, we go in through a percutaneous transhepatic cholangiogram earlier. But with the advent of your MRCP, your PTC has gone to the backstage. So generally, we don't follow these procedures nowadays for diagnostic modalities. Unless we are planning in for any percutaneous transhepatic biliary drainage, we do those procedures. Next slide. So this is a case of a fistulogram. Whenever you have a fistula in ano, through the anal opening, we inject contrast and see what is the level of fistula, whether it is a low anal fistula or a high anal fistula. Here you can see a horseshoe shaped fistula, wherein you have a curve which is. So usually in these kind of a horseshoe shaped fistula, the chances of missing out the fistula is there and recurrences are more common. But nowadays fistulogram is always diagnosed with a MR fistulogram rather than using this kind of a procedures. Next slide. So this is a pediatric X-ray wherein you can see a gas shadow one here and another gas shadow here. When you see these two kinds of a shadow, this is called as a double bubble appearance, which is most common for a duodenal atresia. Next slide. So this picture, you can see there are bubble loops which are going to be present within the chest wall. Usually you don't have bubble loops within the chest wall. When you find the bubble loops which are present within the chest wall, think it is going to be a case of a congenital diaphragmatic hernia. Next slide. So here is a picture of an X-ray. This patient has had a symptoms in the upper limb with a pain, shooting pain, other things. Whenever all X-ray images has to be correlated clinically. Here you can see a rib which is coming apart from the first rib. There's one more rib which is coming here. This rib is called as the cervical rib. So whenever you have a cervical rib, the problem is it can compress on the subclavian vessel and there could be a poststenotic dilatation. There could be a thrombus which can be dislodging. Sometimes there can be even a gangrene which can develop in the fingers. So these things has to be kept in your mind. And the diagnostic test for detecting a cervical rib would be Adson's test, hyperabduction maneuver. All those things can be tried to demonstrate whether the patient has got a cervical rib. Next thing. So this is an X-ray picture of a mammogram. The mammogram is generally taken in two views. One is a craniocaudal view, and this is a craniocaudal view, and this is a mediolateral oblique view. Whenever you take a mediolateral oblique view, you will be able to see the muscle also, the pectoral muscle also would be there. So whenever you have a dense breast, you will not be able to image any malignancy. Only if you have a fatty breast like this, wherever there is going to be any malignancy or any calcification, it will be better to visualize. So that is the reason you go for a. So that is the reason you go for a. Above 40 years, you go for a mammogram. Whereas when you are younger females, you go for an ultrasonogram to diagnose. Next slide. So this is a CT picture of a brain. So in this image, you can see there is an density which is present. This is a lenticular shaped image. When you see this lenticular shaped image, this is a diagnostic of an extradural hemorrhage. Any extradural hemorrhage, you have to take the patient immediately for surgery to evacuate the blood so that the patient doesn't go in for further complications. Next slide. So this is a picture of a subdural hematoma where you can see a crescentic mass. When you see a crescentic mass, you have this is diagnostic of a subdural hematoma. A subdural hematoma, unless a patient is going to be symptomatic, then you need to intervene immediately. Otherwise, some subdural hematomas can be managed conservatively. You can wait and watch whether it is going to be expanding or non-expanding. Whereas in an EDH, it has to be opened up immediately. EDH, usually remember, it appears like an idli. Right? Whereas this would be flat. Next slide. So this is the final slide about the angiography. In angiography, you do have 4 types of angiography. One is a conventional digital subtraction, CT, and an MR angiogram. In a conventional angiography, you do have the bony window along with it. So there will be having some difficulty in finding out this image. So when we do a digital subtraction angiography, all the bone window can be eliminated and that you'll be able to identify. In a CT, you can try to reconstruct and you can recreate what is the tumor and how far the displacement is present. So this is still more better. And an MR angiography is also better one. Next slide. So I have walked you through this, all these radiological X-rays. Hope it was enough for you. Thank you very much. Don't be in a hurry to identify the slides. So wait, read it, correlate clinically, and go ahead with the answer. Thank you. Next presentation is by Chandrasekhar. He would be running you through with all the instruments.
It's only the fast forward. So after that, as a chairman of Chennai City branch, I would like to thank each and every medical college of Chennai, Pondicherry, Vellore, so and Tanjavur, Kadalur, even from Kerala, there is a KIMS. Thanks to all. Slide. So I thank each and every medical college head of the department and students from all colleges. So this is the instrument from ASA Chennai City. Thanks to everyone. Next. So this is a classification. Basically, this is cutting and dissecting. Instrument basically classified into cutting, dissecting, grasping and holding, clamping. So it depends on the work, depends on the purpose, the instrument classification is there. There's some term in the instrument that is a traumatic. See, traumatic, atraumatic, dissection, dilatation, and grasping. Next. So there is a retraction instrument, sharp instrument, then trocar. Next. This is the method of sterilization is autoclaving, boiling, chemical sterilization, gas sterilization, and others. Next. This is the parts of instrument. See, there is a 2 finger bows for any holding the instrument. Then the pair of shaft or body of the instrument, catch or ratchet, that's a hold the instrument, and blades and joints. Next. There is a types of knife. There is a pediatric, there is a 13 size blade, 15 size blade, and 11 size blade for incisional drainage, 22 and 23 for adult, for major laparotomy. So handle, there is a 2 types of handle. One is 3 size, another is a 4 size. The name of the handle is what? BP handle. There is a bar path handle. Next, this is the scissor, Mayo scissor, the short and stout. So next, this is the Metsovam scissor for dissecting. Next, this is the cutting and this is suture removal scissor. There is a heat suture cutting or suture removal scissor. Next, this is the Lister sinus forceps. The sinus forceps used to drain the abscess. That is a Hilton's method of incisional drainage. That is a Lister sinus forceps. Next, this is a routine artery forceps of dissecting and open the tissue plane. There is a 3 types: mosquito, medium size, and large. Next. Next. So there is the lag is right angle forceps. So lag is right angle forceps to do the vascular surgeries and to hold the pedicle like thyroid, upper pedicle, or in the gallbladder surgery. That is a cholecystectomy for the leg at the septic duct, and also in the varicose vein to lift the veins. Next. So this is the Desjardins forceps in case of cholecystectomy. That is a removal of the stone from the CBD. So this is the Desjardins forceps. Next. This is the routine toothed forceps. Next. This is a non-toothed forceps. Otherwise, dissecting forceps or touch forceps. Next. This is the swab holding forceps. That is a swab holding. This is a first primary surgery. There is a preparation of the patients by using, there's a betadine. That is a povidone iodine preparation. That is the preparation of a patient. Some surgeries for adhesion release to use this BAP. That is a Ramley swab holding forceps. Next. This is a Babcock's forceps. This is air traumatic. This is surgery like appendicectomy to hold the tubal-like structure appendix, fallopian tube, and ureter. Next. Next. This is the Alice forceps. This is a sharp and tooth. So you used to hold the tough tissue like the skin, fascia, like that. Alice forceps. Next. This is the Jekyll's forceps to keep the instrument in sterile way. Next. This is the lens tissue forceps for lumpectomy in case of breast surgery, or sometimes to remove the stone from some particular. Next. This is the lung holding forceps. Next. This is a towel clip. There's a Doyen's towel clip. This is the cord clamp for hernia surgery for the lateral section of the cord structure. This is the cord clamp. Next. Next. This is a needle holder. The needle holder looks like a straight artery forceps. The only difference is having next. So the needle holder, there is a crisscross plate and is having some groove. So the screw only holds the needle. Next. This is a Jones thyroid retractor. Thyroid retractor to expose the thyroid, do the surgery comfortably. Next. So this is the Langenbach retractor. This is the Langenbach retractor for all the surgery like hernia, thyroid, all the cases. This is the single size plate. Next. Next. This is the Zenis retractor. Note the spelling C-Z-E. So Zenis retractor. This is the biflange hook in one side and another side, the right angle there in the another end. Next. This is a Dewas retractor in the major abdominal surgery and retract the liver. Next. This is the Morris retractor in the abdominal surgery. It retract the lower abdomen like a bladder also. Next. This is the Kelly's retractor in the major abdominal surgery like the APR. Is retract the whole abdomen in deep surgeries. Next. This is a rib retractor. Next. Next. So there is the abdominal retractor, Balfour's abdominal retractor. Next. So there is Doyen's occlusion clamp in intestinal surgery. Intestinal surgery for resection anastomosis. This is the occlusion clamp. Next. This is a Rayleigh tube. What is the length of Rayleigh tube? Length of the Rayleigh tube is 105. So 105. So use the Rayleigh tube is decompression. Pause the routine to see the Rayleigh tube. Next. This is a Foley's catheter. See the Foley's catheter. What is this? What is the full name of Foley's catheter? Self-retained Foley's catheter. Okay. So next. This is the Malikar's for SBC. Malikar's catheter. Next. So the T-tube. There's a curse T-tube for cholecystectomy. After the surgery, open the CBD exploration, you give the T-tube. Next. So it's the flattest tube. In case of abdominal distension, release the gas. Next. So this is normal, the skin stapler. Next. This is the proctoscope. There is the parts of the proctoscope. Next, previous. So there is the parts of the outer is the proctoscope sheath, and the inner is the obturator. So in the proctoscope for all annual examination. Next. Thank you all. Next. Next, Ilya. Okay, from Tamil Nadu chapter, thanks to all to our students of all medical college. Next. Thank you, team Chennai. And thank you all the professors. So, thank you, Dr. Kanavan sir. Please come up. Next program.
And before that, there is a photo section. One. Next, okay. From Tamil Nadu chapter, session of thanks to all students of all medical college. Next. Thank you, team, Chennai. And thank you all. Thank you, Dr. Kamaran sir. Please come on. Next program. And also, there is a photo section. One. Okay. From Tamil Nadu.
Good evening, all of you. So we are doing a final part of the quiz program. So I call all the finalists to come forward. Shukrit, she is here. Vaishnavi, yes. Krishna Priya, here. Then Shirish. What's his name? Shirish Senthil. Okay. Then Sujit Raj from Tanjavur Medical College. All these 4 candidates are from MMC. Sujit Raj from Tanjavur Medical College. Yes. Then Subhash from MMC. Sri Sai. Naga Anish from Stanley Medical College. Come forward, come forward. All the names I call, you just come forward. Then Sharat Kumar from MMC. Yes. Then Neelavadi from MMC. Yes. Vivek Reddy from MMC. Okay. Then Parthiban from Stanley. Come forward, please. Come forward. And Prerna Agarwal from Oman Durar. Where is she? Okay, okay. So, like yesterday, please, 4 of you in a row. So, leave 4 seats each, and then sit. 4 or 5, whatever. So 3 rows. 1, 2, 3, 4. 1, 2, 3, 4. No, don't carry any of your gadgets. Away, gadgets away. Keep your gadgets away. No phones. Ada. Inga 2, 3, 4. Sorry, 3, 4, 5. 3, 4, 5. So, three, 4, 5. Anyway, I'll announce the questions pattern because you need to understand the questions, how it's answered, the pattern of questions and how it is answered. There will be first we'll have a 15 fill-in blanks. We'll give you 25 minutes for 25 seconds each. 25 seconds each. First 15 questions. Next 10 questions will be multiple choice questions. So for that also you'll have 25 seconds each. And third pattern is based on case history. Case history, and you'll have 40 seconds. You'll have it's a question you have to answer within 40 seconds. And finally, you have a crossword. There are 12 words, and you'll be given a crossword sheet, and you'll have to fill in up. Yeah, you can observe. Okay. Yeah, we'll give her the final results too. will get the results. Okay, the participants, except the participants, all the others can get back if you want to stay. Okay, the participants, except the participants, all the others can get back.
Thanks to all
if
the
you want to stay.
officers of ASI and those who encourage our students from Tagore Medical College. I also thank our dean for allowing all the students to participate in this.
Okay, the participants, except the participants, all the others can get back.
Thanks to all
if
the
you want to stay.
officers of ASI and those who encourage our students from Tagore Medical College. I also thank our dean for allowing all the students to participate.
Okay, the participants. Now, first of all, you sit. Where is Sukrit? Where is Sukrit? Okay. Vaishnavi? Okay. Krishna Priya? Okay. Then Sujit. Sujit Raj from Tanjavur. Okay, fine. Then Subhash. Okay. Sri Sai Naga Hanish. Okay. Sharat Kumar. Okay. Neelavati. Fine. Mask எல்லாம் எடுத்துருங்கம்மா. மூஞ்ச பார்க்கணும். ID issues. Okay. Vivek Reddy. Yes. Then Parthiban. Okay. Parthiban from Stanley. Okay. Then Prerna Agarwal. So only 10 people are here, is it? 2 people have not appeared. Okay. Please now. One more person. You go behind. Move forward. I'm placing. I think the chances. Please come forward. No, you're not here. Please stay away. Please stay away. You come in front. No, not you. You stay. You be on the hold on. No, not you. Vaishnavi. You all go there. Go to the last place. Okay, 1, 2, 3, 4. 4 come in front. 9 members are there. 3 people are not come. Come in. Can you jump? Sir? Can you? Okay. So 1, 2, 3, 4, 5, 6, 7, 8, 9. Out of the 12 candidates, only 9 are appearing. Finalists. So as I told you, the first question is fill in the blanks. Yes. Fill in the blanks. It'll take you 25 seconds. Yes. So second round will be MCQs, regular MCQs. Third round will be case histories. You have to give the answer. And fourth round will be crosswords. The questions will be displayed and the answer sheets will be given to you each. Sharath, can give the answer sheets. The crossword okay? Sorry, she's my junior PG, so. Hey.
Try.
So first will be a blank paper. You have to number it and answer the question. Second will be a crossword. So you have to answer that separately. 10 members. So because yesterday we had some issues with the signal, we have decided to get the papers. Okay, we can start the questions. No comments in between. it automatically gets itself shut down after the fixed time. So make sure before that. Busy. I was expecting you for the session. Yes. Yes. First question to you. After the time, make sure. Second question. The final one. Now we'll have MCQs, next row. All these are from Bailey, nowhere else. We want to instill in your mind that Bailey is the book for final MBBS. You can have all the other books, but Bailey is the book. So 40 seconds for each question, 5 questions. For this question, the answer has been erased. So you can fill up with your own answer because it's the probable diagnosis. There is a controversy because of this question, we'll skip the question. Otherwise, you can answer. Now you have the crossword. You can flip on to the next page. Open your crossword. What happened? What happened, Sharath? Call that fellow, man. Where's the operator? No, the question has stopped. Where's that fellow? Why is he going out? First question, yes. As I said, everything is in Bailey. Thank you. Give your answer sheets. Collect the answer sheets. We'll give you the answer in 10 minutes. Yeah? We can discuss. We don't have time. We can discuss. Not a question. What a calculation. All these questions based on your syllabus, university syllabus books. There are 4 syllabus books. I don't know, if you do not know, I think you should know. That's Bailey and Love, theory. Clinical Science by Hamilton Bailey, which is a clinical book. And Farquharson's Operative Surgery. And of course, you have Das, Clinical Methods by Das. All these 4 books are referred for all these questions because we want to stress on the university best syllabus. So we'll give you the results within 10 minutes. Answers timely. Timely. We have the reference with the my questions Plan முதல்ல தெரிஞ்ச program fix பண்ணிருக்கலாம். We didn't know you were staying. வீட்ல வரவும் அவ்வளவு dangerous lecture.
From simple queries to streaming computation.